Good morning, friends. On behalf of MPSOS, I welcome you all for the midterm conference. As you all know, last one and a half year, almost 17 months now, we are fighting with a very deadly virus, very deadly situation. Not we in India, but it is across the world because of this COVID uh, 19 situations. First, we had a first wave, then there was little bit of relief time, then there is a second wave, then weaker mycosis and all, and still we are fighting with this thing. We, all the medical fraternity, not only ophthalmologists, but other fraternities, doctor colleagues also, they are fighting with this battle. During this battle, we have lost almost 1,000 medical personnel across the India, including few of our MPSOS member, Dr. Gurdeep Singh from Bhopal, Dr. Ravi Matia from Indore, Dr. R.K. Agrawal from Biawra, Dr. H.K. Verma from Vidisha. There are few names which they have left us to heavenly. To pay our homage from our society, before we start our proceeding, we request all of you to keep 1 minute silence to pay respect to their departed soul. Om Shanti. Friends, you'll agree that during this fight, not our member, but our resident doctors have also, they are also helping us, they are also contributing as a frontline warrior. They are our force which are there to manage all these COVID patients, our resident doctor. We as a MPSOS, we are planning to appreciate their contribution of our resident doctor who are working since last 16, 17 months in this COVID period, and we don't know how long they have to work more. So to appreciate their contribution, we from the MPSOS, we are planning to give them a certificate of appreciation during our annual conference in October 2021, which is scheduled to held at Riga. So now coming to this academic part, we we are trying, since there was no guide, there was no permission from the government, there is no guideline to organize a physical conference. We were trying to have this midterm conference as a physical one, but because there is no permission, we have to go for a virtual conference today. For today's conference, our scientific committee uh, headed by Dr. Vijay Nichlani, and our Gwalior Divisional Society local organizing committee with Dr. Rajiv Gupta as the president, Dr. Manav Sethi as organizing secretary. They have worked very hard to organize this today's session. The theme for this session is revisiting basics. So this session, this meeting, this conference has been targeted for general ophthalmologists and to our resident doctor. Before we go for our scientific session, I request Dr. Rajiv Gupta, the president of Gwalior Divisional Society and the president of local organizing committee, to give a welcome address. Dr. Rajiv Gupta, please. Sir, unmute yourself.
Thank you, Dr. Gajanbhai. Good morning, all. Let me begin with narrate a small incident. When we were studying in medical college and we were in the classroom, our professor gave us a case to see and to tell us the diagnosis of that case. After seeing that case, when we were discussing it, he told us that give us the argument in favor of the diagnosis. When we finished that, he in a very simple terminology, told us that I can put forward equal number of the arguments against the diagnosis. That was something very surprising to us, but that's again a science and fascinates us. And that's the beauty of science. And conference actually provides us the right environment to express, discuss your views with energy, passion, and in the end, you finish it after reaching on the conclusion with a smile. With this backdrop, I begin with I am Dr. Rajiv Gupta, President GDOS and Organizing Chairman of Midterm Conference Gwalior 2021. It's a great pleasure, it's a great privilege to be with you all today, this morning. And I warmly welcome President MPSOS Dr. Hitesh Agarwal, sir, Honorary General Secretary Dr. Gajen Chawla, Chairman Scientific Committee Dr. Vijay Nishlani, and other dignitaries of MPSOS. And on their behalf, I welcome distinguished guests, respected seniors, colleagues, and all others who are participating by joining us on this virtual platform. So I welcome you all. Our country is being ravaged by COVID-19 pandemic. This 1.5 years, as Dr. Chawla has again mentioned, this 1.5 years of the pandemic has been devastating to all of us. Many of our colleagues has lost their invaluable lives, and many have lost their near and dears too. Under these depressing scenario, scientific committee has actually asked us to organize the midterm conference. We were a bit hesitant initially, but when I talked to Dr. Nichlani sir, Dr. Gajenla, Dr. Gajen Chawla, they have actually encouraged us in many ways to organize the conference. Dr. Manav has given me the immense support to organize this conference. So I acknowledge the support extended to us by a great friend, Dr. Vijay Nishlani, Chairman Scientific Committee, and Dr. Gajen Bhai, our beloved secretary, and my really truly energetic and ever smiling secretary, Dr. Manav. Life is a journey, and pandemic has actually paused this journey. And in this scenario, never give up is the mool mantra. So what better idea is to overcome this depressing scenario and to again restart the journey and is to organize a conference, is to begin the journey with all the basics clear in our mind. So the today our conference theme is revisiting basics. And it's being organized on the virtual platform. This conference is being organized by MPSOS with Gwalior Divisional Ophthalmic Society. I have full confidence that all of us will definitely love the content and the speeches by our distinguished speaker, followed by discussion. We have divided the full day conference in 4 sessions. To begin with, starting with Retina, proceeded to organize, have the speeches on glaucoma, biometry, and lastly, the video session on cataract. I hope the youngsters will definitely going to enjoy it. Thank you so much, sir. Thank you very much. Have a nice day.
Thank you, Dr. Rajiv, for your kind word. And it was really nice to coordinate with you and Mano to organize this event. And really, it was, as you mentioned, it is a really time to come out from the all depressing situation what everyone is have faced in during, especially during the COVID wave 2. So now I'll request our President MPSOS, Dr. Hitesh Agarwal, to say a few words.
Thank you, Dr. Chawla. Dear office bearers of MPSOS, office bearers of LOC, and all my colleagues and members of the society, It gives me great pleasure to inaugurate the midterm conference organized at Gwalior by LOC. As you all know, this conference will be virtual, that is by video conferencing, due to still persisting COVID-19. Had it been physical, it would have been better and enjoyable, and we could have a chance to meet all and exchange our views personally. The midterm and annual conferences of MPSOS could not be organized last year also due to COVID. But I am happy to say that we have conducted about 10 or more video seminars, that is webinars, in which case presentations, surgical videos, and panel discussions on different topics such as cataract, glaucoma, phaco, retina, manual SICS, OPD in COVID, OT management in COVID, orbit and oculoplasty, and others were discussed. We have invited many guest speakers from all over India who are renowned national figures with great reputation like Dr. A.K. Grover, Dr. Rajiv Raman, Dr. Harbans Lal, Dr. Arup Chakravarti, Dr. Namrata Sharma, Dr. Jiten Jethani, and many others stalwarts. We have been privileged to have them with us. In these webinars, a great number of our members, especially young ophthalmologists, participated from each divisional society and presented their papers, research work, and shared new surgical techniques, which come handy in different times during surgery. We had a great panel discussion in each webinar. I appreciate the role of our senior ophthalmic members like Dr. Rajiv Chaudhary, Dr. Puren Basin, Dr. Arvind Dubey, Dr. U.P. Agrawal, Dr. Shreya Thatte, Dr. Bhagesh Pore, Dr. U.C. Tiwari, Dr. Alok Sen, Dr. Mahesh Somani, Dr. Salil Kumar, Dr. B.K. Jain, Dr. M.K. Ajwani, Dr. Rajendra Agrawal, Dr. Shweta Gupta, Dr. Pradeep Vyas, Dr. Kavita Kumar, Dr. Pankaj Chaudhary, and many others whose names I am not able to take due to time factor, who have taken keen interest in the webinars, guided the young ophthalmologists, and put their valuable experiences and suggestions. I am proud to say that our Chairman Scientific Committee, Dr. V.K. Nishlani, with his team, has made great efforts to arrange these webinars and conducted them very successfully. Our Secretary, Dr. Gajan Chawla, has also contributed a lot to organize them. Our past President, Dr. Parwani, past Secretary, Dr. Sandeep Chaurasia, present Vice President, Dr. Lalit Shrivastava, and Treasurer, Dr. Saroj Gupta, had also guided with their valuable suggestions in these webinars. I am happy to say that our each Divisional Ophthalmic Society has also conducted many webinars in this period, including on mucormycosis, which was a dreaded infection at that time. Treatment guidelines and medical aspects were discussed. Today, we are attending the midterm conference, which I am sure will again be very successful and will bring a lot of knowledge in the form of new papers and surgical skills. It will give a new platform for our senior and young ophthalmologists to interact amongst them, exchange their views, and give valuable suggestions and guidance to all the surgeons. Today, midterm will be on the theme Revisiting Basics in the form of 4 dedicated sessions on retina, glaucoma, biometry and IOL power calculation, and finally cataract. I thank the LOC Gwalior, especially Dr. Rajiv Gupta and Dr. Mano Setia for arranging this midterm. I hope and wish that in our 44th annual conference, which is the next conference and is due at Riva on 30th October 21, we will be able to attend it physically. Dr. Shashi Jain, Dr. Ankur Agrawal, Dr. Ilesh Jain, and Dr. Pankaj Chaudhary have already started making preparations for that. Now I wish all the speakers very best. I'm sure today's CME will be a great academic feast for all of us. Thank you, and with best wishes.
Thank you, President sir, for your kind words. Yes, I'm sure the situation will improve. Definitely, we will have a physical conference in October 2021. Yes, Dr. B.K. Jain sir, our patron, our forefather, our guiding force is there with us, and I'm sure he will help the local organizing committee of RIVA to organize this physically if government permits us. So with these words, we are going to end our inauguration program. Now I'll request Dr. Vijay Nichlani, Chairman Scientific Committee, to start the midterm conference.
Thank you, Dr. Gajen Chawla. Good morning to everyone, all delegates, our chairperson, panelists, and faculty speakers. So as it was already given the idea that how we come to this virtual platform for organizing this midterm, where the Gwalior Divisional Ophthalmic Society associated with us and helped us in organizing this virtual platform midterm conference. This was in the mind that what exactly would be the theme, so we decided to go with the basics. As many of general ophthalmologists and the PG members, they require more of the basic tips and more of the basic practical knowledge. So I, along with my team, Dr. Satish Premchandani, Dr. Parvez, and Dr. Shakya, decided and framed this kind of 4 sessions where we are going to discuss more of the practical tips and the basics of the topic that the faculty talks are going to be delivered. So one more protocol we observed that this midterm has to have for the MPSOS and for MPSOS and from MPSOS. So this time we have taken this care that none from the outside of MPSOS as a speaker has been invited. So it is all MPSOS family get together and the scientific piece that we are delivering. So coming to the first session, we thought we start from the back of the eye. So retina session is the first, where we have the galaxy of vitreoretinal surgeons as a chairperson and speaker. Dr. Parvani is the founder person in MPSOS. He's a medical retinologist. Dr. A.K. Dubey has been an office bearer of MPSOS at so many places in a different capacity. I admire his explaining the scientific content. Apart from the social content, he explains very good and very nice. Dr. Atul Mishra from Jabalpur, the senior vitreoretinal surgeon. Dr. Dhananjay Shukla from Gwalior. We have got Vivek Som, associate professor from Gandhi Medical College. Dr. Ashish Atle, an excellent vitreoretinal surgeon in private practice, Bhopal. Dr. Alok Sen, heading the retina in Chitrakoot Sadguru Netra Chikitsalaya, and Dr. Shavir Bindra from Bhopal as a medical vitreoretinal surgeon in a panelist team. To moderate this session, we have got eminent vitreoretinal surgeon from Bhopal, Dr. Gajen Chawla, who is a Shankar Netralaya fellow and has got experience of more than 30 years. So all to Dr. Gajen Chawla to moderate the session. Thank you.
Thank you, Dr. Vijay Nichlani. Now, with the permission of our chairperson, Dr. Dubey, Dr. Parvani sir, and others, should we start our session on retina? Understanding the retinal disorder always remains the challenge for the retina specialist. For a quite long time, the FFA was the only tool to diagnose retinal disease, and at that time the cryo first and then the laser was the only treatment. So our understanding for the disease were very limited, but in last 2 decades or so, there is a very fast technological advancement and a newer diagnostic tools are available in the form of, initially it was a time domain OCT. I remember when 2004-5 when I was working with Ajmani Hospital, we had a first time domain OCT of Bhopal. And then after that, the spectral domain and the newer OCTs are coming up, and then OCT NGO and so many technological advancement and the equipment we are having to diagnose and understand the retinal pathology. On the other hand, we do have a newer treatment modalities available with us in the form of intravitreal pharmacotherapy, and other things are also available with us. There are newer advancement in the laser technology also. So now we all retinal surgeon, we are having, with the help of this newer technology, newer equipment, we are having a better understanding of the disease, and we can treat the patient in a better way. But and nowadays the OFFA and OCT, they are the basic required or basic tool any retina specialist will have in his office or his chamber to treat the retina disorders. To understand these two basic tools, how their presenting feature, what is the feature one can understand, how they present in the different diseases. We have organized this session. We have designed this session so that our general ophthalmologist fellows, our the general ophthalmologist friend, as well as the resident could understand this both machines, both diagnostic tool in a better way. To explain the basics, to understand the this basic feature of these two diagnostic tools, we have a very experienced retina specialist from MP, as well as we are having a galaxy of the retina expert and the stalwart of retina from MP in our panel, and in our chairperson, they will discussing their view this coming session. So we'll start our basic of the first session, fundus angiography and various pattern in FFA. That will be taken by Dr. Rahul Chobe from Jabalpur. I request all the speaker to keep time allotted to you of 8 minutes. So be in time. At 6 minutes, there will be a buzzer from the, you will listen a buzzer, and at 7 minutes, just 1 minute before, we'll again give you a buzzer. So keep the time in mind. So Dr. Rahul Chobe, start your presentation now. Please share your screen and start your presentation. Dr. Rahul Chobe. Dr. Rahul Chobe is there? If Dr. Rahul Chobe is there or not? If he is not there, I'll request Dr. Pratik Mahajan to first take his talk. Dr. Pratik, you are ready? So, Dr. Pratik Mahajan from Indore will be talking on how to read a normal retinal OCT, various layer and their clinical relevance. Dr. Pratik Mahajan?
I think he's unable to listen to you. Yeah.
Dr. Pratik?
Yes.
Yes, please share. Yes, please go ahead.
Just wait.
Make slideshow and please.
Yeah.
Great.
So let's discuss about how to read an OCT, various layers and clinical significance. Well, if we see this picture, this shows the placement of various vasculature retinal cells in relation to the OCT picture in background. So here we see the arterioles, capillaries in the retina, the arteries, veins in the capillaries in the choroid space. Here we see the Muller cells, amacrine cell, horizontal cells. These are the photoreceptor cells. And so these are the various layers of the retina. We have traditionally studied 10 layers of the retina. But when we keep a OCT in front of us, actually we can appreciate nearly 19 to 20 layers, including the vitreous and the choroid. So this is the posterior vitreous, this is the preretinal cortex, then there's an internal limiting membrane, nerve fiber layer. Now these 4 layers, ganglion cell layer, inner plexiform layer, inner nuclear layer, outer plexiform layer. Now in condition when these all 4 layers get disorganized or lose their architecture, we call it as a drill. Then there's a Henle's fiber layer and outer nuclear layer. We see the outer segments of photoreceptors. Then we have the myoid zone and the ellipsoid zone. We have got the interdigitation zone. Then the RP Brooks membrane complex, choriocapillaries. the Sattler's layers, Haller's layer, and the choroidoscleral junction. So we have new understanding of three different areas. One is the vitreoretinal interface. We can appreciate various kinds of vitreous opacities and vitreous cells. We can appreciate the bursa perimacularis and the Broca's canal. Now we have new understanding about the ISOS junction also. Earlier we used to talk about the ISOS junction, but now we understand there's a myoid zone and an ellipsoid zone. So the myoid zone contains the Golgi apparatus and the ellipsoid zone contains the mitochondria, which helps for the energy production. We have a new understanding about the choroid. We can measure the choroidal thickness in various diseases. And this is a elevation or a inflection point in choroid because of the pull of the inferior oblique muscle in young patients. So how to read an OCT? We'll discuss about data and date, the scan quality, the overall profile of the retina, how to identify fovea, and then carry out structured assessment. Data and date, it's extremely important. For example, this is a OCT picture and you get on your WhatsApp and you need to read it. And you might advise, okay, it's a dry macula, and you will advise the patient requires no treatment. But you must understand, this OCT is a part of the treatment, because earlier the OCT picture was like this, and the patient was advised intraretinal injections, and because of your suggestion, now he missed his treatment, and finally again he developed a macular edema. So it's important that you assess all the details. A clinical picture, take your account a clinical picture while reading a OCT. Scan quality is important. As Chawla sir told, we have evolved from the time domain to spectral domain to the swept source OCT. We have more and more resolution now. We should, when we get a report, we should see whether there is a good signal to noise ratio. We should check for the artifacts like shadowing, but the vessel shadowing is a normal phenomenon. Sometimes even a low quality image is useful. For example, here we see a detached retina. On day one post-operatively, there's a dense cataract also, but still a low quality image show us that, okay, retina is nicely attached. We should appreciate the overall scan profile. A normal retina looks slightly concave with a foveal dip, and these are the vessel shadowing. But this is multiple serous detachments. The retina looks zigzag, and this is an exaggerated concavity in cases of high myopia. Now, overall scan profile, we should appreciate the RP detachment, retinal detachment, retinal thickening of various etiology like fractional, cystoid, and choroidal neovascular membrane. Now, one should be able to identify the fovea. That's very important. That the scan is it the scan passing through fovea? So the key is that you just see the nerve fiber layer and the outer plexiform layer, and the point at which these appear to meet is the dimple. It is actually the fovea. For example, this is a patient with choroidal rupture with a secondary choroidal neovascular membrane, and these are various scans. Now, if we see this scan here, the fovea is visible. So this scan is passing through the fovea. We should identify the foveal area. Now we carry out the structured assessment. We appreciate the hyporeflectile structures and the hyporeflective structures in the OCT. Normal hyperreflectile structures are the internal limiting membrane, RNFL, IPL, OPL, RP, choriocapillaris complex. The abnormal ones are the drusense, the PEDs, epiretinal membrane, choroidal neovascular membrane, scars, hard exudates, and hemorrhage. For example, this is a hemorrhage, and here we can appreciate that this is a pre-retinal hemorrhage, and this is the sub-ILM hemorrhage. Inner layer hyperreflectivity is a biomarker of ischemia, mostly seen in cases of artery occlusions. Again, these are hyperreflective dots which are seen in the OCT, and these are called as understood as imaging biomarkers of inflammation. Similarly, we should identify the hyperreflective structures, ganglion cell layer, inner nuclear layer, and outer nuclear layer. The abnormal hyperreflectivity is like intraretinal fluids and the subretinal fluid. Now, this picture shows the retinoschisis cavity again, which is a hyperreflective. Here we see the inner retinoschisis. This is the outer retinoschisis, and this is the area of retinal detachment. We appreciate the alteration of layers like as irregularity, fragmentation of layer, rupture, interruption, depression, elevation, thinning, and thickening. So this shows a wrinkling of internal limiting membrane, and this shows a bumpy RP due to drusen. Again, this is a reduplication of retinal pigment epithelium suggestive of choroidal neovascular membrane. So take-home messages: we should identify all structures systemically, starting from pre-retinal, the epiretinal, intraretinal, subretinal, and the sub-RP layer. A word about the drill, the disorganization of inner retinal layer. These 4 inner retinal layers, when they lose their architecture, their separation, they appear, we call it as a drill. For example, this picture shows a diabetic macula with severe drill. And sometimes now when we talk about the outer retina, there's a condition called ORT, outer retinal tubulations. Now these appear as a circumscribed hyporeflective spaces bordered by a hyperreflective layer. So these are basically circular arrangement of photoreceptors in response to the injury to the RP, like in cases of age-related macular degeneration. So thank you so much for your kind attention. Sitting in front of a OCT is like sitting on a beach when waves of knowledge are continuously coming and you feel more and more excited. Thank you so much.
Thank you, Dr. Pratik, for nice presentation, very nice elaboration of different layer. And I must appreciate the quality of OCT. Especially, I like that retinoschisis and retinal detachment. It was a very wonderful image. We'll be discussing all these topics in the last of all presentation. So now I'll call Dr. Rahul Chobe if he's available with us.
Yes, sir. Yes, sir.
So Rahul Chobe, please share your screen, and you'll be talking on the fundus, fluorescein angiography, and various patterns in FFA. Dr. Rahul, please.
Very good morning to everyone. What we are talking about today is about fluorescein angiography, though it's an age-old tool that everyone has. I'm Dr. Rahul Chobe from Jabalpur. To start the angiography, basically angiograph is in vivo study of the retinal circulation. And the basic principle that we are encountering is luminescence, that is emission of light by the excitation of atoms. And the fluorescence is luminescence that is maintained by continuous excitation. So what we do here, we use a shorter wavelength light, excite the electrons from the ground to excited state. And while coming back from the excited to the ground state, the electrons emit a light that is of a higher wavelength, but of a lower power, according to Stokes' law. What are the phases of the normal angiogram? You have an arm to retina time, that's around 10 to 15 seconds. You have a retinal circulation time, that is around 15 to 20 seconds. In the phases of the angiogram, you have pre-arterial phase, arterial, arteriovenous transit, recirculation phase, and a late fluorescent transit. If you see the first picture, this is a choroidal phase, where you can see a choroidal flush, but the retinal and arteries and the veins are completely empty. When you have a cilioretinal artery, it fills with the choroidal phase, but the rest of the retinal vessels are still empty. In the arterial phase that comes around 1 second after the choroidal flush, you will see the filling of the retinal artery. In arteriovenous phase, you have the filling of the arteries. In the veins, you will have an early lamellar flow with the lateral walls have dye staining. In the venous phase, you will have arteries, veins, and the capillaries being filled, and marked lamellar venous flow can be seen. In late phases, which is of most concern, occurs after 10 to 15 minutes of the dye, because most of the dye is completely out of the blood circulation. And then you can see the leakages, stainings, accumulation, pooling, everything. If you see this pictogram, from A to D, there is progressive hyperfluorescence, and in late stages in D class, you have a staining. Why the fovea is dark? Because of the foveal avascular zone, high amount of xanthophyll, and the RP cells have more melanin and lipofuscin. This is the foveal avascular zone that we talk about. Then how you analyze an angiogram? Do a sequential frame-by-frame analysis. Look for the anatomical analysis from choroid, RP, and neurosensory retina. Do a morphological analysis of the pattern. What you are seeing is a hyperfluorescent one or a hypofluorescent one. While reporting, start with any striking abnormality and describe this in detail. which phase of the angiogram you saw it, whether the component was a hypo or hyperfluorescent. C, for the intensity of fluorescence, does it change by time? And the area of concern, does it change by time or not? The common abnormalities that we encounter are the timing. It is increased when you have a low cardiac output or a carotid perfusion defect. The abnormal dye distribution could be an hypo or a hyper one. When we talk about FFA interpretation, when you have a hypofluorescence, it could be a blocked or a non-filling one. In a hyperfluorescence, you can have a leakage, pooling, staining, and a window defect. If you see this pictogram, you have a pre-retinal hemorrhage, and it is causing hyperfluorescence of the choroid and the retinal vessel beneath it. This is also a case of a diabetic retinopathy. You have multiple pre-retinal hemorrhages causing blocked fluorescence of the choroid and the retinal vessels. If you talk about this pictogram, there is a subretinal hemorrhage that is causing the choroidal flush as a blocked fluorescence of the choroidal flush, but the rest of the retinal vessels are totally normal. There could be a filling defect also. As seen in this diabetic retinopathy case, you can have multiple retinal areas, also known as capillary non-perfusion areas, are being labeled as a silent area. The causes of the hyperfluorescence could be due to neosensory retina, as seen in the case of cystoid macular edema. It could be from the choroidal neovascularization from the new vessels. Staining is a classical feature of the dry RMB with drusense that is seen in the very late phases. You can also have a window defect because of loss of neosensory retina over the fovea that is labeled as a hyperfluorescent well-demarcated area. You can also have a leakage of the dye. The leakage increases in the sequential pictograms, but the margins of the leakage are fuzzy. When you have a pooling, from the start of the pictogram, you will have hyperfluorescence, but it won't increase in the size, and the margins will be well marked. In case of cystoid macular edema, you can have a sequential hyperstaining, hyperfluorescence area from the early to the late stages. You can see a multiple cystoid space, but the peripheral marks area will be not well demarcated. When you have a staining, as seen in a choroidal neovascularization scar, you will have a hyperstaining and very well marked and very well delineated areas that are typically seen 10 to 15 minutes after the pictogram taken. The leakage from the abnormal vessels could be from the choroidals or from the retinal new vessels. Typically can also be seen in cases of tumors of the choroids. What is autofluorescence? When we talk about autofluorescence, it is when the pre-ejection phase, you have a fluorescence body. It is typically seen in optic nerve drusense or in astrocytic cytomas. Some of the FFA patterns of some common diseases, if we see this diabetic retinopathy case, you have a pre-retinal hemorrhage in one that is giving a blocked fluorescence appearance. In the number 2, labeled as 2, you have retinal ischemic area, also labeled as CNP areas. In 3, you have microaneurysms that are seen as a hyperfluorescent bubble dots appearance. You can have an NVE as seen in labeled as 4. You can have IRMA, and you can also have a venous bleeding that's typically seen in labeled as 6. In ARMD cases, though FFA is not of very good help because you won't be able to find the typical point of leakage because FFA does not give you an in-depth analysis of the choroid, but still the classical picture of hyperstaining is seen when you have a scarred out CNVM. In occult CNVM, though in a sequential pictogram, you will see a progressive fluorescence, hyperfluorescence, but you won't be able to find the pinpoint focal point of leakage. In BRVO cases, you will see multiple blocked fluorescence, hyperstaining of the vessels, and a partial leakage. Though in this picture, you don't have any NVE. In CRVO, you will see a multiple blocked fluorescence and hyperstaining of veins. In a CRO case, the arteries delay by more than 5 seconds after the retina arteries are filled more than 5 seconds after a choroidal flush. So the arteries are still empty and the choroid is blooming and giving a good choroidal flush. If you see a case of a BRO, the upper quadrant in this pictogram is totally normal and the vessels are normally filled. but the inferior quadrant is silent. If you see the case of a CSR, you can see multiple ink blot leakages or a smokestack appearance.
Dr. Rahul, please wind up.
In a case of Lees disease, you will see staining of the vessels, multiple CNP areas. You can also see hyper-staining of the disc. In choroiditis, you will see multiple hypofluorescent patches with peripheral hyperfluorescent borders. So there are limitations of FFA. It does not permit the study of choroidal circulation. There are chances of more adverse side effects than ICG. It is inability to do a good angiogram in case of excess hemoglobin or serum protein. Thank you, MPSOS and GDOS, for giving me this opportunity. Thank you.
Thank you, Dr. Rahul, for nice presentations. You have covered from basic to the some of the clinical picture. It was a wonderful presentation. I'm very happy you have mentioned two specific points. One was looking for the autofluorescence, which we should take pre-injection time, pre-injection photograph, and while analyzing, we have to do a sequential analysis reading of the frame to frame. These 2 points really you have covered well. We'll be discussing more in the end of the session. Now now we are coming to the clinical scenario, the OCT and FFA in different situations. So first we'd like to call upon Dr. Amit Srivastava from Bhopal, who will be talking about OCT and FFA in CSR. Dr. Amit, please. Dr. Amit Srivastava? Dr. Amit, I'm not able to hear you.
Yes, Dr. Amit, please go ahead. Your slide is on screen.
Okay, sir.
Carry on.
Thank you. Okay. Good morning, everybody. Today, topic of my presentation is role of fundus fluorescein angiography and OCT in central serous chorioretinopathy. The incidence of CSR is recently on a rise because of increased use of steroid in management of COVID cases. And typically, acute CSR presents as blister-like elevation of neurosensory retina over the posterior pole. Before undergoing into the detail of these investigations, understanding of pathophysiology of CSR is must. There is diffuse hyperpermeability of the choroidal vessel, which causes leakage of fluid to collect below the retinal pigment epithelium. Over time, there is development of RPE leak, from which fluid leaks into the subretinal space, leading to localized neurosensory detachment. Now, coming to the first investigation, it is fundus fluorescein angiography. It is the first investigation to be used in patients with CSR. Nowadays, it is not done on the first visit in acute CSR cases. We require this in some cases where the diagnosis is not sure, such as those associated with membrane over the posterior pole. In some cases where there is exudative detachment and diffuse RPE changes. Also, when the diagnosis is not sure, like in cases with CNVM or VKH, we want to confirm the diagnosis. Second indication is in chronic CSR when we have to find the leaks before laser or PDT. And third is to detect complications like choroidal neovascularization membrane. Now, what are the phases of angiography in a case of acute CSR? Typically, there is a point-like hyperfluorescence which appears in the early AV phase, which corresponds to the RPE leak of the fluorescent dye into the subretinal space. With progression of these phases, their leakage continues into the subretinal space and it increases in both size and intensity. Depending upon the pattern, we may found ink clot pattern, smoke pattern, and sometimes there is no definite leak. Now, this is the first type of pattern. In this angiogram, we'll find a leak starting at the posterior pole. There are 2 or 3 leaks superior to the fovea. Gradually, there is increase in the size and intensity of this leak, while the other leaks remain same. So this is ink blot pattern associated with few isolated PEDs. Second is the smokestack, in which there is a pinpoint hyperfluorescence, which starts and then ascends up to take a mushroom-like appearance in the later stages. Now, once the CSR becomes chronic, it loses its single pinpoint appearance and there is diffuse RPE defect leading to multiple early hyperfluorescent spots, which increases in size and intensity in the later stage. Still, chronic CSR are associated with diffuse RPE pigmentary changes leading to window defect. Here again, we can find an active leakage in chronic CSR along with the tract sign. There is an entity known as multifocal CSR, which is seen in patients taking steroids and sometime in pregnancy, in which in acute CSR, there are multiple points of hyperfluorescence in the early phase, which increases in the later stages. In bullous CSR, again, angiography helps in confirming the diagnosis. We find ink blot pattern of hyperfluorescence here and few pattern here, along with block fluorescence because of leakage of fibrin. Again, in CSR with CNVM, complicated with CNVM, angiography helps in confirmation of the diagnosis by late leakage in the later phases. Now, second investigation is the optical coherence tomography. It is now the first line of investigation, and if possible, it should be done on the first visit. It can even diagnose subtle amount of subretinal fluid, and most important, it quantifies the detachment, and it helps in both progression and resolution. We can monitor both the conditions. Now, as Dr. Pratik has shown, these are the different layers of the retina. In CSR, there is elevation of the ellipsoid zone from the underlying RP Brooks membrane with a clear hyporeflective zone in between. This is the case of acute CSR. More than 50% time, this is associated with elevation of the pigment epithelium with a hyporeflective zone inside this. This is serous PED associated with acute CSR. Now, as the CSR starts getting chronic, there are deposition of hyperreflective dot below this ellipsoid zone. This is because of shedding of the photoreceptor segments. And also there is elongation of the photoreceptor zone in chronic CSR. Still, if the CSR doesn't resolve, it is associated with some amount of subretinal fluid, along with diffuse RP irregularity, loss of ellipsoid zone and external limiting membrane, and a thinning of the inner retinal layers. And recently, a sign known as double layer sign has been shown to be correlated with CSR. Here, there is a thin, wavy RPE line, which is elevated from the underlying Brooks membrane, with a clear hyporeflective zone in between. In cases with chronic CSR, this is known as hyporeflective DLS sign. If CSR persists for maybe 2 years or more, then it develops fluid in the inner retinal layer known as cystoid macular edema. Now, recent advances like enhanced depth imaging have shown that this disease is associated with the pachychoroid spectrum of disease with dilated outer choroidal vessels associated with collection of subretinal fluid in the subretinal space. We can also utilize three-dimensional cross-sectional study using B scan and C scan, which I will be telling later on. Now, this is the first case in which patient presented with acute CSR fluid in the subretinal space. At baseline, 2-month follow-up showed decrease in the subretinal fluid. 3 months, there was complete resolution of subretinal fluid. Again, patient presented with diminution of vision and OCT showed some subretinal fluid present. Patient was started on epinephrine. And 2 months after start of medication, the fluid disappeared and the fovea remained dry even after a year. Now, if we utilize this transverse C scan to the level of PED, we can see there are few PEDs. This is a larger PED with a micro rib, and this area is the subretinal fluid. Okay, no problem. Then on follow-up, there was decrease in the size of the PED and resolution of the subretinal fluid has disappeared. Now, case 2, in which there was persistent subretinal fluid, then angiography was done, which showed leaking pinpoint fluorescence, which increases in size. Laser was done, and 1 month after laser, there was decrease in subretinal fluid. Now, come to the differential. First is the PCV, which, if not associated with hemorrhage, may mimic CSR. Here, elevated double layer sign, which is presence of separation of the inner RP from the Brooks membrane and the hyporeflective zone. It is more common in patient with PCV and PCN, and almost exclusive if it is hyperreflective DLS sign. And it is also associated with notched PED. Second is VKH, in which there is a fluid. Yes, sir. Even OCT shows subretinal fluid at the posterior pole, and we do angiography, show mottled hyperfluorescence over the posterior pole. Patient is started on a steroid. This is contrary to the CSR, where we don't have steroid, and after 5 days, there is complete resolution of subretinal fluid. Now, to conclude, FFA is must in all non-resolving cases, and it confirms the diagnosis in atypical presentation. OCT is now the first line, and it should be done on the first visit, and it monitors the progression of the CSR. Thank you.
Thank you, Dr. Amit, for nice presentation. You have covered subject very well. You have shown different patterns and different presenting features, the pattern, the way the CSR can be seen on FFA and OCT. It was a very nice presentation. We'll be discussing more on this in the latter part. Now I invite our next speaker, Dr. Rajendra Bisen from Jabalpur. He will be talking on OCT and FFA in vascular occlusions. Dr. Bisen, Rajendra Bisen, please.
Good morning, sir. Thank you. Am I audible?
Yes, please. You're loud and clear. Yes. You're visible also. Your slides are visible. Please go ahead.
Yeah. Good morning, everyone. My topic for today is role of OCT and angiography in vascular occlusion. Basically, OCT provides very high quality images, structural detail, whereas angiography provides as a retinal circulation. So both are complementary to each other, and sometimes both are needed for diagnosing and managing the venous occlusion and retinal artery occlusion. So first, I'll discuss about venous occlusion, role of OCT. OCT has now become indispensable tool for diagnosing the macular edema in case of the venous occlusion, and it is the single most tool by which we can assess. We can quantify our macular edema, we can see a therapeutic effect of our drug therapy. And it is proven by the studies that OCT has a better or higher detection rate as compared to the angiography. So how this macular edema looks like on OCT? So there are two patterns seen commonly. One is the cystoid and another is the serous retinal detachment. So in the cystoid edema, there is a accumulation of fluid in the outer plexiform and inner nuclear layer. These fluid accumulated between the molar cells, and because of the stretching of these molar cells, there is a initially cone-shaped serous detachment below the fovea, which later on leads to a dome-shaped detachment. So thanks to OCT, that now most of the macular edema associated, more than 80% of the macular edema is associated with this. Then coming to the BRVO, in BRVO, macular edema is slightly differ from CRVO, like more macular edema will seen on the affected area or non-perfused area, like here picture showing that superior area, vertical B scan showing there is superior area is showing more macular edema. Now coming to the like by the OCT picture, we can prognosticate our edema. Like here we can see there is cystoid spaces that reached external limiting membrane, and there is damage in the ISOS line, and there is thinning of the photoreceptor and inner outer segment. So this overall gives a poor prognostic sign to the therapeutic options. Now coming to the angiography, in BRVO, if we see in this stage, angiography shows the blocked fluorescence, and along with there is a patelloid leakage of the cystoid macular edema. But basically indication of angiography in case of the BRVO, so when very long standing BRVO, like here we can see there is inferior BRVO with the sclerosed vessel. So if we do an angiogram, corresponding angiogram showing there is hypoperfusion background fluorescence, which shows the capillary non-perfusion area, along with there is macular non-perfusion. So this is the case where we required grid laser photocoagulation. Another findings in angiogram in BRVO, like neovascularization elsewhere and neovascularization over the disc. In this condition, we required sectoral laser photocoagulation. Another condition, very important, to look for the collaterals. So sometimes we get confused with the neovascularization. So angiogram better delineates the collaterals. They never leak, but the new vessels, they leak. Now coming to the CRVO, angiogram in CRVO, in acute stage, we don't do the FFA. FFA should be done after resolution of these hemorrhages. So basically to classify CRVO, we are doing angiography. So in case of non-ischemic CRVO, there will be a blocked fluorescence. There will be no or less than 10 disc diameter of CNP area. But in case of ischemic CRVO, you see more than 10 disc diameter of hypofluorescent background CNP areas, along with there is enlargement of the foveal avascular zone. So this categorized like we are dealing with the non-ischemic CRVO, which will be a prognosis will be poor. Now, in chronic CRVO, you will find that there is presence of neoescalation elsewhere, there is presence of neoescalation over the disc, and there iris neoescalation is very common with CRVO. So we need a photocoagulation in such cases. Now coming to the CRAO, the fundus findings are quite diagnostic in CRAO because, in which there is loss of transparency and of the retinal layers, and retinal layers showing yellowish white except the fovea, which is cherry red. So angiography is usually not required, but if we see the findings of the angiography, there will be a masking of the background fluorescein, there is delayed filling of the retinal artery, but these findings are very transient. Sometimes if you do after 1 week or 2 week angiogram, you will see a normal angiogram because of this recanalization and reperfusion of the retinal artery. So this should be kept in mind. OCT is quite informative in case of CRAO. The inner layers of the retina get hyperreflective from retinal nerve fiber layer to inner nuclear layer, and hyporeflectivity of the outer retina, outer plexiform layer and photoreceptor layer. If we do OCT in a 2 months later CRAO case, we can see that there is lot of significant thinning of inner retinal layer, and there is loss of foveal depression. Then coming to the BRVO, as picture fundus photo or fundus findings are quite diagnostic. You can see the affected and non-affected area. Angiogram is also showing there is masking of the background fluorescent, delayed arterial filling. If we do a vertical B scan OCT, then OCT is showing hyperreflectivity of inner retinal layer and hyporeflectivity of the photoreceptor and outer retinal layer. Another condition is a CRAO along with ciliaretinal artery sparing, in which fundus photo showing there is area which is supplied by ciliaretinal artery is quite perfused, and the ischemic area is showing whitish or yellowish, and the corresponding angiogram at 26 seconds showing there is ciliaretinal artery circulation along with the choroidal circulation and the venous filling, whereas the central retinal artery has not filled. OCT, the corresponding ischemic area or affected area is showing hyperreflectivity of the inner retinal layer and hyporeflectivity of the outer retinal layer, and the area which is supplied by ciliaretinal artery showing a normal OCT. So concluding here, OCT is diagnostic for macular edema and venous occlusion. Angiography for macular edema is not needed, but angiography reveals the perfusion status of the venous occlusion, so it is required for managing the venous occlusions. Fundus findings are quite diagnostic in case of retinal artery occlusion. OCT and angiography are ancillary tests for retinal artery occlusion. Thank you very much.
Thank you, Dr. Hussain, for a very nice presentation and compiling all the vascular occlusion in such a short time. It was really a challenging job, and you really justified that. I agree with that. Both tools are procedures are complementary to each other, although the uses of FFA is decreasing nowadays, but still it is required. So we are coming to our next talk by Dr. Mano Sethia. He will be speaking on OCT and FFA in diabetic maculopathy. Dr. Mano, please. Dr. Sethia, I can't hear you. Hello.
Carry on, Dr. Mano.
Yeah, thank you for the opportunity. Am I audible, sir?
Yes.
I'm talking about an important topic of OCT and angiography in diabetic maculopathy. It's not moving. Some problem, sir. Some technical issue, it's not moving. Yes. So, in brief, OCT, we all know and understand, gives us the architectural, cellular, and optical biopsy. Now, since we all, your diagnosis of diabetic macular edema will depend upon the technology of OCT that we are using. Most of us are using spectral domain OCT. For better resolutions, SWEP source plays a vital role, but I'll stick to the SWEP the spectral domain OCT. Why? Because the central foveal thickness will vary upon the OCT machine that you're using. If it's stratus, it's less than 250 microns, and if it is spectralis with you, then it is more than 320 microns, the normal. So how do you quantify DME or diabetic macular edema on OCT? Well, it is the central subfield thickness on Zeiss OCT of more than 290 microns for women and 305 microns for men on spectral domain OCT, and 320 microns if you are using a spectralis OCT. DRCR.network has given us a beautiful description about the central involving and non-central involving diabetic macular edema. This is a picture of a central involving, and this is non-central involving diabetic macular edema. Well, central involving diabetic macular edema is defined as central subfoveal thickness of more than 250 microns or edema on clinical examination within 500 microns of the center of the macula, or edema of more than 1 disc area and within 1 disc area of the center of the macula is defined as central involving diabetic macular edema. This picture has already been described by Dr. Pratik in his presentation. Beautifully described myoid zone, ellipsoid zone, and the interdigitation zone. Qualitative OCT interpretation is necessary for the postgraduates to understand the hypo and the hyperreflectile areas. Hyporeflective are the inner nucleus and the outer nuclear layer and the fluid. So what role does OCT has in diabetic retinopathy? Well, it helps us to evaluate unexplained visual loss, identify area of vitreomacular traction, and also to evaluate patients with difficult or questionable examination for diabetic macular edema. Roles of OCT are broadly into quantification, estimation of macular volume, classifying the macular edema, and defining the vitreoretinal relationship. Both quantitative and qualitative response to treatment is also very well beautifully described on OCT. I'll brief you through the patterns that we've already well versed with. One is the spongy thickening here. Then you have the cystoid macular edema. You have the sensory macular detachment with subsensory fluid and a taut posterior hyaloid face on the OCT. This is a beautiful picture of an OCT describing the pearl necklace sign. As you can see, the hyperreflectile dots inside. Why this is important? Because it carries a guarded visual prognosis for surgery. Taking you brief through cases of OCT and angiogram. This was a case of a type 2 diabetic since last 14 years, showing few microaneurysm here. When we run the OCT, we see central involving diabetic macular edema. Case 2 is a type 2 diabetic 55-year-old female since 14 years, uncontrolled diabetic with glycosylate hemoglobin of 9.6. Her vision actually was 6.6 in both the eyes, but you can see central involving diabetic macular edema in the OCT and few hemorrhages and hard exudates in the fundus picture. Case 3 is a type 2 diabetic since last 20 years, hypertensive since last 14 years. A patient with nephropathy who was on dialysis came to us with metamorphsia. And when we run the OCT, we see a vitreofoveal traction. Patient had severe metamorphsia, but we waited for this foveal traction to relieve off. But since after 1 month again, when he came back and his metamorphsia had persisted, he was taken up for surgery, and you can see beautiful resolution of the and normalization of the foveal contours post-surgery. Case 4 is a 52-year-old diabetic for 5 years on hypoglycemic agents. Visual acuity was 20/80 in right eye, and you can see a broad-based vitreomacular traction in both the eyes. Case 5 is a type 2 diabetic since last 15 years, hypertensive also, and and when we run the OCT, we see a edema on both the eyes, central involving cystoid edema, and post-injection, you can see beautiful resolution. Case 6 is a type 2 diabetic since last 14 years. This is another way to monitor your progression by automated values and using color coding. As you can see, the color coding has, and this dark color red has gone off. We know and understand that injection or intraretinal injection is not a one-time job. This is the case of a diabetic macular edema followed up for more than 8 years on OCT. And you can see beautiful resolution after 8 years. And the patient is now stabilized. So OCT is required for follow-ups. Also, understanding the response to various intravitreal anti-VEGF which are present today or maybe will be present in times to come. You can see beautiful resolution of in-width accentrics. When there are poor responders to anti-VEGF, you use intravitreal steroids. And also you can monitor the progression or the resolution of the edema on dexamethasone. As you can see, the implant was injected and this vitreofoveal traction was relieved also with this. So you can measure all this. OCT biomarkers play a very vital role in protocol T, rise and ride. What are they? What is it? It is the presence of subretinal fluid, mild foveal thickening, large anatomical response to and poor response to large intraretinal cystoid spaces. Now, there are qualitative biomarkers, has been described by Dr. Pratik, which is the drill most important one. The interretinal hyperreflective dots, intracystic hyperreflective material, ellipsoid zone disruption, and the ELM integrity. I'll brief about a few of them. Hyperreflective dots are well circumscribed areas. You can see few of them. They are associated with pro-inflammatory mediators. Drill has been beautifully described earlier by Dr. Pratik on his MPSOS. This is present. There is presence of drill here, and there is absence of drill here. You can see the inner layers being not disrupted. ISOS junction integrity in diabetic macular edema. Now you can see the ISOS junction is regular and continuous, whereas it is partially broken, the ISOS junction in diabetic macular edema. And in this picture, there is complete discontinuity of the IOS layer between the arrows. So OCT bypass, clear cyst versus cloudy cyst, there is no difference in the outcomes. Well, does angiography still has a role? Yes, it definitely has a very important role to play in diagnosing and laser treatment for cystoid macular edema, and to explain to evaluate unexplained visual loss, and also to identify suspected but clinical obscure retinal neovascularization. This is the beautiful picture of on a spectralis taken of an angiogram. You can see the early, middle, and late phases of a diabetic macular edema, mild to moderate NPDR, which you can see hemorrhages filling, and in the late phases showing already the CNP areas here. So angiography helps us to, because in identifying retinal microcirculation, identifies areas of leakage, and also shows macular ischemia with increased foveal avascular zone and areas of non-perfusion. I'll brief you a few cases. Case 1 is type 2 diabetic since last 22 years. Left eye had traction retinal detachment. Right eye, you can see X-rays here. And we suspected a neovascularization, and we did an angiogram. We found out NVE. And so FFA helps classifying and confirms the type of PDR that we are dealing with. And this thus helps us to decide on the urgency of laser treatment and the macular status. As you can see, the CNP areas and the foveal avascular zone is disrupted. Also, it helps us to confirm a regression of the NVE post-laser. Why? Because 1/3 of these lasered PDRs will not even regress beyond the lasers that you've done. And also helps us to differentiate between intraretinal microvascular abnormalities and the NVE, which are seen in the late phases of the angiogram. I did an angiogram to find out vision. So we found out a large area of CNP areas, and the patient was taken up for laser. Beautifully described NBD digression on angiogram is the shriveled appearance of the old vessels here, and in the middle, you can see a nicely backlit by small amount of fluorescein that does leak. Whereas if you compare with the right picture here, you see florid leakage seen with new and active vessels.
Please conclude.
Yeah, sir. Just finishing. Diabetic papillopathy, last slide, sir. Diabetic papillopathy is an important feature, and we can miss it. And angiogram helps us to identify this entity. When patient will have a very good vision, you might suspect of an optic neuritis here. And how do we do that? Is you help us by seeing a nerve fiber layer hemorrhages, and the early phase of an angiogram showed typical dilated vessels, as you can be seen, and the late phase is showing staining within the substance of the nerve. This is a differential diagnosis of a cystoid macular edema here. Response to steroids can be seen on the OCT, and the patient was diabetic since last 20 years. So to conclude, well, the take home is that OCT is a non-invasive, quick, and reproducible investigation that has revolutionized the image of posterior segment lesions. Correlation of individual layers involved on OCT with histopathology has brought us much more closer to an accurate diagnosis than ever before. Various combinations of finding on OCT and comparison with the known OCT biomarkers have made disease identification and prognostication simpler. High contrast angiography, high contrast detail of retinal circulation identifies the area of leakage and microorganisms, and also shows us macular ischemia and the area of non-perfusion. Thank you for your patient hearing.
Thank you, Dr. Mano, for a nice presentation covering all aspects of diabetic maculopathy role of OCT. Yes, I agree with that. With the help of OCT, since we are having this nowadays in our all practice, it is we are very comfortable to monitor our treatment, how it is improving, not improving. So it is really wonderful tool, non-invasive tool. So yes, it is really we are having very comfortable time to explain everything to the patient. Although the role of FFS is still there in diabetic macular edema to see the non-partisan area at ischemic maculopathy and non-partisan areas. So we'll discuss a little more later. And now we'll call upon Dr. Ram Kumar from Indore, who will be talking on OCT and FFA in ARMD. Dr. Ram Kumar, please share your screen. Yeah, Mano, you share. Dr. Ram Kumar. Dr. Manu, please de-share your screen.
I have already.
Yeah. So, Dr. Ramkumar, yes, your screen is visible, but your voice is not there, Dr. Ramkumar.
Yes, sir. Am I audible now?
Yes, please.
Yes,
Go ahead. Go ahead, all yours.
Yes, sir. Sorry. Okay. Good morning, everyone. I thank MPSOS Chairman Scientific Committee for giving me this opportunity. Sir, I am asked to present on FFA and OCT in age-related macular degeneration. The classical description being dry AMD and wet AMD, the non-exudative or exudative AMD. Non-exudative being represented by drusen, geographic atrophy, pre-geographic atrophy, and exudative AMD classically was classified into classic CNVM and occult CNVMs. Nowadays, they are being called type 1 and type 2, and type 3 also RAP lesions. But there are many descriptions which have come up after the onset of these SWEPSOTs, OCTs, and enhanced depth imagings, and also Opta, OCT angiography. So the wet AMD, the classical classification is being sidelined nowadays. I'll try to stick to the basics as has been the theme of this session. So coming to drusen, most of these drusen on FFA, they especially the soft drusen, excuse. Yeah, especially the large soft drusen, they stain on FFA. And on OCT, they are seen as convex homogeneous. The most important thing is the internal reflectivity under the elevation will be a homogeneous reflectivity, medium internal reflective deposit without overlaying hyperreflective foci. I'll show you the images. So these are the large soft drusen, and you can see fine drusen also. And some of them which are not very clear on the color photograph are stained on FFA in late phases. So this is the picture where the stain doesn't cross the boundaries, that the hyperfluorescence doesn't cross the boundaries, though you can see large areas of like this infratemporal to the fovea. If you can look at this is pretty large enough. If at all it increases in size, the hyperfluorescence, then we may have to classify it as a CNVM. But this doesn't, the hyperfluorescence doesn't cross, though even the intensity also doesn't change much on FFA. And this is the OCT, how it looks. As I mentioned, the elevation and the deposit is uniform, homogeneous, medium internal reflectivity will be there in that, in the drusens. Coming to the geographic atrophy, FFA shows areas of hyperfluorescence that appear during transit phase surrounded by rim of hypofluorescence. And we may see choroidal vessels, if it is pretty atrophic, we may see choroidal vessels seen passing through the region, and the staining persists in late phases, not doesn't increase. And on OCT, we will see most of the outer retinal layers are lost, like ELM, ISOS junctions, RP, and Brooks membrane complex, and there will be choroidal hyperreflectivity. So though this is not exactly totally a case of geographic atrophy, you can see the area of geographic atrophy, though that is not very prominent on the fundus photo. you can see the area of geographic atrophy stained and then surrounded by an area of hypofluorescence. But there is a component of a CNVM on one side of the region. So this is one of the pictures of geographic atrophy, and this is a typical geographic atrophy on OCT, where I have mentioned loss of outer retinal layers along with choroidal hyperreflectivity. Coming to type 2 CNVMs, though we had these many in beginning of practice, in my practice after my fellowship 13 years back, I used to have lot many classic CNVMs. But looking back, they appear more of I can say PCVs rather than classics. So nowadays, this FFA classification slowly becoming, because most of the times we see these classic CNVMs associated with other diseases rather than AMD, especially in Asia. So this kind of a picture, where though we don't see hard disk rates in classic CNVMs, but you can look at the FFA pattern, wherein in the early phase, you can see a clear-cut demarcated area of hyperfluorescence, which is filling. You can see the veins are just started filling. So when the veins are just started filling, you can see the hyperfluorescence in the choroidal vessels, and the hyperfluorescence is very well demarcated, and the hyperfluorescence is increasing both in intensity and the what I can say size also. So that is what is called leakage from this, and pooling also happens if there is a subretinal fluid. And this is a case where there is a part of the lesion was scarred, which is showing only staining. And as I mentioned, some of the choroidal vessels are also seen here. But in the early stages, you can see a blocked fluorescence by the hemorrhage, and that blocked fluorescence has active part of the choroidal neovascular membrane, which starts leaking in the midface, and then the leakage covers even the hypofluorescence caused by the hemorrhage also. So this is one of those CNVMs. So occult CNVMs are characterized by fibrovascular PEDs and irregular area of hyperfluorescence with surrounding stippled dots with elevated RPE. But elevated RPE we cannot appreciate on normal routine FFA. We need stereoscopic FFA. And late phase shows minimal leakage as the dye gets accumulated in a closed space, because the CNVM complex is below the RPE. It has not crossed to reach the subretinal space. So you can see in this, though there is a hyperfluorescence which is increasing in intensity, because it is sub RPE, it is not leaking as such. It is sub RPE leak as such, and you can see stippled hyperfluorescence also. So on OCT, though there are many descriptions, especially recent literature for the last 3-4 years has given lot many nomenclature and lot many descriptions regarding what we see on OCT, especially because of the confusion with PCV and RAP lesions and many other descriptions which are coming. I try to show only those points which usually matter us for treatment purpose. So what we usually look at on an OCT when we want to treat or to follow it up and to repeat treatment or restart treatment after a certain period of quiescence. So what we look at actually are either a fluid, which is subretinal, or intraretinal. Intraretinal is like retinal edema, hemorrhage, which can be subretinal or sub-RPE, RPED, retinal pigment epithelial detachment, which can be hemorrhagic, which can be fibrovascular. Serous PEDs we usually don't see in AMD, though the appearance looks like serous, but they are not actually serous. And subretinal hyperreflective material is one of the recent finding which is prompting us to restart treatment after a period of quiescence, or in cases of fresh cases also, even if you are not seeing a fluid or even if you are not seeing a hemorrhage, we do think about starting treatment based on its SHREM.
Last 1 minute, Dr. Rama.
Yes, sir. So exudative AMD complex, if I have just classified these things into the different things which I have mentioned, you can see a hyporeflective area, which is a subretinal fluid, then medium reflective area, which is a SHREM, and hyperreflective, strong hyperreflective area, which is the scarred part of the membrane, and hemorrhage also shows medium hyperreflectivity. So these are some of the images pre and post treatment. One has to look at the fovea. Under the fovea, if the lesion is receding and if the foveal contour is coming back, then the patient improves better. And even if there is improvement in the, even if there is reduction in fluid, if there is a hyperreflective scar under the fovea, you may not see much of an improvement. And this is you can appreciate sub-RPE and sub-retinal hemorrhages in this case, which with anti-VEGF treatment, which the hemorrhage clears, and this gives a hyperreflective scar under the fovea. So this is one more patient who had a classic CNVM, and over a period of time, over 3 injections, has improved very well, and that left a juxtafoveal scar, which is hyperreflective. So PCV is something which, as I mentioned, it is not that easy to understand and to follow. Most of the cases which we are seeing are mostly PCV. What we are seeing is a double layer sign, as mentioned already during CSR presentation, and also a notched PED and polypoidal lesions, which may be seen as hyperreflective dots inside the PED. So these are certain cases which I have come across with hyperreflective dots and double layer sign, which is showing medium internal reflectivity. Yeah. So this is a case of PCV, and this is one more case of PCV which was treated, and after a continuous 5 injections over a period of 1 year, that has become quiescent, but still the PED is seen. And this is one more case over a period of 1 year. After 5 injections, this patient has shown a scar under the fovea, but improved a little. And Opta is coming up nicely. This patient, when we saw, there was vasculature, fine vasculature, which was seen, but the patient was on a 6.6, so she was not convinced. Then after 2 months, the vasculature increased, and you can see the increase in the subretinal fluid. So nowadays, rather than more of FFA, we are shifting towards Opta, apart from the routine SSOCT and EDOCT to treat AMD cases. So I think I'll wind up here. Thank you.
Thank you, Dr. Ram, for a very nice presentation and showing a beautiful series of cases. Yes, we are seeing more of PCV nowadays because of probability availability of newer OCTs and OCT-A, as you mentioned. Yes, we are having a next speaker who will be talking to us about the very new technology or new technological advancement, new diagnostic tool, which is now available in India also, and quite a few vitreoretinal surgeons in India is using it, the OCT angio, what mode it express. I'll invite Dr. Prevarth Bhatia from Chitrakoot to speak on this topic. Dr. Prevarth, please.
Good morning, everybody. Are my slides visible?
Yes, Prevarth, please go ahead. All yours.
So today I'll be talking about OCT angiography, and the first question that comes into our mind, why OCT angiography? So it's a non-invasive tool. It detects blood flow, and mind you, it does not detect leakage. And a very major advantage it has is that it has a layer-specific microvascular details that we can look into. So people may ask OCT versus FFA, which is better. For me, comparing OCT angio with FFA is like comparing milk with water. There may be some properties of milk and water which are similar, but there are certain situations where either cannot be replaced by each other, and so is true with FFA and Octa. So I'll be concentrating on features of Octa that will help us in certain cases over FFA, and the same is true for FFA, but I'll be sticking for some situations where Octa is very helpful. This is how a Octa scan looks like. Just for the sake of it, I'm showing the superficial capillary plexus, a large network of vessels. Deeper is the deeper capillary plexus. Underlying the outer retina, which is meant to be avascular, shows a dark black area, and the choriocapillary shows multiple white dots indicating flow in the choriocapillary vessels. I will move on to the first case here. This was a 17-year-old boy who had a fever with rash 1.5 months back, and since 3 or 4 days he started developing diminution of vision, which was sudden onset. He came to us with a visual acuity of 5/60, and on examination we can see there's a large retinitis lesion involving the fovea at the posterior pole. Adjacent to the retinitis lesion, we can see a blot hemorrhages and a few hemorrhages near the anterotemporal arcade. We went ahead with the OCT, and what we see with the OCT is confirmation of the retinitis involving all the inner retinal layers, going into the outer retina with some amount of subretinal fluid. The adjacent retina looks normal as we can delineate all the layers. The vitreoretinal interface shows presence of vitritis. A fluorescein angiogram, specifically in the early phase, we can see the vein has not filled up. So this is an early phase, and we see there are no new vessels in the area of the retinitis. In the later phases, there is an intense hyperfluorescence. On OCT angiography, which was done, shows a large network of new vessels, which was nowhere delineated on a fluorescein angiogram, probably because of the intense hyperfluorescence which had started. The underlying shadowing at the deep capillary plexus, outer retina, and choriocapillary is a known phenomenon when there is a lot of flow in the overlying layers. This is known as the shadowing effect. On the B scan image of the corresponding areas, we can see lots of red color here in the retina. This red color corresponds to the presence of flow, again indicating presence of neovascular network. This is another case of a 22-year-old male who presented to us with the complaint of floaters since 5 months and a recent onset metamorphopsia. The best corrected vision was 6/9 and N8. On examining the fundus, we can see there are multiple areas of vasculitis involving the veins, and there are some areas of perivascular choroiditis. We can see these yellow areas. The large area of choroiditis just temporal to the fovea and a yellow lesion superior to the disc. So this patient was diagnosed to have a retinal vasculitis with perivascular choroiditis. A TB workup was done, and he was diagnosed to have ocular TB and was treated for the same. But here, if we look into the angiogram here, we see that the lesion just next to the disc showing early hypofluorescence, which turns into hyperfluorescence. The areas of vasculitis is showing hyperfluorescence. But if we look into the lesion just temporal to the fovea, on the fundus photograph, it appears yellow like choroiditis lesion. But on the fluorescein angiogram, in the early phases, we can see this is the early phase as there's a laminar flow in the veins. There's a lacy hyperfluorescence at the center of the lesion with a rim of hypofluorescence and surrounding hyperfluorescence. And this hyperfluorescence increases in the later phases, as you can see. So it is looking like a CNVM on the FFA. But let's see how the OCT looks like from each of these lesions. The lesions next to the disc here, on doing a scan through these lesions, shows a presence of a fibrovascular PD-like growth at the RP, and the B scan image shows these red dots indicating flow. The NFAS image at the choriocapillary levels confirms the presence of a neovascular network. So this is a presence of a inflammatory neovascular membrane in a case of choroiditis. The other lesion, which we were suspecting to have a CNVM on FFA, shows nothing. There's no flow, and even on the NFAS image, we cannot see any new vessels. This is another case of a serpiginous-like choroiditis, a 49-year-old male, again having multiple active and inactive lesions. And if we do a fluorescein angiogram in such a case, we show lots of hyperfluorescence due to staining, window defects, and leakage. Again, OCT angiography came to a rescue in detecting a neovascular network at the outer retina and at the choriocapillary level also. And concentrating on the B scan image, we can see there's a fibrovascular PD-like growth, and there's hyperreflectivity beneath it. The corresponding B scan image shows presence of a lot of flow here, confirming the presence of CNVM. So with these three cases, a few points I'd like to highlight is that retinitis or choroiditis in their active phases, they'll show initial hypofluorescence on FFA and intense hyperfluorescence due to leakage. And when they heal, there is again hyperfluorescence, but this time it is due to staining and transmitted hyperfluorescence. So when such pathologies have a concomitant retinal or choroidal neovascularization and lots of hyperfluorescence due to the inflammatory pathology, it becomes very, very difficult to highlight the neovascular complexes. And it is in this situation that OCT angiography becomes a very handy tool to detect inflammatory new vessels. Now, this is a separate scenario. This was a 48-year-old woman who was tailor by profession. And mind you here, she was a tailor and near work was extremely important for her. And she had a troubled vision since last 1 year. She was diagnosed as a CSCR elsewhere and had been on treatment with eplerenone since the last 5 months. The visual acuity was 6/9 N10 and with a troublesome metamorphopsia. A fluorescein angiogram here shows there's a presence of a hyperfluorescent area just inferior to the fovea. And in the later phases, this hyperfluorescent area becomes much more intense, giving more like a smokestack pattern and an adjacent dot-like hyperfluorescence, sort of like a pooling. Now, this was not very conclusive. More or less looked like a CSCR at this point of time. We did an OCT. We saw small PEDs and overlying neurosensory detachment. So, thinking in lines of CSCR as they were underlying pachyvessels present. But if we look into the fluorescein angiogram, the raster line was not passing through the area of the leakage. As we see, this is the area of the leakage. On passing the raster line just through the area of leakage, we see the RP is bending backwards. There is slight separation of the RP from the Brooks membrane, like a double layer sign. So this was actually a case of focal choroidal excavation with the neurosensory detachment and underlying pachyvessels. OCT angiography was done through this lesion, and to our surprise, what we saw was a presence of a neovascular network. And this was confirmed that this patient is actually a case of focal choroidal excavation with pachychoroid disease with neovascularization, choroidal neovascularization. The other eye of the patient had a large neurosensory detachment with separation of RP from the Brooks membrane, adjacent area of focal choroidal excavation. The FFA again shows some stippled hyperfluorescence, and which more or less increased slightly in size, not very conclusive for a CNVM, though we can suspect in such an appearance that a CNVM is present. Again, OCT angiography came to our rescue and confirmed the presence of CNVM in this eye also. The patient is being treated with anti-VEGF and is very happy at present. So from this case, what we learn here that cases of non-resolving CSCR, chronic CSCRs with underlying pachyvessels, and if there's a presence of a double layer sign, you should always think of ruling out CNVM. And how is that possible? Either by a fluorescein angiogram, as shown in the previous talks very nicely. It is very helpful to rule out CNVM. But many a times the fluorescein angiogram in such cases is also not very conclusive, because in chronic CSCR, there is hyperfluorescence due to RP defects, which is a transmitted hyperfluorescence, and sometimes there's some staining of the RP, and it becomes very difficult to assess if this is actually due to a choroidal neovascular membrane or it is just a transmitted hyperfluorescence. In these cases, OCT angiography again comes to our rescue and helps us in identifying a CNVM complex. Now, in this talk, I want to highlight a very important point here is the clinical decision making of which investigation to be chosen at the right time. These are some of the scenarios where OCT angiography does come to our rescue and helps us in managing patients in a better way. I would like to acknowledge my mentor, Dr. Alok Sen sir, who has been helping us understand all the retinal diseases. He has been helping all the residents and has been tirelessly working with all of us for our teaching. I also have to acknowledge our retina and uveitis team at SNC Chitrakoot. Thank you.
Thank you, Dr. Pivar, for a very nice talk on a upcoming, I should say, upcoming technology, because it's really, we are still, we retina experts still working, we are trying to understand how the OCT will helpful and in our clinical practice, because in the recent survey done by BRS Society, out of 100, more than 100 VR surgeon, hardly few of them were having access to this particular technology. But nonetheless, I definitely feel like a few years back we were talking about OCT when it was came in 2004-5. So we were thinking, "Arey yaar, OCT kya karenge?" But now OCT become the basic need. Probably in coming few years, this OCT-A will able to understand retinal disease more, and probably it will be part of our all retina experts OPD. Thank you for a nice presentation. So now we are having some time for our panel discussion, few question answers we will talk about. So my first question will with Dr. Atul Mishra sir. Is there Dr. Atul Mishra ji?
Yes.
Yeah, yes, sir. Sir, since you are a very senior practitioner from MP and you have seen you are having a lot of experience. But in my own practice, I am seeing the number of FFA in routine practice is decreasing. When I was earlier, I was saying whatever the number I was doing, now it is almost 20, maybe 15-20% of my earlier number. So. Can you elaborate what are the indication where FFA is must even today?
I think when in any pathology you have to see for new blood vessels or microaneurysm or capillary dropout area, there is absolutely no other way. You have to have an FFA done. For others, yes, OCT is an answer. So in any pathology where you have to look these things, you have to do the FFA.
Yes, certainly, sir. Thank you, sir. Yes, where we have to assist the non-perfusion areas, especially this, we are looking for the ischemic macular edema is mentioned in the talk also. We do have to assist sometimes the ischemic and non-ischemic CRVOs, where we have to find whether there is a homogeneous capillary non-perfusion area, so that in CRVO cases there is a risk of going into NVG. So probably we have to plan our laser. FFA is still relevant, although the number is decreasing. Now I'm coming to Dr. Parvani sir. Parvani sir, in case of CSR, how long you want to wait before planning for any laser for extrafoveal CSR, means initial treatment of CSR? Dr. Parvani sir. Is there Dr. Parvani sir? Dr. Amit, can you answer this? Amit Srivastava?
That depends upon the profession of the person also.
Yeah.
If he's actively involved in some activity, like he's a pilot, driver, tailor, then we have to plan the resolution of CSR early. So I will wait for a month, maybe month or 2 months, and if there is no resolution, then we'll do a fundus fluorescein angiogram, and depending upon the location, we can plan the treatment. Otherwise, we can wait for more than 4 months.
Oh, yeah. Dr. Vivek Singh, your comment on this? Meantime, whatever be the, when patient comes to first attack of CSR, is Dr. Amit said, yes, if it is required, the urgency of the treatment. What is the minimum period where you want to wait for laser or for PDT if it is a subfoveal CSR? And what treatment you advise during that period? So first month, as Dr. Amit said, he will wait for 4 weeks. So what the treatment options you will advise to the patient?
Is it for me?
Yeah, Vivek, for you.
Yeah, the standard protocol that is followed is you treat the cases of CSR which are chronic, that is lasting for more than 4 months. Second is if they are recurrent, occurring frequently, after resolution, they come back again. And when you have ruled out other causes, you'll start the treatment by laser or subthreshold laser. In cases of CSR occurring in only one-eyed patient who is active in his life and is pursuing professional, career and needs acute visual acuity to be restored at the earliest. In such cases, you might decide to treat CSRs which are, not chronic and not recurrent. Second thing is most of the CSRs are basically self-resolving, but newer drugs like Applanation have been tried and successfully in many cases.
Thank you, Vivek, for your nice compiling the things. Yes, I was about to ask this epileron. Somebody can tell of the experience when to start epileron and how long to be given. Dr. Dhananjay, if he is available with us. Dr. Dhananjay Shukla.
Yes, sir. Could you repeat your question, please?
The role of epileron in CSR, treating the CSR.
Yeah, it's just a supportive role. Actually, it doesn't help much in most cases. It is more of a empirical treatment, and I think a recent randomized trial has shown, Vivek, that it doesn't help much. So we can give it when we have nothing else to do. For example, in a fresh CSR in a fighter pilot or something. But basically, it's like treating yourself or supporting a belief that you are doing something for the patient. Not much more.
Okay. So Vivek,
some of the things, I'm Ram Kumar here, sir.
Yeah, please.
Some of the publications mentioned aldactone, spironolactone being better than eplerenone in this regard. So what is your take, Shukla, sir?
Are you asking me?
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
What's your question? Come again. I can't hear you.
Sir, regarding the eplerenone, like you mentioned, the recent RCT has shown that it is not much useful. And there are papers which mentioned spironolactone or being better than eplerenone. But still, this debate is going on that also. So, do you recommend among the two, if you have to prefer, which one you prefer?
I would prefer neither actually. See, first of all, this is a class on basics. Let's remember the basics. The number one treatment for CSR is photodynamic therapy, which we are forgetting and nobody has mentioned actually. This is the photodynamic therapy has shown best results only in CSCR and never in AMD. So that's the number one treatment for me. And secondly, for PCV, I mean, in the cases which don't respond to, ILE and stuff. Any drugs actually which like eplerenone or spironolactone, they are just supportive actually. So I do not consider them, and we only try them in chronic CSCR where the lot of loss of RP pump anyway. So people have tried every damn thing, like Diamox, like topical dorzolamide, and there are some papers with some benefits in any of them. It's like anything which doesn't have treatment is a lot of treatment. Let's remember the basics: photodynamic therapy, and for extrafoveal leaks, focal laser treatment.
Thank you, Dr. Dhananjay, for nice compiling. I agree with your view. So now since we are, I'm asking Dr. Alok Sen. Alok Sen, sir. The biomarker has been described for the DME treatment, the role of DME in a number of Manav has, Dr. Manav has mentioned different biomarker on OCT. Do you think with this, which biomarker can we treat with steroid? Can you decide your treatment protocol, whether this particular biomarker will go for anti-VEGF, with this particular biomarker we are going for steroid as a first line of treatment?
Am I audible, sir?
Yes, hello.
Yeah. Good morning, all. I usually don't use any biomarkers for deciding what treatment I would give for diabetic macular edema. Usually, I start with anti-VEGFs in a fresh case of treatment naive diabetic macular edema, and after 3 injections, if there is suboptimal response, I shift to steroids. Now, there are biomarkers which have been shown to be more effective with steroids vis-a-vis like subretinal fluid, large cystoid edema. But what I think is any chronic edema where the component of inflammation is more would respond better to steroids. So fresh edemas and studies have also shown that initially the VEGF drive is more, and as the edema gets chronic, the inflammatory cytokines increases. So fresh edemas, treatment naive-wise, fresh edemas where you have cystoid edema or even subretinal fluid, I usually tend to treat with anti-VEGFs. Chronic, as the edema becomes chronic, I would be more inclined in treating with steroids, of course, keeping in mind the side effects of steroids.
Dr. Parvani, sir, your take on this? Dr. Parvani, sir, is there? Dr. Ashish Atle? Dr. Ashish, your take on this? Please unmute yourself.
Yes, I agree with Dr. Alok that in treating clinically, we mostly use biomarkers for prognostic significance. And in chronic cases, like steroids are better. That I agree with Dr. Alok. And mostly to explain the prognosis or to decide on treatment, you can use biomarker. Only to explain the prognosis. And treatment-wise, you would go by individual cases and other investigations.
Anyone who gives in which condition steroid is a first treatment? Any of them are panelists, Dr. Dhananjay or anyone? First line of treatment. Yeah,
sir,
please.
Yes, sir. Usually, when we combine it with cataract surgery, then I tend to use steroid more often than anti-VEGFs. So somehow, I feel that post-cataract surgery worsening of edema is better. Shows better response with steroids than with anti-VEGFs. That would be one indication where I treat. Otherwise, pseudophakic studies have shown that pseudophakic eyes with diabetic macular edema, you can use either because the response is similar. And We can even use triamcinolone, which is much cheaper than all the available anti-VEGFs with us.
Yes, I agree. I have also used triamcinolone, and I'm still using in some of the patients where the who cannot afford the Ozurdex. Shabir Bindra, do you think in real world practice macular laser is still having a role in treating diabetic macular edema? Apart from the extra, I'm talking of central involved macular edema, not talking about extramacular, because that is clear cut. Focal laser in that is always there.
So now, in maximum cases, sir, if you are having central involving macular edema, anti-VEGF or in certain cases steroids are the first drug of choice. Only in those cases where we have a refractive edema and on angiography we have those succinate exudates, then probably we can give a shot of focal macular lasers. Otherwise, I don't perform macular grid laser also now, modified grid laser also now, are out of practice.
Dr. Dhananjay sir, any take on this?
Yeah, I fully agree with what the other speakers, especially Alok, have said. The only other thing I want to add is when you have lipids, when you have submacular lipids, I always prefer steroids to anti-VEGF agents because this is the condition where I've seen steroids performing much better. One more condition, again, it's not study-based like this one is study-based, but the other is not study-based, but personal experience in chronic renal failure patients. I again see steroids performing much better than anti-VEGF drugs.
Thank you, Dr. Dhananjay. Since we are having a short of time, we are coming to next topic, Dr. Vivek Som. How in case when we are treating ARMD, SRNVMs, how much fluid you tolerate? What is your threshold?
It's a very difficult question and it's a controversial thing nowadays. People start saying that you don't treat fluid, you treat something else. Fluid is a very important marker of how the lesion is responding to the treatment. So once you have started the treatment and the fluid, you have done the loading dose and the two OCTs, two consecutive OCTs showing no improvement in the fluid, you can stop and think of PRN or extend and treat basis. You can always tolerate a fluid which is remaining in 2 or 3 consecutive OCTs and the visual acuity has stabilized and no other signs of activities there.
Thank you, Vivek, Dr. Vivek. Dr. Ramkumar, your say.
Sir, as I mentioned, fluid is something which prompts us to treat. Even retinal fluid, though it is supposedly chronic, treatment naive eyes definitely prefer to treat. And whenever we are getting the response and the fluid is getting reduced, till the time it totally dries up, we can keep treating. But only thing is that if we are not seeing any response even after 2 or 3 consecutive injections, that time we can think about extending the time period between the injections or can watch at that time. Otherwise, whenever the patient is responding injection by injection, I prefer keep treating rather than extending my interval.
Thank you, Dr. Ramkumar. Dr. Atul Mishra, sir. If patient of vein occlusion comes to you, do you advise FFA on first visit or you wait? You will just do OCT and manage the case?
Well, we first will do OCT.
Yeah.
And if the OCT does not show edema, then of course we have to do the FFA to look for the the extent of capillary dropout area.
Yes, Dr. Bisen. Dr. Rajen Bisen, your say. Dr. Bisen, unmute yourself, please.
Yes, sir. I agree with sir. The first line investigation nowadays is OCT. But if a poor responder with our treatment, definitely we would like to see the perfusion status, and definitely we would like to treat with the laser photocoagulation, especially in case of BRVO. If there is a CNP perfusion areas, CNP areas, then grid laser is do very well. In case of CRVO also, if there is neovascularization, there is CNP areas, then again we require laser photocoagulation. So angiography is helpful here.
Thank you, Dr. Bisin. I think I will come to a last question because we have to hand over session to the next session. About OCT-A. It is a very new diagnostic tool and upcoming, but we still need to have a better understanding of this machine and procedure itself. Dr. Preworth has shown a beautiful pictures, but the recent VRISI survey shows it is not available with most of the surgeon. Dr. Pratik, I think you are having you are also using the OCT-A. What do you think in in last 15-20 years, OCT has taken over the maximum role from the FFA. Do you think with OCT-A development will be this FFA will be abolished, absolute procedure after maybe 5-7 years or so? Dr. Pratik Mahajan.
Yeah. It's a lovely question, sir. Basically, what I feel like during my practice, many peripheral, for example, if it's a case of a severe NPDR, okay, when we see a case of, which is common in our day-to-day practice, you see a case of severe NPDR, and you just need to rule out a proliferative changes that is there any occult PDR. So there's no replacement of FFA. Only thing what I see, the macular area, it can be screened with nicely with OCT-A, and it gives a lot of details. Definitely in cases of inflammatory CNVMs, and while following up the size of membrane in cases of age-related macular degeneration, the OCT-A helps us a lot. Second thing, in diabetic macular ischemia, like you can diagnose the ischemic macula without subjecting to the patient to a invasive investigation. So in those cases, OCT-A really helps, but FFA definitely will have a role in cases of seeing leakages and activity, especially in peripheral retina.
Thank you, Dr. Pratik Mahajan. I think we are now, our time is over, so I'm having a lot of questions to discuss with such a beautiful panelist and very experienced surgeon. But because of the time sake, I have to close down this session. I really thank to all my speakers and the panelists who has contributed and discussed, shared their view in this retina session. I agree with that. This FFA and OCT are as of now the basic requirement for any retina practitioner. But in time to come, it will have more of OCT, and now the ultra wide imaging angiography system is also available. So probably we are having much better understanding of the retinal diseases that will help for the better treatment of the diseases in future. Thank you so much for everyone for keeping us very updated on the subject. Thank you so much.
Thank you.
I hand over mic to Dr. Vijay Nichlani sir for the next process.
Thank you, Dr. Giran Chala. Very exciting and very scientific information-filled retina surgeon. So I thank all the participants and moderator for chairing and conducting the sessions. Now we are coming up to the next session. That is a glaucoma session. We have got galaxy and the stars of glaucoma specialists, his faculty speakers, and the experienced chairperson and panelists like Dr. U.S. Tiwari, who had been head of the department and professor and the dean, Gwalior Medical College, Dr. Pradeep Vyas from LV Prasad Eye Institute, Dr. Yogin Vinayak, he is the experienced anterior segment surgeon, Dr. Girish Lale, one of the glaucoma specialists from Bhopal. Thereafter, we have got Dr. Saroj Gupta, Dr. Pankaj Chaudhary, Dr. Arpita Basia, and Dr. Navjot Singh Ahluwalia. So these are the panelists and the chairpersons of next session. To moderate this session, I call upon Dr. Aditya Agrawal, who is again one of the eminent glaucoma specialists. So over to Dr. Aditya Agrawal to conduct the next session. Thank you.
Thank you. Am I audible?
Yes, sir.
Welcome you all on this August platform. And our first speaker is Dr. Sapna and she will be speaking on Applanation tonometry. Dr. Sapna, are you there?
Yes, sir.
Okay. You can start sharing your screen.
Yes, sir.
We'll be having the question answer at the end of the session, not after each talk.
Am I audible, sir?
Yes, go ahead, Dr.
Yeah, you are.
A very good morning to all. I, Dr. Sapna, today have the pleasure to presenting the amount of pressure our eyeballs can handle so as to make our patients smile and see the beautiful creation of God. I'm thankful to MPSOS and GDOS for providing me this wonderful opportunity to start the discussion on the gateway of intraocular pressure, the Applanation tonometry, which is the gold standard for the measurement of intraocular pressure and accurate, based on the Imbert's fixed law, which states that the pressure inside an ideal sphere is equal to the force necessary to flatten its surface divided by the area of flattening. Cornea is not an ideal sphere. The two extra forces acting on the cornea, capillary attraction of the tear meniscus, tends to pull the tonometer toward the cornea, and the corneal rigidity resists the flattening. These two forces cancel each other when flattened area has a diameter of 3.06 millimeter. Because of this, we can measure the pressure of the cornea. Applanation tonometry displaces only about 0.5 microliter of aqueous humor. Displacement is so small that the ocular rigidity and stretchability of the globe has a little effect on the pressure readings. Now the parts of the tonometer with this rod we can connect with the slit lamp. This is biprism with the feeder arm, housing and adjusting knob. To calibrate the instrument, a curved bar is used. Only the tonometer should move forward. The arm should move in the same degree in both the direction, above and below the zero mark. Always clean the tonometer probe before and after each use. Take alcohol swabs and apply to probe in a circular fashion for 5 seconds and dry with the tissue. Inform the patient about the procedure. The patient is instructed to relax, maintain position, and hold the eyes open wide. Put a drop of paracaine in each eye. Wet a strip of fluorescence with a sterile saline. Place it in the superior or inferior bulbar conjunctiva. With the cobalt blue filter, scan the cornea. You use the low magnification 10x. Cobalt blue filter is used with the slit lamp open maximally. The angle between the illuminating and observing beam should be approximately 60 degrees. Room illumination is reduced if possible. Slit beam shine on the tonometer head from the patient's right side for the right eye measurement and for the left eye measurement from the left side. The fluorescent semicircles are viewed through the biprism and force against. Our goal is to align the Maya so the inside edge of one just touches the inside edge of the other. At this point, we measure the intraocular pressure from the scale, which is in the centimeter of mercury. We need to multiply by 10 to convert in the millimeter of mercury. For example, if reading is 1, we need to multiply by 10 to get the reading of 10 millimeter of mercury. If our reading is 1 plus 2, we need to multiply with 1 into 10 plus 2 is equal to 12 millimeter of mercury. In case of large corneal astigmatism, the semicircles appears elliptical rather than the circular, gives error in the measurement of intraocular pressure. So rotate the tonometer tip to red line so the dividing line between the semicircle is 45 degrees to the major axis. Keep in mind, as you rotate the probe according to the cylindrical axis, the Mayas will tilt with the direction of axis. If you see your Mayas are very far, increase the drum pressure to get the alignment. If you see the Mayas are overlapping each other, decrease the drum pressure to get the alignment. If prism is not dried after cleaning or lid touches the prism, it gives the wide Myers, which overestimate the intraocular pressure. So please dry the prism before the use. Inadequate fluorescein concentration may cause hypofluorescence, which underestimate the intraocular pressure. Ask the patient to blink or use the additional fluorescence. Thick cornea due to increased collagens give overestimation, whereas the corneal edema gives the underestimation due to biochemical changes. Distortion of cornea or corneal scars gives the inadequate intraocular pressure measurement. Too little fluorescence, thin cornea, corneal edema, repeated tonometry gives the falsely low IOP, whereas the too much fluorescence, thick cornea, steep cornea gives the falsely high intraocular pressure. There is a relationship between the intraocular pressure and center corneal thickness. Accurate 3D comes when the center corneal thickness measures between 545 to 550 micrometer. Thinner cornea may lead to underestimation of the intraocular pressure. Pressure that is causing glaucoma damage is actually higher than the measured by the tonometer. Thick cornea leads high intraocular pressure reading, leads to overestimation of intraocular pressure, leads to over treatment of the normal intraocular pressure. If your IOP comes high or low and it is not clinically correlates, you can plan Phacoemulsification. In the last, if active infection patients with recurrent corneal erosions or corneal abrasions that are not totally healed, please don't do the procedure. In the COVID era, clean and sterilize the slit lamp before and after the use the PPE kits. If you are doing any suspected patient tonometry, please sterilize your tonometer prism by immersion in the bleach solution with sodium hypochlorite or 3% hydrogen peroxide for at least 5 minutes. Thanks for patient hearing.
Thank you, Sapna. It was a very comprehensive presentation. And if we have any questions, we'll take at the end of the session. Our next speaker is Dr. Mayank. And as you all know that we have to classify glaucoma, whether it is open angle or close angle. So Dr. Mayank will speak on gonioscopy, how to identify structures, documentation, and classifying the angles. Dr. Mayank. Do I have to keep the time also? Somebody else is taking care of it.
Someone else is taking care of it.
Okay.
The IT person, Mr. Rahul.
Okay,
Very prompt in time.
Okay, thank you.
Thank you.
So are my slides visible? Hello?
Yes, they are. Yes, they are.
Okay. So good afternoon, everyone. At the outset, I would like to thank Dr. Rakesh Shakya sir, Dr. Navjot Singh Ahluwalia sir, and Dr. V.K. Nichlani sir for giving me an opportunity to present on this topic. So the topic assigned to me is gonioscopy, how to identify structures, document them, and how to classify or grade the angle. Now, before going into the topic per se, let's quickly understand the basic principle of gonioscopy and how do you perform gonioscopy. So the angle of anterior chamber cannot be visualized directly through intact cornea because light rays emitted from angle structure undergoes total internal reflection. Gonioscope facilitates examination by obviating the corneal air interface and aiding in visualization of angle structure. The direct gonio lenses have a steeper curvature than the cornea, so light rays are refracted such that the critical angle is not reached. Whereas in case of indirect gonio lenses, they have mirrors mounted on gonio prism. So light rays are reflected from mirror and leave the lens nearly at right angle. Now, a wide list of indications are listed in textbook wherein gonioscopy should be done. I have listed a few of them and classified them broadly into diagnostic and therapeutic, which are listed in this slide, like classifying a narrow angle glaucoma into primary angle closure suspect, and primary angle closure glaucoma, and to differentiate between open angle and angle closure glaucoma. However, in conditions like open globe injury, a case of recent or fresh hyphema, cases with active infection and corneal epithelial pathologies, gonioscopy is contraindicated. Now, these are some examples of direct gonio lenses and indirect gonio lenses. Now, the gonioscopy is broadly classified into two categories, that is direct and indirect. Indirect can be further classified into scleral type, that is without indentation, and corneal type, that is with indentation. Now, coming on to the procedure, I'll be highlighting only some basic important steps. The patient's head should be braced firmly against the headband of slit lamp. The lateral canthus of eye is lined up with the canthal marker of slit lamp, and the examiner's elbow must be well supported using an elbow rest. In scleral type lenses, after anesthetizing the cornea, a coupling gel is inserted into the cup of gonio lens, and the lens is brought in contact with the inferior sclera and can be tipped up into the position. In case of 4 mirror lenses, lens should be applied lightly until the air disappears from the corneal interface. As per Southeast Asian glaucoma guidelines, the examination should be performed with least possible illumination. A narrow slit beam should be used and it should not cross the pupillary margin. It should be parallel to the axis of mirror, that is, vertical for superior and inferior angle and horizontal for nasal and temporal angle. Start with the temporal quadrant and you can go clockwise or anti-clockwise. Now, manipulative gonioscopy is of value in studying angle anatomy, narrow iridocorneal angle. A more tangential viewing of angle aids in identification of angle structure obscured by convex iris. This can be achieved in Goldman type lenses by simply asking the patient to look in the direction of mirror or moving the mirror towards the angle which is being viewed. The technique of indentation gonioscopy is useful to differentiate between appositional and synechial angle closure. It can be done with 4 mirror lenses which do not vault the cornea. A central compression on the cornea pushes the aqueous peripherally and the iris root posteriorly. If the posterior trabecular meshwork becomes visible upon pressure application, then the area of angle closure is appositional, otherwise it is synechial, as shown in this picture. This gonioscopy image depicts the sequence of angle structure from anterior to posterior, which will be discussed in subsequent slides. Now, the Schwalbe's line is the most anterior structure. It demarcates peripheral termination of Descemet's membrane. It is marked only by a slight change in color from trabecular meshwork or by a faint line. It is best identified by locating a corneal wedge. That is, when a thin slit of light hits the iridocorneal angle at an angle of 10 to 15 degrees, 2 light reflections from external and internal corneal surfaces are formed, which pipe down at the sclerocorneal junction. That is Schwalbe's line. The prominence of this line is known as posterior embryotog zone, which can be appreciated in this picture. Now, the trabecular meshwork lies between Schwalbe's line anteriorly and scleral spur posteriorly. In young individual, it has a ground glass or a translucent appearance and it becomes coarse and pigmented with age. It has an anterior non-pigmented or a non-functional part and a posterior pigmented or functional part which overlies Schlemm's canal, through which aqueous humor escapes from anterior chamber angle. The next structure, that is scleral spur, is the most anterior projection of sclera and it is the site of attachment of longitudinal muscle of ciliary body. Iris processes are small tenuous extension of anterior surface of iris that insert at the level of scleral spur and can cover ciliary body. The ciliary body stands just behind scleral spur as pink, dull brown or a slate gray band. It is important to note the peripheral iris configuration and classify it as either steep, plateau, flat, and queer. Now, while documenting gonioscopy finding, one should always keep in mind that a mirrored gonio lens does not invert the image of angle, which is very much evident in this picture. One can always use color codes to document angle findings like synechiae in orange and angle recession in brown and cross-hatched lines. Do document your gonioscopy finding with the date in the following sequence, like use X diagram to represent angle, record the most posterior structure, record the effect of manipulation, interpretation as to what structures are seen, describe the grading of posterior trabecular meshwork pigmentation, record presence of iris process in appropriate quadrant, and record any anomaly in appropriate quadrant. This is Schaffer's color goniogram. Now, various grading systems have been put forth to classify angle. We'll be discussing few of them here. Like Shy system emphasized on the most posteriorly visible structure. It scales from 0 to 4. It is reverse of Schaffer system, with grade 4 being the most occludable angle. The most widely used scheme is Schaffer classification. The widest open angle is grade 4 and closed angle is grade 0. Spieth classification is a complex system of grading angle. It classifies the angle after taking into account site of iris insertion, angle width, peripheral iris configuration, and trabecular meshwork pigmentation. In the next couple of minutes, we'll be seeing gonioscopic images of various angle abnormalities like goniosynechiae and peripheral anterior synechiae, plateau iris configuration, where we see curvature of iris along lens surface and anteriorly placed ciliary process with dipping of iris at lens equator, widening of ciliary body band in angle recession glaucoma, heavily pigmented angles or mascara pigmentation with concave iris configuration and pigment dispersion syndrome, cyclodialysis cleft due to separation of ciliary body band from scleral spur, PCIOL haptic through peripheral iridectomy in angle, foreign
Last 1
body in
minute,
angle.
Dr. Mang.
Hello.
Last 1 minute.
Yes, sir. New vessels in angle with the peripheral anterior synec is seen in neovascular glaucoma and silicon oil particles in angle. Now, these are American Academy guidelines for cleaning of diagnostic lenses. Alternatively, 10 minutes of continuous rinsing under tap water can be used. So I would like to conclude my presentation by saying that diagnostic basis of any glaucoma should be in correlation to gonioscopy findings, and nothing can replace the art of learning by doing. So don't be hesitant of practicing gonioscopy, because only regular practice can help you learn the accurate art of gonioscopy. These are my references. Thank you.
Thank you, Mayank. It was a very comprehensive and you also finished in time. We'll take the questions after the session. Our next speaker is Dr. Ravi, and he will tell us about how to evaluate a optic disc, which is the gateway to the diagnosis and treatment of glaucoma. That's the first thing we come across after IOP. We become suspicious about the disc, and it's a very important clinical entity. Ravi.
So am I audible, sir?
Yes.
Yes, so slides is visible?
Yeah.
Good.
Yeah. Good afternoon, all of you. Yes, after the tonometry and the gonioscopy, now just into the eye and see the optic disc, where the most of the happening things is going on in the glaucoma. So this is the triad for the diagnosis of the glaucoma. If we look at the IOP, that is not necessarily raised in all the cases of the glaucoma. If you look at the fields, that has to be correlated with the disc finding, and even the disc field changes to occur, the decent number of the axons and ganglion cells has to be damaged. So this is again for the disc and the RNFL changes is we can say that found in the almost all variety of the glaucoma. If I have to choose one finding out of these three, then I would definitely choose the disc and RNFL changes. Even in for the definition point of view, that itself says the importance of the disc evaluation, that it is the morphological changes at the optic nerve head and the retinal nerve fiber layer. So how do we do that? We can do this by imaging, but the limitation of that is not accessible to each and every person, every ophthalmologist. And even if you are having this 30 lakhs costly machines, that certain times it is not able to pick up the subtle changes that your eyes that is having the 500 megapixel camera can pick these RNFL defects. So clinical examination is of course the most important thing, that we can do this by the 90D or 70D examination, and with the help of the slit lamp biomicroscopy that provides you the stereopsis as well as the magnification. Even if you don't have this, we can do this with a direct ophthalmoscopy, but that is lacking the stereopsis, and the indirect ophthalmoscopy that is lacking in the magnifications. But even if you don't have these 90D and all these things, you can do that with all these equipments also. So should be done in the dilated pupil, because it provides you liberty to the detailed examination, and even you can examine the anterior segment as well, so that we can see the neovascularization or the pseudoexfoliation, and also examine the dilated condition, the peripheral VR view, that sometimes mimicking the field changes for the glaucoma. So what we should look for? We should looking for the 8 intrapapillary features or the 4 peripapillary features that has been described by the Dr. Jonas. The 2 aspects of the optic disc, 2 aspects of the NRR, 3 aspects of the cup, and the position of the central trunk. So please don't jump directly to the CD ratio, because CD ratio is what we have lost actually. We are more interested what we are remaining, what the remaining half glass of the water or the glass of the water remaining part, that is the NRR. Even if I say that cupping is 0.3 or 0.8, that primarily give the impression that 0.3 cupping seems to be normal and 0.8 cupping seems to be glaucomatous. But if we see the picture, that situation is reversed. Here's the 0.8 cupping is non-glaucomatous, while the 0.3 cupping looks like it is glaucomatous. So please don't jump directly to the CD ratio. If we see this cut pieces of the egg, the central yellow part seems to be the cupping. All 5 cut pieces is having the 0.5 cupping. upper rows is the 0.5 cupping seems to be the white NRR seems to be normal, but the lower rows, although it is having the 0.5 cupping, but the inferior rim is thinning. So alone cupping saying doesn't make any sense. So firstly, we should measure the disc size because it is having the large variability from 0.96 to the 2.91, and glaucoma tends to be overdiagnosed in the large disc and often missed in the small disc. So we should measure the disc size. How we can do that? We just first decide the disc margin. What it is basically the innermost border of the reflective tissue that is internal to any pigmented area. That is what we call the scleral ring. Once we decide the optic disc margin, we just put the slit beam and focus and coincide with the margin and just see the reading on the graticule of the slit lamp and put the multiplication factor for the correction factor according to the lens. We are using an 90D or 78D. Once we decide the disc size with the slit lamp microscopy, even if you don't have, you can use the direct ophthalmoscope, small aperture of Welchel ophthalmoscope. Just put this on the optic disc. If it is just outside, it is normal size disc, and if it is within the disc, 5 aperture, it is a small disc, and if it is way beyond, it is large disc. So after deciding the optic disc size, we move further to the CD ratio. And what we do is margin. First, we decide the margin of the cup. After deciding the disc size, we decide the margin of the cup. Where it is basically the sharp drop off where the NRR ends, and usually the circumlinear vessels kink at this cup rim junctions. That is very well depicted in this picture. So cup usually becomes vertically oval in the glaucoma. Usually it is horizontally oval, whether it is disc is vertically oval. So it is cup becomes vertically oval in the glaucoma. So once we do the CD ratio deciding, if I say the CD ratio is 0.3, 0.5 and 0.8, it gives you false impression that the 0.8 is having the glaucomatous cupping. If I remove this curtain from this and we see the whole picture, then this is incorporate this disc size into the consideration. Then although this 3 disc is having the different CD ratio, but the rim area in all the 3 is almost same. So we should consider whenever we say CD ratio, we should consider the disc size also. Next comes the neuroretinal rim. Identifying the neuroretinal rim is the most important parameter we should do in the examination of the optic disc. It is basically the pink or orange area between the disc margin and the cup margin. And inferior one is the thickest. Isn't rule is if it is disobeyed, that means the arouses highly suspicion of the glaucomatous damage, but it is not necessarily more than 80%. It is obeyed, damaged or disobeyed in the glaucomatous condition, but certain times it is disobeyed in the normal conditions also. So loss of NRR from its inner edge is cardinal feature of the glaucomatous disc damage. It can be the focal or diffuse. It more commonly seen in the inferior temporally or superior temporally, and we should pay more attention to the contour rather than on the pallor or the color. So where the vessels is having this changing its direction, we can say there is the loss of the NRR and this is notch or excavation is there. After this, we should look for the RNFL that is best done in the red-free color, red-free light, that is green light, and we see the bright striations superiorly and inferiorly. And if we focus on these areas, that is showing basically the V-shaped defect of the RNFL that is more prominent in the red-free light, and the vessels becomes more evident in the, if it is the RNFL defect is there, the defect has to be carried to the disc margin. That has to be the if it is glaucomatous. If we see this picture, picture is showing the vest defect. Rest of the thing is normal. That sometimes may not picked by the costlier OCT machine that you can pick with your eyes. That is having the more than 500 megapixel camera. Next, yes sir.
Please conclude.
Yes, sir. Next is the peripapillary atrophy that is having the beta zone, that is the inner one, more important for the glaucomatous point of view. We have the disc hemorrhage. It is suggestive of the uncontrolled glaucoma, but sometimes it is subtle disc hemorrhage that cannot be seen, easily missed. So we have to look for that. These are the vascular sign, bayoneting, bearing of the circumlunar vessels, and arterial narrowing, or there is a shifting of the vessels. These are the certain changes, lot number of changes seen in the optic disc. We have to look for that, and we should document. We are not, nobody is judging your drawing skills. You have to just document and all these things, and just use the DDLS score for the standardization of the purpose, so that everybody can compare the things. If we do the systematic examination, we are able to answer all these things that is traditionally called as the 5R. And so that took only 30 seconds. That has been proven in the study of the teaching institute, that the whole examination took only 30 seconds. So I just conclude my saying that the saying of the Dr. Robert Fechner, that we get so enamored of the technology in ophthalmology that we can overlook some of the fundamentals. If we do this at certain times, we can get much more information that we can get from the posterior machines. Thank you.
Thank you, Ravi, for your talk. And the take-home message which you gave in the last couple of slides was that you should start drawing your disc and make your own small findings on the case sheet of the paper of the patient, so that in the long run they help you. And we don't have to depend too much on the technology. As we all know that there is a pressure-related damage to the optic nerve fibers in glaucoma. And there is also element of recording of the intraocular pressure. But the cornea and the sclera and the lamina crepullosa, their biomechanical property, do have a bearing on the pressure-related damage. So I request Dr. Parag Sharma to give his talk on the cornea and the glaucoma. Thank you.
Good afternoon, sir. I thank to the Madhya Pradesh State Ophthalmic Conference for giving me the opportunity, and my topic is corneal factor in POAG. Does it make difference? So the cornea factors represents a summation of cornea's curvature, elastic properties, surface tension, and intraocular pressure. Although in all of that, central corneal thickness is a major component. The mix of the collagen types, corneal hydration, pacing density of the collagen fibrils, and the structural metrics and other factors undoubtedly vary among the individuals. So the central corneal thickness can influence by many factors, including ethnicity, genetics, age, glaucoma treatment, and subtype of the glaucoma. This has been proven in American Academy of Ophthalmology, Canadian Ophthalmology Society, APGS, or European Glaucoma Society. All this society has done number of studies, and they have proven this CCT can vary. So several well-designed studies confirm that central corneal thickness bear an inverse relation with the risk of developing glaucoma damage. So the CCT may vary systematically in the different form of the glaucoma, like pseudoexposition syndrome have a thinner cornea as compared to the only pseudoexposition is proven by the different study. So CCT among the racial groups, like black participants have a thinner cornea, like 529 micron as compared to the white one. After LASIK is very big mistake done by the many ophthalmologists and even by me sometimes. So if you not take the history, a patient has undergone the LASIK surgery 20-25 years back. We just looked at a disc. Okay, disc is look like a myoptic disc, and the pressure is hardly 18 millimeter mercury, and you have not taken the central corneal thickness. So you may miss the glaucoma, and that condition patient may have lost irreversible damage. So this condition, definitely we have to take a very good history, and simultaneously we have to prove that central corneal thickness, and that become a part of our routine examination. And if you get that patient has history of LASIK, that best way to take the intraocular pressure is a dynamic control tonometer. So the Goldman Applanation tonometer is the gold standard, and the IOP measured was developed based on the 500 micron. However, with the cannulation study, is a central corneal thickness of 520 micron is found the most accurate for gap tonometer. So how we can take the central corneal thickness with the most widespread use of the measure the CCT is ultrasound phacometry. Other devices that we can use, the Goldman pressure tonometry is still gold standard, and post-LASIK we can take by the dynamic control tonometer. Many newer tonometer like ocular response analyzer, which takes into the account corneal hysteresis and provide 2 IOP measurement, and by corneal compensated IOP or Goldman correlated IOP. Tonopen have very negligible effect of CCT when we get the intraocular picture. Rebound tonometers affect the corneal hysteresis and the resistance rather than the CCT. So the Alhers et al. That deviation of 100 micron from the ideal CCT of 520 micron introduced as error of 7 millimeter mercury. So IOP correction factor are based on a structured normal cornea with no pathology. Thicker cornea like corneal edema have a lower intraocular pressure. Thin cornea, if there is a scar, they may have a high intraocular pressure with the increased elasticity of increased rigidity of the cornea. This study has proven that central corneal thickness has an importance. In that row, ocular hypertension treatment, hypertension study, if the patient CT is 555 micron or less, had a 3-fold increase risk of developing glaucoma within 5 years as compared with the someone have CCT greater than 588. So glaucoma, the patient with the established glaucoma, the predictive role of CCT is still we have to see and decide on that. The CCT phenotype is highly heritable trait based on the twin study, and the CCT associated with the primary open glaucoma with the genetic profile of FND3C3P. So if you consider the history and take the hypertension, diabetic, or migraine or something, if the patient is diabetic or HbA1 level is a higher side, and that type of patient, definitely the CCT is thicker as compared to the normal person. Other anti-glaucoma medicines like prostaglandin analog, beta blockers, alpha-2 agonists, they all have a reversible increase the central corneal thickness. But in carbonic anhydrase inhibitor, cornea is not good, not healthy, or it becomes decompensated cornea that increase the CCT value. So I conclude my topic that by performing phacometry maintains the management of the all patient by allowing clinician to first observe or pursue less aggressive treatment of patient with pseudo-ocular hypertension. Second, modify the target interpretation in patient with glaucoma. And if there is a thick cornea, they are protective. Or if there is a thin cornea, they definitely have a big risk for the developing glaucoma. Thank you.
Thank you, Barak, for finishing before time and also highlighting the factors which may influence the recording of the intraocular pressure, which is again a guiding factor for treatment of glaucoma. Our next speaker is Dr. Manish Pandey, and he has got a uphill task to finish his talk in time, and that is again on perimetry. So, welcome, Manish.
Yeah. Are you able to hear me, sir?
Yeah.
So my topic is basics of perimetry reading. I thank MPSOS for the opportunity. So when we look at a visual field printout, that's the way we need to look into it. The number one thing that we need to look, whether the initial parameters are okay, the patient's name, the correct sort of printout, the age has been entered correctly, and whether the reliability parameters have been put up correctly, and before we start analyzing what the test is giving us. Go next and have a cursory look at the thresholds there, but don't go into details at that point. Go next and see into the statistics, that is the total deviation and the pattern deviation plots. It's the pattern deviation plot which is more important for us when you're talking about glaucoma. And finally, there'll be some numbers at the end that we need to analyze. Basically, when you talk about perimetry, there are different sort of tests, but commonly we use the 30-2 or the 24-2. Both are very similar to each other, except the peripheral row of points is missing the 24-2, except for the 2 nasal points that are incorporated. The other common test that I do is a 10-2 test that tests the central 10 degrees, but here the spacing is a little more wider at around the 2 points in the 24-2 are spaced by 2 more points. There will be 3 more points in between 2 points. So their spacing is wider, and we are able to analyze the central visual fields a little more closely there. The other one is a macular threshold. Commonly in glaucoma, we talk about a CETA standard test that we do, a 24-2 size 3 perimetry. That is called as a white on white perimetry. Sometimes you also do a 30-2 test. Look at the reliability indices, look at the fixation losses, which are flagged if they are more than 20%. Look at the false positive errors, which might suggest a trigger happy patient, and look at the false negative errors, which may suggest that the patient is fatigued, inattentive, or possibly malingering also. Go next and see into the total and pattern deviation plots. Now, it's important to look into these plots because the total deviation plot may have a lot of scatter because of many of the reasons like media opacities. And when we correct it, we get a pattern deviation plot, which gives us a localized damage. It's the localized damage that we are looking for into glaucoma, and that's what we are more concerned with. So the pattern deviation plot is what we need to look for. When we need to do a 24-2 and a 10-2, look into the 24-2 tests and see those central points. So the central, one of the points is depressed to 0. So we need to do a 10-2 test to find out whether there is a threat to fixation at that point and do a 10-2. That is one of the indications that I commonly use. The second one is when there is total field constriction and we see only a central visual fields, it's important to do a 10-2 and possibly follow that also with commonly with the 24-2 as well as a 10-2 testing on this. Now, there may be different generations of perimeters also. So in some of these perimeters, even in a patient with advanced glaucoma and advanced field damage, you might find that the pattern deviation plot in the left figure is actually showing very small damage. That is because most of the points are actually depressed. And that might give off a false suggestion that the fields are actually normal. So we don't need to regard these sort of visual fields. In the newer generation of machines, it is already written there that the pattern deviation plot is not shown because the fields are severely depressed and need to refer to a total deviation or the VFI plots there. Go and see into the glaucoma hemifield test because it gives a high sensitivity and specificity for glaucoma. And there is another small value given next to it called a visual field index, which is noted as 91% here. It varies from 0 to 100%. 0% would mean a totally blind and 100% would mean a totally normal visual fields. Look into the artifacts. So this is a patient who has come to us with a visual fields and you can see a superior defect there. But if you look closely into the picture, the upper eyelid is actually encroaching onto the pupil. Lift the eyelids with a tape and repeat the visual fields and they come out to be normal. Another patient who has fairly normal looking disc and we see those peripheral rim points there, rest of the fundus appears to be normal. And we can see that the fields have been repeated and corrected by use of a contact lens. Because of the correction there, it's plus 7.25 diopters and it has been because of the peripheral row of points is because of the error from the trial frame. Use a correct sort of contact lens and repeat the visual fields and you can see those spots disappearing. A cloverleaf pattern, it's because patient is initially attentive to it, visual fields, and after some period of time becomes fatigued. And this is a typical sort of a cloverleaf pattern which may come. Another pattern is the trigger happy patient in which you can see those foveal thresholds increase to 40 and 45. If you look closely into the picture, that is theoretically not possible humanly. And that's because the patient is constantly pressing the buttons. And that is why you are seeing this sort of a response. And you can see those white scotomas on the gray field. But we have to look into the clinical correlations. And whenever you do a visual fields, there are two questions that we need to ask ourselves. Is there a visual field effect? And is it glaucomatous? And never interpret a visual field in isolation. That is always correlate clinically. Don't look into the picture unless until you have seen with optic disc that we have seen in the previous presentations also. So there is an inferior and thinning there. And that's why you're correlating it with a superior defect there. So is this defect glaucomatous? Yes, because it correlates to what we see on the optic disc. Is this defect glaucomatous? Yes, because there is a superior defect there. You can see the nerve fiber layer and you can see a corresponding inferior defects there. It's a moderate defect. So there are certain rules when we are trying to assess visual fields. Establish a baseline over 2 or 3 visual fields that may be required over a short period of time if the patient is coming to you the first time and is doing the fields for the first time. And in case you have a suspected progression, not a confirmed progression, but a suspected progression, we may need to repeat the visual fields within a shorter period of time. So what do you expect out from these fields? Always have a strong structure-function relationship. So look at the optic disc and try to correlate what you are trying to see or expect from the visual fields. So is this defect glaucomatous? When you look at the optic disc, you might feel that possibly there's hardly any rim loss. There's a large optic disc and appears to be fairly healthy, but the fields are not correlating to what we see in the optic disc. Repeat the visual fields and they come out to be normal. So is this defect glaucomatous? No, because there is a corresponding to a coloboma there, and that is why you are having those sort of defects. Is this defect glaucomatous? No, it is not, because there is a tilting of the optic disc, and that corresponds to the defect that you see on the visual fields. Is this defect glaucomatous? No, because the peripheral row of points, what we see on the visual fields is correlating to the PRP spots that the patient has undergone in the picture. So look into the fundus also. It's not just the optic disc. You have to go and look into the peripheral fundus also, whether there is a reason why you are having these sort of defects. Establish a prior probability of progression. Glaucoma may be well controlled or may have a poor control and advanced damage. Look at the clinical inputs also that have been discussed. Look into the intraocular pressure, the disc hemorrhages, what stage the disease is, and the further supporting factors such as imaging. And if progression is there, we have to find out if it is glaucoma which has caused the change, or is it something else? Because there may be certain reasons such as localized subcapsular cataracts, retinal lesions, or disturbances of the higher visual pathways which may cause these apparent defects. And if these do not correlate, there may be other reasons or there may be neurological reasons. So if you look into these visual fields, they don't appear like a typical glaucomatous defects because they respect the vertical midline and they are sort of quadrantic defects. The patient will have something out into the brain and we need to do possibly an imaging of the brain also to find out the reason for that. Another picture, and if you look at it very closely, this patient came with medications. And if you look very, very closely, you might see that there is a bitemporal effects which are much more severe on the temporal halves in both the sides, though it becomes a little confusing in the left picture, but we'll see there are more defects. And ultimately, patient turned out to be a pituitary macroadenoma. So in conclusion, we'd say never interpret a visual field in isolation, always reconfirm any change, and it is beneficial to correlate with other clinical observations. Thank you.
Thank you, Manish. That was an excellent presentation. And every comprehensive ophthalmologist has to learn how to read a single visual field chart. And thank you for making things look so simple. Otherwise, a visual field chart looks like something written in Chinese. So thank you so much. As we all know that structural damage precedes the functional damage. And we have newer technologies who can give us some clue about the structural damage. So we have Dr. Parvez Siddiqui. Welcome, sir. And he will highlight on the newer diagnostic technique of OCT. Dr. Parvez.
Am I audible, sir?
Yes, sir, you are.
First of all, from the onset, I would like to thank MPSOS for giving me an opportunity to speak upon OCT or optical coherence tomography in glaucoma. This is my alma mater where I work. And to begin with basic, optical coherence tomography is an imaging technology that employs coherence interferometry to obtain cross-section images of the ocular tissue. It is shown, the machine is shown, and whatever you get from that is shown over here. What are the basic advantages of these things? It is easy to operate. It has the best resolution among all the imaging devices. Has a rapid image acquisition time. Being a non-contact technique, images can be obtained without causing undue discomfort to the patient. That is very important because it's something which is not present in other machines. You can have a qualitative and a quantitative data, and which can be analyzed. It is the only technology capable of imaging the optic nerve head, retinal nerve fiber, and other, which I'll be discussing, macular GCIPL cell. It can obtain posterior segment images without pupillary dilatation. Let us discuss something about anterior segment OCT. Anterior segment OCT uses light of longer wavelength than compared to the posterior segment OCT, that is 1310, to obtain images of the anterior segment. This is very important because we are using something. Application goes down to see angle recess area, trabecular arrest space. As far as these are the few of the importance of anterior segment OCT. You can evaluate the laser peripheral anatomy and other intervention of the angle anatomy. Very important thing is that assessment of the blood morphology and patency ostium post-filtering surgery can be assessed. What are the disadvantages? Poor ability to show the details of ciliary body and posterior surface of the iris.
It cannot detect cyclodialysis, cleft, and ciliary body tumors, although we are not very seeing a lot of cases of ciliary body tumors in day-to-day practice. But when it occurs, you can rely on anterior segment OCT. Image quality of superior and inferior quadrant is not so much up to the mark. And landmarks which are there for gonioscopy, like scleral spur, Schwalbe's line, not always clearly visible as compared to UBM. Okay, they are visible to a certain extent. Here, as far as posterior segment OCT is concerned, it uses a light of 830 nanometers. The parameters which can be topographically and automatically calculated related with the age and everything. What is the I'll be discussing these talks under three headings. One is the assessment of RNFL thickness. Second is optic nerve head assessment. And third is macular GC plus IPL thickness. Because in this machine of Cirrus and Sweep Step and all what have come into the market are not able to differentiate GC IPL in total. They take into consideration the inner plexiform layer thickness also. So let us discuss a few things about RNFL thickness. These are the quality assessment checks. Signal strength should be at least 5 in a Cirrus model. Other Sweep Steps or other modes have got their own strength, but what machine we have, the Cirrus SDOCT should be more than 5. What it measures a 6 by 6 millimeter cube square area, which is a circle stationed around a 6.46 mm centered at the optic. And a Cirrus OCT advantage with the other TD and other machine is that it does not depend upon the operator, because it just corrects by itself if something is not stationary upon it. What you get into it? RNFL thickness measurement is represented in a graph with temporal, superior, nasal, infra. Again, the temporal orientation comes into it. This is a depiction of what you see in an SDOCT machine. A few words regarding what we are trying to calculate and what we want to see and what are the ranges into it. Average parameter is 114.03 mu micron. In various textbooks, in various other literature, there may be some difference in this parameter, but in a nutshell, 114 or in the vicinity of that is the average parameter on NFL. As we are aware, inferior, superior, nasal, and temporal. The thickness goes down in particular fashion. Inferior to temporal comes down to 70.2 micron. I will illustrated the average range also of all the diameters in various quadrants. What we are looking for into it? When do we say we have got a loss of RNFL and which is perimetric, or it is perimetric, and what do you want to exhibit into it? In a patient who is in early glaucoma, if you have an RNFL thickness of somewhere in the vicinity of 80.3, that is been quoted in literature also, and in advanced glaucoma, sometimes it goes down to 50.7. Leave aside the fluorescein. You will not have a complete abolition of this particular RNFL thickness as such, because other supporting cells are there. Advanced glaucoma will go down somewhere in the vicinity of 50.7. After that, you require the help of macular GCL IPL thickness or a visual field, because lesser than that, you will not be able to correlate the linear event or trend-based progression of the RNFL thickness. We are all aware structural changes precede functional changes, and those patients of ocular hypertension who were diagnosed had RNFL defects 6 years prior to visual field defects. That is why this RNFL defects become very, very important as far as pre-perimetric or early glaucoma patient, or in patients of glaucoma suspect or patients of ocular hypertension. We are all aware RNFL thickness has got 84% sensitivity and 98% specificity. What we are looking at the inferotemporal and the supratemporal quadrant mostly with a higher predictability value. There is one thing more which has to be taken into account, and new machines are taken into account, is that RNFL thickness goes down the year as we ages by, with a somewhat 0.2% per year, or and in a normal age group. But in a glaucomatous patient, I have shown it is minus 4.08 micron, but in a glaucoma patient, it goes down much faster at a more swifter rate, somewhere in the vicinity of minus 0.98, rather it is not 0.98, 9.98 micron per glaucoma patient. Fluor effect I've already illustrated. Fluor effects means 57 micron left in cirrus. If it occurs, go for macular OCT because these are the cells, RNFL is not left. Only the supporting glial cell and other cells are affected. Do not keep on doing a serial assessment of the RNFL patient if it has gone down to 57, 55. You will not find any drastic change or reduction in this quantity. As far as their inferior quadrant is resistant to age-related decay and should be followed very, very carefully. Inferior quadrant has to be looked into it. And recent software of Stratus, this variety of 5.0 version, has included a software to evaluate association between average RNFL thickness and age also. These are the where you are doing it now. These are the mapping of the RNFL thickness.
Dr. Parvez, can you conclude now? Thank you.
I'm concluding the RNFL thickness. We go for a glaucoma suspect if it shows expansion of an RNFL defect. If there is development of new defect, I'm talking of glaucoma suspect. If there is expansion of RNFL defect, if there is development of new RNFL defect, if there is a deepening of the existing defect, or if the infratemporal meridian should be very looked for. Whereas in glaucoma, in a glaucoma confirmed patient, average RNFL thickness monitoring should be done preciously. RNFL thickness in inferior quadrant should be looked. Greater than 9 mu micron difference between the two eyes of RNFL thickness should always be taken into account. In green diseases, although all the parameters are in green, but if there is asymmetric thinning between the two eyes of a glaucoma patient, then it has to be taken into account. In red diseases, in which mostly patient comes in myopia, as far as then in red diseases, myopia status has to be looked into. If you in monitoring of the patient, if there is decrease of 5 mu micron or more, optic nerve head assessment is not very much important parameter as far as this particular thing is concerned. OCT machine is concerned. We are most using this machine for a lamina cribrosa assessment. This is the diagram of a lamina cribrosa. The early sign of glaucoma damage. 102 is used. This is a scan of GPIPL thickness. It includes retinal nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. Basically, we are assessing the ganglion cell layer and the inner plexiform layer. These are the diagrammatic representation. Map is color coded. Those which have a thicker region are displayed in yellow and orange. Thinner regions are depicted in blue and green. We are all aware the M cells are present in the outer part of the macula. P cells, which are parvo cells, are located more.
Can you conclude, sir? Dr. Parvez, can you conclude?
Okay, just one more slide. I'll conclude. Just one. Just one slide. That is the pitfall of this particular machine. The automatic demarcation of the optic border may not be incorporated. Poor quality of images do come, uncooperative patient come, expensive instrumentation are few of the disadvantages of this machine. Thank you, sir, for giving me this amount of time.
Thank you, sir. Our next speaker is our 2020 hero, Dr. Rakesh, and he will take us through the step-by-step trabeculectomy. Dr. Rakesh.
Yes, sir. Parvez, sir, you actually you stop the sharing the screen, please.
Kya cheez? Sorry. Sorry, very sorry.
It's done. Dr. Rakesh, go ahead.
Yes. So today, actually, good morning to all, especially Nichlani sir and Dr. V.K. Jain sir, Alok sir, and Pratik Vyas sir, US Tiwari sir, to giving the opportunity, and all PSS team. So I am going to demonstrate how to do the trabeculectomy. So I always follow the standard trabeculectomy. So I'm going to slightly brief about the trabeculectomy. So the Sugar and Keynes Act 1968 actually demonstrate the trabeculectomy. It is the creation of the fistula with partial thickness cleft at the limbus, which allow the communication between the antechamber and some conjunctival space. So be bypassing the trabecular mesper and Slam's canal, and this connecting the channel, which aqueous is drained steadily, leading to the intraocular pressure is reduced. And this technique is appropriate for the patient to reduce the IOP.
Your video is not running.
Yes, I'm just running the video. I just demonstrate, and then I running. The video is slightly short, so I going to slightly demonstrate before the video.
Please go ahead. Please go ahead.
So the long-term success technique is slightly actually limited due to the chance of the complications slightly higher. Most common complications the fibrosis of the bleb area, and other complications like the hypotenuse, maculopathy, and infection, hemorrhages, and endophthalmitis. So when actually the IOP, when you do the trabeculectomy, is always when the IOP is not controlled by the non-surgical means, like by the lasers or any lasers, any medications, or when the patient are intolerant or in compliance to the medical therapy, and when the patient come with the advanced video field effect, and with multiple drug therapy or advanced glaucoma, like in the NTG requires much lower IOP with glaucoma, and sometimes when working in the high volume centers, so where the patient follow-up and compliance is very low. So this is the first line therapy, actually surgery to drop tree light, and sometimes the patient is with field patient. So you can choose this surgery. And sometimes the patient is come with the neovascularization or some proliferative diabetic retinopathy. So in this condition, this surgery is contraindicated. So initially, the preoperative evaluation is very must, and the counseling is very important. I always say the patient, this surgery is I'm going to do the surgery to preserve the vision, not to improve it. So जैसे हम कहते हैं कि भाई नस सूख गई है, इसमें नजर आने की गारंटी नहीं. So, and also talk about the follow-ups and some complications and some other. So now I am going to demonstrate my video. So I always prefer the peripulvar block, and I always check any scarring or thickness of the conjunctiva before the surgery. So, and then I take traction suture, and sometimes I take the rectus braided suture, and then you take this traction suture, and after that we are the convex-based conjunctival plate made. It is about 6 to 7 mm, and then the vascular seizure is always undermined in the conjunctiva up to the 7 mm, up to 7 to 8 mm, and carefully dissect the conjunctiva near the rectus muscle. And after that we always do the slightly painful quarterly, is the bleeding vessels quarteri. After that, we slightly retract the tenon capsule, and then apply the mitomycin C. It is about 0.4 to 0.4 millimeter per ml, or sometimes 0.2. And then thorowash is done with the help of it is about 30 ml. And then I map that I always make a 4 by 4 mm triangle flap. It should be partial thickness. With the help of 15 number, I make a incision initially slightly superficial, sometimes superficial, and you can do again, make it slightly deeper. It should be partial thickness. And after after that, we actually do the paracentesis, and then put some pilocarpine injection to constrict the pupil, and then put the visco to tighten the chamber, deepen the chamber first, and then remove before actually deepen the chamber, remove the thorowash done. After the lamidal dissection is very easy with the help of the crescent. Initially, we actually lift the apex part, and then with the help of the crescent, it is advanced up to the cornea. It is about 1 mm. And then see the sclerocorneal junction is here, and then I incise it. It is just entering the antechamber just 1 mm away from this scleral junction, and then cut with the help of Kelly's sponge. This is about 1 into 1 mm. The Kelly pen size is about 0.5 mm. And then after that, we deposit the iris and then we cut with the help of debakers or Wanasiria. So I gently hold the iris tissue, and then the other hand we can cut this, and you can see the aqueous come out, and then clean up all pigments before and deposit it and put the patency of sclerostomy with the help of air or with the help of saline. And then after that we see the chamber actually maintained is not. So then after that we put two actually in the arm of the triangle flap, we put the 10-0 nylon sutured with the help of two suture. Give the first two suture, and then after that we titrate. So it should be suture should be always buried every time, and then chamber after that. With the help of the saline, you can titrate the antechamber. Is actually sometimes the antechamber, even after putting the two suture, and antechamber becomes shallow. So you can put the 3 suture, no problem. This should be buried, and then after that we check the chamber is maintained, and then there the chamber is become slightly deep, and then after that we can put the releasable suture or 2 or 3 two releasable suture, or sometimes you can put the two releasable suture, one inside and one is at the apical part and the apical part. So after the actually tighten this suture, and then after that we always put some saline, and then always check it if it is sliding or not, and then we put the 2 conjunctival bean shaped suture to tighten the conjunctival flap, and then it should be watertight. Sometimes the actually aqueous leakage from the center. You can put the 1 suture at the center also. And then after putting the 2 suture, you can always check it with the help of fluorescein stain, or it is leaking or not. And then you can see after that we remove the air bubble and then see the AC form, and then see the bleb is forming. So the surgical result is keep in mind for the trabeculectomy, for the good surgical result. So you always keep in mind that the least handling is the best handling, and do the trabeculectomy when is required. And least trauma is increase the success rate, and failure of the first surgery reduce the success of subsequent surgery. Each step should be meticulously done and titrated. So do the close follow-up is very important in the trabeculectomy. When the complication occur, you always do treat the complication promptly, and there is any minor changes in your technique and can give the major difference in the trabecularity outcome. Thank you.
Thank you, Rakesh. How well you do your trabeculectomy? The next day and the next 15 days, be prepared for getting the surprises.
Yeah, thank you.
I request Dr. Vinita to take us through how to deal with hypotony and its management. Dr. Vinita Ramnani.
Thank you, sir. Good afternoon, everybody. I will be presenting how to deal hypotony and what are the causes. It can be defined statistically or clinically. Statistically, it is known when the IOP is less than 6.5 millimeter of mercury, which is more than 3 standard deviation below the normal. Or it could be called clinical hypotony when the IOP is so low that it results into the vision loss. There are various causes of uniocular or bilateral hypotony, but we will be dealing with hypotony which is secondary to glaucoma filtering surgery. It could be because of overfiltration or hyposecretion of aqueous humor. The overfiltration may be due to the loose sutures over the scleral flap or conjunctival flap, or it could be a blab leak. And the hyposecretion could be because of the ciliary shutdown due to the inflammation, ciliochoroidal detachment, formation of cyclodialysis cleft, or mitomycin C toxicity. It has a varied incidence of 1.3 to 18%. Few studies quoted up to 38%. The risk will be more in a male gender, myopic young patients in a primary surgery where we use antimetabolites. And it depends more on a surgical technique, that how do you put the conjunctival flaps, whether you put the scleral sutures 1 or 3, whether you use the releasable sutures. But to my contrary, the limbal-based conjunctival flap shows more hypotony because it has a cystic and avascular blab, which is accompanied with various epithelial microcysts, which gives the passage to the aqueous humor. And it could lead to the complication in the form of a corneal edema, secondary corneal decompensation, large astigmatism, cataract because of the iridocorneal touch, ciliochoroidal effusion leading to choroidal detachment, choroidal hemorrhage, and the dreaded one is a hypotonous maculopathy, which causes loss of vision due to cystoid macular edema or optic nerve edema. And ultimately, this eye can end up into a phthisis bulbi if it is not managed. Most of the time, it could be asymptomatic or it could have a decrease in the vision, especially so a distorted central vision, where the IOP is less than 6.5 millimeter of mercury, and most of the time they will show a hyperopic shift in the refraction with a characteristic fundal and the blab findings with the choroidal folds, with tortuosity of the vessels, with or without disc edema. UBM is rarely used to diagnose the hypotony, but it will give us the details beyond ciliary body, maybe the rotation or cyclodialysis cleft, which is missed on clinical examination. OCT helps in confirming the diagnosis and monitoring the outcome of our results. And sometimes the subtle wrinkling at chorioretinal folds we can miss, which can be visualized on OCT. FFA is rarely used, but it can show the alternate dark and light bands of hypo and hyperfluorescence, and also the leakage of the optic disc in acute phase. Indocyanine green is not being used much, but it gives a choroidal hypofluorescence when FFA is not showing anything. B-scan can be done to detect the presence of choroidal or retinal detachment, especially when the media is hazy because of the cataract. And they can show the thickening at the sclera and choroid. Management, basically, it depends upon the etiology, whether it is a blab leak or overfiltration, and its appropriate treatment will help us to treat it and prevent the vision loss. Majority of the cases are self-limiting and observation is the only treatment. 70% of the patients will have a hypotony for 2 weeks and then eventually they subside. In a one review of 699 trabeculectomy performed with mitomycin C, only 9 developed hypotony, which requires a bleb revision. So the surgical treatment is not required in many of cases. And those who developed hypotonous maculopathy, they will have a 50% chances of losing the vision permanently. So we have to treat immediately if there is a hypotonous maculopathy. The conservative management, which is required in a case of blab leak, is use of aqueous suppressants, the beta blocker and acetazolamide, which will reduce the egress of aqueous from the window and start healing and epithelializing. Then we can put a pressure patch or a bandage contact lens. It will also promote the healing and prevent the leaking. We can use the cyanoacrylate glue to prevent the leakage. Prophylactically, we should give the antibiotics, otherwise there is a risk of blebitis. Hypotony and uveitis go hand in hand, so sometimes we have to give a vigorous corticosteroid to prevent the ciliary body shutdown and increasing the hypotony. And cycloplasics play a very good role. Maybe atropine can be used to activate the ciliary, relax the ciliary body. If we have to do a surgical management. If our conservative management fail, then we can advance the conjunctiva without handling our blab. We can do a conjunctival grafting or amniotic membrane grafting, But if the sclera is involved, we have to do a scleral patching or pericardium along with it. So this is the treatment for the bleb leak. But if it is an overfiltering bleb, then we have to quickly taper down our steroids so that we can induce inflammation. We can reform anterior chamber with the help of air, but the air usually leaks in 24 hours. So we can use viscoelastic or C3, F8 or SF6 gases. Where we can rarely use the laser or diathermy or cryo to stimulate the inflammation at the site of the bleb to avoid the overfiltration. The best is to inject the autologous blood, but care has to be taken that it should not aggress into the anterior chamber and can give hypema. One can put a compression suture in the manner shown here vertically or horizontally, but it is rarely required, especially if it is very large cystic bleb which is overfiltering. We can apply compression sutures like this. Bleb revision is rarely required. We can put a transconjunctival flap sutures also if the scleral flaps are being opened up. Or we can do a bleb revision and put the sutures again depending upon the hypotony situation. And very rarely we have to excise the large big bleb and we can cover it with the tenons and conjunctiva. So basically it is just the etiology. You diagnose the etiology and give the treatment, must be conservative and then followed by surgical. But sometimes the hypotony is so strong that we need to do a vitrectomy rarely with an ILM peeling to avoid the vision loss, especially in one-eyed patient, or we can put an heavy liquid into the posterior chamber to avoid the hypotonous maculopathy. Prevention is always better, so we should use judicially the antimetabolites, especially the myopic and young patients. We have to be very careful. Nowadays, we are using the lesser doses of 0.01 or 0.02 milligram. We can even reduce the timings to 1 to 2 minutes only, and care should be taken not to touch the conjunctiva with this antimetabolites to avoid the bleb leak. And proper suturing is very important. One should avoid the bleb, one should avoid the buttonholing of conjunctiva and use the releasable sutures and release them judicially. Multiple scleral sutures can be used, otherwise it will give excessive filtration. As Dr. Shakya said, we can put 3 sutures. There is no compulsion that we have to put only 1 suture. And we can incorporate tenons also if we feel that it is leaking, and timely laser suturolysis will prevent the hypotony. Prognosis is usually good if it detects.
Can you conclude, Vinita?
So to conclude, if it is in hypotony with a flat anterior chamber of grade 1 and 2, we can put cycloplasic and pattern bandage and give viscoelastic. But if it is grade 3, directly viscoelastic can be injected and go for a resuturing. And the ideal time and the ideal type of the surgery has to be individualized depending upon the hypotony and amount of glaucomatous damage, vision of that eye, and the status of other eye. Thank you so much for giving me this opportunity and patient listening.
Thank you, Anita. We have a few minutes for discussion. Vijay, how much time do
we carry on for 10-15 minutes, sir? We can extend this patient for 10-15 minutes.
Yeah, we have a galaxy of panelists and chairpersons. If each one of you can take one topic starting from maybe the Applanation tonometry and give your sort of take-home comment to a comprehensive ophthalmologist. Professor Tiwari, we can start with.
Maybe am I audible? Dr.
Yes,
Adi?
you are. Yes, you are.
Great. Maybe a one-liner for each of the presentation, whatever I could collect, whatever I could recollect now. About the sterilization of the Applanation tonometry, using the
पैनलिस्ट होंगे ना जिनको पूछा.
Yes, go ahead, please.
Yeah. So using the isotropy alcohol just prior to the Applanation tonometry may not be a very good idea. Maybe you can use it and put it there for a while. For in between, yes, a weak solution or a sodium hypochlorite solution or a Deccan solution is a good idea. Now, as far as the last talk, I think the key is to use the atropine eye drops on the table itself. So whenever the trabeculectomy is being performed, do not forget to put a drop of the atropine. नया अभी ताजा खोला हुआ atropine use करना है, and just put one drop. This will take care of the shallowing of the anterior chamber. Most of the times it will not. And if it happens again, use atropine, number one. And in most of the cases, a cascade of the events following the shallowing of the anterior chamber, a cascade of events occur leading to the choroidal detachment. So if there are choroidals, maybe you will use steroids. So that is what is important. As far as the gonioscopy, I think the key structure that is to be remembered, this session, I believe, is for the general ophthalmologists who want to do glaucoma practice also. So the key for the gonioscopy as a beginner is the trabecular meshwork. Now, if you can visualize trabecular meshwork all around 360 degree, the angle is open because this is posterior pigmented TM which is functional, so you can be safe. If you can't see the posterior pigmented trabecular meshwork, then you are dealing with a shallow anterior chamber, and the rest of the details have already been elaborated by the presenter. About anything else, Dr. Aditya, you would like to have opinion from the others also?
Dr. Aditya Agarwal sir, you are mute.
You are mute.
Sorry, do we see Dr. Pradeep here?
Yeah, very much.
Yeah, Pradeep. So welcome, Pradeep, to your take-home comments and maybe on something you picked up from the talks or whatever.
You want me to discuss each talk?
Pradeep, you just a quick, because we don't have a lot of time, just a few.
Just an overview about all the talks in a time. Yes, the Goldman Applanation tonometry is the gold standard. Everyone should start practicing Goldman Applanation tonometry if we are not doing so. It's very reliable, authentic, and the lecturer has already covered most of the things related to that. If you do not have access to the Goldman Applanation tonometry, then probably you may get away with the Short's tonometry as well. But still, I would insist upon that every one of us has a slit lamp, so they should start practicing the Goldman Applanation tonometry, and it's not that expensive as well. The best way of sterilizing the bioprism is just to wash with the soap and water. If you can spend a couple of minutes for that. Otherwise, whatsoever she has covered is perfectly all right. Now, next comes to the corneal thickness. Yes, the corneal thickness is important in particularly patient with a low tension glaucoma. Otherwise, if the corneal thickness is high, say for example, the ocular hypertension trial says there's 555, but still it is 540, 550, 560. It does not make any sense that, we should discount the intraocular pressure on the basis of that. But the thinner cornea and the high intraocular pressure is highly relevant. Highly relevant. And obviously, if you compare the hysteresis versus the central corneal thickness, the central corneal thickness is more important as compared to the corneal hysteresis. Coming to the third talk regarding the gonioscopy, yes, the gonioscopy is the mandatory part of the glaucoma examination, and each one of us should start doing the gonioscopy of every patient. Either you suspect a glaucoma or the patient has a glaucoma, whether it's an open angle or a closed angle. Many a time you find lots of new findings while putting the gonioscope. You may see the angle recession, you may see a hyperpigmentation at the angle, you may find some pseudo-exfoliation which otherwise you may not visualize. So the gonioscopy is mandatory. The best gonioscope is the Sussman gonioscope, the 4-mirror indentation gonioscope. The fourth talk, Manish has beautifully covered in very brief about the perimetry. The perimetry and the optic now must go hand in hand. The stereoscopic examination of the optic nerve and the RNFL is very critical, and it must correlate with the perimetric finding. Then only you can diagnose the glaucoma. Regarding the OCT, yes, the OCT is one of the important tool in our armamentarium, but it's not a gold standard. If you do not have access to the OCT, don't regret. You can find everything. You can pick up the disc hemorrhage, you can pick up the splinter RNFL defect even by doing the good clinical examination. Related to the trabeculectomy talk, yes, the Rakesh is a wonderful surgeon, and whatsoever he said and he has shown in a video is very correct. The only difference, some of us prefer to do the fornix-based conjunctival flap, and some of us prefer the limbal-based. I still use the limbal-based conjunctival flap, and mostly I uses the mitomycin C in all my patients, except who has a high myopia, red myopia. And related to the complication of the trabeculectomy, yes, Vinita has covered most of the things, including Dr. U.S. Tiwari has also shown some, thought on that. Yes, in my opinion, the atropine is must, but the atropine is good to prevent the aqueous misdirection. If you are doing a trabeculectomy in a patient with the angle closer diseased, then you must put the atropine at the conclusion of the surgery. Okay, otherwise, for the other secondary glaucomas and the primary open angle glaucoma, that's okay. It depends on the surgeon's discretion. Thank you very much.
Thank you, Pradeep. Excellent suggestions for a comprehensive ophthalmologist. Girish, just give your expert comment.
Yes, I do agree with each and every line told by Dr. Pradeep Vyas. But I also prefer to use atropine in all the cases operated for trabeculectomy, because it definitely prevents a aqueous misdirection and the shallow chamber post-operatively.
Also, sir, it puts the iris lens diaphragm back, so it deepens the chamber. Sometimes, as soon as we make the iridectomy and make the deep sclerectomy, the AC is very shallow. So at that time, the using of cycloplegics puts the iris lens diaphragm backward, and it also deepens the chamber. So it's beneficial.
That's right.
Do we have Yogen on the panel here? Yogen, would you like to add anything? Saroj?
Yes, sir.
Do you want to add anything, or do you want to have any comment on the...
Regarding gonioscopy, I would like to add, especially for the beginners, it requires a lot of practice. So I advise all my students to buy the gonioscope at the beginning of their residency and start doing gonioscopy. And to them, I advise to buy a Goldman gonioscope instead of the Postner or the Sussman, because that stabilizes the eye and they can do it in a better way. And to start identifying the structures. So I advise them to do one gonioscopy at least daily and try to see how the angle looks in various conditions, like in young patients and in older patients, in aphakic eyes, in pseudophakic eyes, in exfoliation also. So gonioscopy basically requires a lot of practice before we diagnose pathology in the angle. And second is to do disc evaluation with the 78D lens, slit by microscopy, to see a detailed stereoscopic view of the disc, and do a red-free disc evaluation also to see the early retinal fibrillary defects. So beginners, these two are very important, and Applanation tonometry.
I think that makes sense, Dr. Aditya. Because if you use Sussman, it's a good lens, no doubt, but it will artifactually open up. So you may not be able to pick up those oppositional closures, which you could otherwise pick up by the indirect gonio lenses. So maybe you should do both. You should do indirect as well as the Sussman type.
I totally agree with you. And the few gonio lenses give you better magnification, so the identification of the structure is very easy. Pankaj, do you want to add anything? Dr. Pankaj Chaudhary?
Sir, all the things are covered, but for my residents, the beginners, what I want to say is, whenever they are diagnosed glaucoma, it is very important to do all the things hand in hand rather than doing one thing in a day. The perimetry is the most important. What they are doing is, whenever they are doing perimetry, they must go through what has been discussed, that reliability should be there. But first printout should not be taken as the final. You must rule out all the errors and repeat it again so that he is also habitual of, and then correlate it with the 90-day finding of the disc and then do it.
Thank you.
What about, if permitted, Dr. Aditya,
Yeah.
A word about the utility of the short tonometry as mentioned by Dr. Pradeep Vyas. I think there is a point, because sometimes you are required to do a diurnal variation, and maybe it may not be practically possible to do a Applanation tonometry for these subjects. In these situations, also maybe there is a place for the short tonometry, and that should be still in our armamentarium.
Yeah, I totally agree with you. But as far as the gold standards are considered, I think we should also teach our younger generations to sort of stick to the gold standards only. Anything else? Any comments from the? Otherwise, we can hand over the stage to Vijay.
Any comment about releasable sutures in trabeculectomy surgery?
One has to have I take the apical suture as the releasable one, so that we have a better control on the early modulation of our bleb. And I think it should be learned by everybody and practiced by everybody. It does give us a additional tool to modulate our bleb in the early post-op period. Anything else anybody wants to add?
Sir, I have a comment for hypotony. So as madam mentioned, for hypotony management, yes, bandage contact lens do help. And bandage contact lens is also helpful in immediate post-operative because of the suture-related irritation, pricking sensations. So it takes care of the two things. If there is any undiagnosed leak, so it takes care of that, and the pricking sensation, which is very common after immediate post-operative. And the other thing, which a new change I'm trying to do in my cases, is pre-injected mitomycins. So what it helps in two ways. The intra-op time is reduced with the pre-injected mitomycin C, and the bleb is quite away from the limbus, and it's quite diffuse. So I have done few cases with pre-injected mitomycin C, and the hypotony is also less, and the bleb is quite away from the limbus.
By pre-injected, you means you elevate the bleb by injecting mitomycin and then start dissecting it. Am I right?
Yeah. I around half an hour before putting paracaine and betadine drops, then we inject mitomycin around 0.04%, 8 to 10 millimeter away from the limbus. And after half an hour, the patient is taken for in the OT, and then the surgery is done.
But you have no control over the action of the drug, and half an hour is a bit too longer period.
Yeah, 20 to 15-20 minutes after that you can take, and it's, sir, the pre-injected, it gives a very like the dose of mitomycin C is is fixed. Sometimes when you put the sponges, the exact dose doesn't goes to the bleb area. So when we inject the amount of mitomycin C is always the fixed what we have decided.
It's okay, but that has not yet become the order of the day, and we still follow the conventional technique of sponges. And we count them. Yeah, this is a food for the thought. That's right. There is a race actually going on between the leak and the fibrosis occurring. So unless the fibrosis occurs, the leak cannot be prevented. So I think let us address the cause of the shallowing of the anterior chamber. If there is a need, you can put additional sutures, you can do a bleb revision, and so on. So I think the underlying cause must be addressed, and the problem should be corrected.
Totally agree with you, Professor Tiwari. Vijay, do we have more time, or do we wind up?
Yes, I think it is better to wind up, sir.
Okay, so I would like to congratulate all the speakers, panelists, and the chairpersons. जैसे हिंदी में बोलते हैं गागर में सागर भरना, क्योंकि glaucoma is a subject which can go on for hours and hours. But I congratulate all the speakers for being very comprehensive, very practical, and finishing in time. Thank you so much. Really appreciate your participation. Thank you.
Thank you, Dr. Aditya Agarwal, sir, and the session officials for conducting this glaucoma session. Very useful for general ophthalmologists. Now I may call upon Dr. Parvez Siddiqui to have an honor to introduce the session officials for next session, that is biometry and IOL power calculation.
Thank you, sir. Thank you, sir. Am I audible?
Yes, yes, you are audible.
The chairperson for this session is Honorable Dr. S.C. Batalia, sir, Dr. B.K. Jain, sir, Dr. M.K. Ajwani, and Dr. Salil Kumar. The session will be have esteemed ophthalmologists as panelists, Dr. Navneet Saxena, Dr. Rachna Gupta, Dr. Vasudha Damle, Dr. M.K. Somani, and Dr. Sandeep Chaurasia. The session on biometry and IOL power calculation will be moderated by Dr. Gautam Parmar. Dr. Gautam Parmar, I hand over the session to you for this particular.
Yes, thank you. Thank you so much, Parvez sir. I would like to welcome you all in this session of biometry and IOL power calculation. So I welcome all our respected chairpersons, our esteemed panelists and speakers. So we know that cataract surgery nowadays is a kind of refractive surgery, and patients' expectations are going high and high. So we need to do a precise biometry to deliver those expectations. So to speak on that, we have a galaxy of speakers which will cover all the topics pertaining to this IOL power calculations. In this, the first one is Dr. Aditi Dubey. I would like to ask Dr. Aditi Dubey to please share her screen presentation. Aditi Dubey, are you there? Please share your screen. Dr.
Yes,
Aditi Dubey has 7 years of experience in ophthalmology. She did her Phacoemulsification training from the SNC Chitrakoot. Her field of interest is trauma, orbit and oculoplasty, ROP and anterior segment. She is currently working as associate professor at Gandhi Medical College, Bhopal. So over to you, Dr. Aditi.
So for the kind introduction, myself, Dr. Aditi Dubey, I'll be speaking on the basics of A-scan biometry. Under the headings of its introduction, principle, technical terminologies we need to know, how to operate a biometer, immersion and contact techniques of biometry, IOL power calculation, and when should we repeat it, and what are the possible sources of errors. So before going into the biometric thing, first we should know that there are various USG techniques that are used in ophthalmology. The A scan, the amplitude mode, B is the brightness mode, UBM is for anterior segment examination, and Doppler is for vascular blood flow examination. So one of the most important application of A scan is A scan biometry. Biometry means to measure the anatomical distances within the eye. It is very important for calculation along with the keratometric readings which represent the corneal curvature and is measured by the keratometer. The axial length is conventionally measured by A-scan ultrasonography, and apart from the axial length, A-scan also measures the anterior chamber depth, the lens thickness and the pachymetry. Coming to its principle, ultrasound means the sound waves which are inaudible to human ears. So high frequency sound waves of around 20 kilohertz are inaudible to human ears. And diagnostic ophthalmic ultrasound that we use is even much higher frequency, that is 7.5 to 12 megahertz. The frequency depends on the thickness of the crystal in the probe, and this frequency is directly proportional to the resolution and inversely proportional to the depth of penetration. So A-scan is based on two effects. The first is the piezoelectric effect and the second is the acoustic impedance. Piezoelectric effect means the input electrical impulses with the help of ultrasound transducer that is in the probe, that are the crystals, is converted into sound waves, and again these sound waves are collected back with the help of these crystals and are converted into electricity. And acoustic impedance means that when the sound waves travel from one media to another media, they are reflected because of the difference in the velocity between the two media. So whatever the sound that is reflected is known as echo, and greater is the difference in the velocity at the interface, stronger will be the echo. On this principle, our biometer is based. So before operating a biometer, we should know what are the parts of it. So it has a pulsar, it has a transducer, an amplifier, and the main display. The probe of the A-scan that we use usually has a fixation light, which is for easy fixation and for consulting the optical axis with the sound direction. The important terminologies we should know is the pulse. Pulse is the short wave of sound that is produced by the probe of the USG machine. Echo is the reflected back sound. Spikes are the electronic and proportionate display that we see on the screen of the biometer. And gain is the amplification factor, which help the weak echoes so that they can be displayed on the screen. So before starting, one should enter the patient's details so that the identification is maintained, the eye, whether right or left, a calibration check, then the modes, eye type, gain, and the gate should be adjusted. The calibration check is taken care by the sensitivity dial, which is provided by the manufacturer. And there are two modes of examination, the manual mode and the automatic mode. In the manual mode, it is operator dependent, and the best echo pattern that we see, we freeze that with the help of the foot pedal. While in automatic mode, it is operated by the software algorithm inside the machine and is nowadays more commonly used because it is also useful in uncooperative patients. The eye type entry is very important because there is difference in the velocity of sound waves in different medias. So if we are missing on this part, then I'm sorry, we are not going to get the true axial length. We'll just have the apparent axial length. So eye type entry is very important for accurate distance management measurement. Then gain in cases of dense cataract or media opacity, as most of the sounds will be reflected, so there will be attenuation of the waves and weak signals will not be displayed on the screen. So in such situation, we need to increase the gain, and it should be increased in cases of dense cataract, high myopia, and in cases where there is highly refractile material inside the eye, like in pseudophakia, the gain should be decreased. Also, the gates are the pair of calipers. These are electronic calipers for measuring the distance between two given points. And in machine, they are usually automatically, they are placed where there will be the corneal spike, the lens spike, and the retinal and the scleral spike. And in between, the distance between these spikes is actually measured in form of millimeter. Now moving on to the actual examination technique, we have two techniques, the immersion technique and the contact technique. In immersion technique, the patient is in supine position, and after instilling the local anesthetic drop, we need to apply these scleral shells. Henson cells are more commonly used, where we fill or methylcellulose, and then the probe is inserted inside this shell. These shell, in these shells, due to the presence of saline in these shells, there is no direct contact of probe with the cornea. So we have a spike here, as in the spike chart we can see. We have a spike for the probe. Then we have two corneal spikes adjacent to each other. Then the anterior and the posterior lens surface spike, the retinal and the scleral spike, and posterior to that is the orbital tissue spike. It is more accurate method of biometry, and because there is no corneal indentation. But because it is cumbersome, it is quite less commonly used. The second technique is the contact technique, in which the patient is in the echo spikes. Here we get a single spike, you can see in the spike chart, that a single spike of the probe along with the cornea, then the anterior and the posterior lens surface, retina and sclera, and the echo-free area is the vitreous cavity. It is less accurate method because there are chances of corneal indentation. Always 5 or more scans should be taken, and average axial length should be taken rather than taking only one scan for axial length for a better accuracy. These information, the biometric information, are entered in the machine, and there are various softwares which are now available. The formulas that we were using earlier were the theoretical formulas, but they are obsolete now. The regression formulas are more commonly used, and these are based on the actual regression analysis of the post-operative results of the IOL implant. Most commonly used formula is SRK2. And depending on what is the axial length, for shorter eyes, we have Hoffer-Q. For average eyes, we have SRK-T or 2. For slightly longer eyes, we have Holiday. And for large eyes, like more than 26 mm, we usually use SRK-T formula. Then what are the possible sources of error we should know before performing a biometry, because this will help us to do an accurate examination. So corneal indentation, if it is a minimum corneal indentation of even a slight of 1 mm, just see what is the amount of post-operative refraction we are going to get. In an average eye, it can change the power of the IOL up to 2.5 diopter, in long eyes up to 1.7 diopter, and in short eyes even up to 3.75 diopter. The second most common source of error is the alignment. So how do we check for the alignment? Here we can see in the lower graph that the first spike is the probe or the corneal and the corneal spike. The second is the anterior lens, and the third is the posterior lens. So if there is difference between the anterior and the posterior lens spike more than 10%, then definitely your probe is misaligned. You need to recheck it, and this distance between the anterior and the posterior lens spike should not be more than 10%. Also, other sources of error like improper placement of gates, improper selection of settings, dense cataract, air bubble, and pathological states like staphyloma and PVD we can have erroneous axial length. The other thing that we need to take care of before going for a...
Please sum up. Will you please sum up, Dr. Aditi? Will you please?
So when we should repeat the A scan, it should be repeated if we are getting the axial length more than 24.5, if the difference between the two eyes is 0.3, and if the two consecutive measurement is more than 0.2. Also, it should correspond with the refraction. So the take-home message is to prevent post-operative refractive surprises, the clinical examination, pre-operative refraction, and a meticulous A scan. All the three findings should match. Thank you, MPSOS, for providing me this opportunity and your patience listening.
Thank you so much, Dr. Aditi, for comprehensively covering the topic. Now I would like to our next speaker, Dr. Meeta Joshi ma'am. She will be speaking on the newer generation IOL formulae and their implications. Dr. Meeta Joshi is currently working as Associate Professor, Community Ophthalmology, School of Excellence for Eye, MGM Medical College, Indore. She had 15 years of experience in the field, and her field of interest is anterior segment. So over to you, Dr. Meeta.
Unmute yourself, Dr. Meeta Joshi. Unmute yourself, please. Dr. Meeta, unmute yourself.
Yes, sir. Yes.
Go ahead.
Thank you, sir. At the outset, I'd like to take this opportunity to thank the Society and Chairman Scientific Committee for giving me this opportunity. And we'll look into the newer generation formulae for the implications and the uses which we have in our practice. IOL power optimization, as we all know, has been the holy grail since Sir Harold Ridley put in his first IOL all the days back. And what initially used to be done was the pre-cataractus refractive power of the patient was calculated, and it was added, plus 18 was added to this value to get the IOL power. But then, since then, we have moved a lot ahead. And what we now wish is that we stay within half a diopter of the desired refraction in more than 90% of our cases. So creating and improving these formulas is not just the job of the ophthalmologist now, but needs a whole team of physicists, mathematicians, and engineers to help us arrive at the conclusions. But since we being surgeons, what we would prefer is we would like to have a device wherein we would just put in all the values and get the results so that we don't have to work too hard for it. Like Dr. Aditi said, the IOL formulas are divided into various generations, and the standard equation which we used to have was the power is equal to A minus 0.9 K minus 2.5 L. What the K indicates is the average keratometric value in diopters, and the L is the axial length in millimeters. But since we have more data now, we keep on changing our values, and we now have an A constant which is more varied and which is dependent on the axial length and changes according to the change in axial length. Hoffer added the AC depth into these calculations, And once we realized that the axial length which was measured was not including the sclera, we added the retinal thickness axial length corrections. And since we use a multiple variety of topographers, the corneal refractive index for each of this machine varies, and we have to take this point also into consideration when we calculate the IOL power. One more modality which was introduced was the effective lens position or the postoperative IOL position, which is very important in determining the power of the IOL to be used. Because if you place the IOL in the sulcus or in the anterior chamber or in the posterior chamber in the bag, the power difference, the distance of the IOL or the position of the IOL would change the power so that the rays of light which are passing through the IOL would fall onto the retina. So again, two more variables are added, the anterior chamber depth and the lens thickness. And so we have a few more measurements added, like the corneal curvature, corneal diameter, lens thickness, and the AC depth. And again, these formulas were classified based on the methods which are used rather than the generations 1, 2, 3, 4. So you have the refraction-based, the regression and divergence-based formulae. And these again are divided on the basis of the variables which are used. The Holiday, the SRKT, the Hoffer-Q use only the 2 variables. Hegges has 3, Barrett uses 5, and Holiday uses 7. So now we have even the patient's age and the patient's gender added onto the calculations, in addition to the measurements which we take standard, that is the axial length and the keratometry. Ray tracing is used in Olsen and Oculix formulae, and artificial intelligence is used in the Hill RPF, the Kane, and the LEDA super formula. We have the Wong-Koch modification for axial length more than 25, and this is specially used for vitrectomized eyes, which would be discussed later in the presentations. So this is the standard chart which we have been used to referring, depending upon the axial length of the eye, which formula to be used. So you have the Hoffer-Q or the Hegges for the shorter eyes, the Holiday 2 for the longer ones, and the SRKT, which is the gold standard now for almost all the routine measurements which we take. But we have seen that the eye is not only the axial length. You have the anterior chamber depth, which has to be taken into account because of the effective lens position. And for that, you have to take the keratometry into account, because a steeper cornea or a flatter cornea would again change your AC depth measurements. So use the Hegges for short axial length and steep corneas, or long eyes with a flatter cornea. The Hoffer-Q is ideal for the short eyes with an average K, the Holiday for short eyes with a steep K, and the SRKT for the longer eyes with a flat or average K. We'll look at some of the formulas which can be accessed online. You have the Hill RBF, which you can go online and put in your calculations and just see what you get. So it is basically a radial basis function, like a neural network, and it takes multiple factors into consideration and to nonlinear relationships and gives you the calculations. What you basically need here is adding your date of birth of the patient and the gender of the patient. The rest of the things remain what you have, the 5 or 7 parameters which are used. And since this is optimized for a single machine or 1 or 2 type of lenses, it will keep on asking you the preferences and will keep on giving you warnings that you are not using the standard lensometer or the biometer for this, but you can still go ahead with your calculations with the machines with which you are versed with. And what it basically does is it gives you inbound or out of bound calculation. It is a self-validating program. So it will check whether the reading which it has given to you is correct or not. So the earlier versions had a data of around 3,400 eyes. So it would compare the values with these and tell you whether the answer it has given to you is correct or not, or whether it is in bounds or out of bounds. I won't say correct or not, but how reliable it is. And the newer version has a database of more than 12,000 eyes. So you have more accuracy with the prediction of the IOL power which you are calculating. Barrett's Universal 2 has the advantage that the optional lens thickness and white to white are optional features. So in case you don't have those features in your calculating machine, you can still go ahead and calculate the IOL power required. Again, it will give you the IOL power and the refraction which is predicted with the IOL power, and it has an inbuilt A constants depending upon the type of IOL which you use. And even if you don't use this IOL, you can just put in the standard 118.0 constant or the constant of the IOL which you are using. But then you'll have to put in the surgeon correction factors accordingly. Kane formula, again, it is a mix and match of the old and new, theoretical optics and regression and artificial intelligence. And it uses the simple constants which we have measured in the day-to-day life, so that you have the AL, keratometry, AC depth, and again lens thickness and CCT are optional. The EVO formula, again, these are all online calculators which can be used, and it can be used for refractive, post-refractive surgery patients also. The Ledal super formula, what it does is it takes the best of every formula. So you have the SRKT, the Hoffer-Q, Holiday with the Wong-Kok adjustment and the Hagees, and it takes in the account the axial length and corneal power of the patient which you have entered, and it will then use the formula which is appropriate and give you a result. So again, then which biometry? So immersion and OCT based both have their advantages and disadvantages. And you have to keep in mind that when you're switching from one to other, you have to just keep the constants varied accordingly. These are the equations which are used when you have your ultrasound biometry and you need to convert to optical coherence biometry readings. So you can use them and convert your readings accordingly.
Ma'am, your time is over. Please sum up.
Yeah. So these are the simple tips and tricks which are there. Always have two measurements. Use two different machines, especially for your keratometry data. And never dilate or applanate your patient prior to your measurements. Check measurements of both the eyes so that you can compare, and check the patient's refraction also. Have a standardized capsulorhexis. Validate your measurements. Spend time counseling the patient, especially when patients have short eyes or previous refractive surgeries. And don't just keep on doing what you've always done. Just don't stay in the rut ki nahi hum to SRK2 use karte hain to wahi karenge. Go for the other formulas. See which gives you better result. Thank you.
Thank you so much, ma'am. A very well covered topic. You covered nicely the all kind of new generation formulas and give briefing about them. So I would like to invite Dr. Abha. Ma'am, please ma'am share your screen. Dr. Abha is currently working as Associate Professor, GRMC Gwalior. She has 24 years of experience in the field. Her special area of interest is ocular trauma and anterior segment. Over to you, ma'am.
A very good afternoon from the city of music, Gwalior. I'm thankful to Scientific Committee for including me in this forum to discuss the basics in ophthalmology, biometry, and IOL formula calculations. Technical advances has given vision, hope, and courage to make dreams come true. Once the moon landing was a historical moment, and now the space agencies are trying to colonize Mars and promoting space tourism. Same way, once the ultrasound biometry was a historical moment, still it is being practiced, but now everybody is understanding this optical coherence tomography and newer biometrics formulas. Refractive, nowadays, it is not a simple cataract surgery, but it is called a refractive cataract surgeries because best surgical skills, evolved technologies have given advanced phaco machines, micro incisions, use of femto, premium IOLs. These all things have given excellent surgical outcome, and they have enhanced the visual experiences. But they have also increased the expectations on the part of patients, and this poses challenges to the operating surgeons. On top of that, post-LASIK surgeries having cataract is really a difficult scenario. So now we have optical biometries for axial length measurements. Ultrasound biometry was commonly used, as Dr. Aditi has nicely explained, but now we have IOL Master 500 in different optical biometries. IOL Master 500 was the first automated optical biometry device available for the clinical use because it is highly accurate, non-invasive, automated method. So this has become the gold method for using IOL power calculation. Its ease of use, accuracy, and reproducibility has made optical biometry gold standard for IOL power calculation. If we compare the ultrasound with the optical biometry, ultrasound is based, A-scan is based on the sound wave functioning. It measures along the anatomical or geometric axis. It measures only up to the internal limiting membrane. And assumptions for the retinal thickness has to be made, that is about 200 micron, but retinal thickness can vary from 160 to 400 micron. And as Dr. Aditi has nicely mentioned that in this we do corneal indentation. So there can be variation in the axial length measurement from 1 to 3 millimeter, 0.1 to 0.3 millimeter, and this can lead to a variation of dioptric power calculation to 1 to 3 diopters. Ultrasound gives us 0.1 millimeter accuracy in the power calculation. Next comes the better IOL power calculation methods. These are the optical biometry. This uses partially coherent light source of shorter wavelength. And this measure to the center of macula, that is the refractive or optical axis. Axial length is measured from the corneal epithelium to the Brooks membrane. So actual axial length is being measured. It's a type of non-contact method, so no question of indentation. So its accuracy is about 0.05. It is more accurate. We can understand that these newer optical biometers are like the newer Android phone. The older older mobile phones were like the ultrasound biometry or A-scan, but this newer Android, they have all the apps the same way. These newer optical biometers, they calculate axial length, keratometry, both anterior and posterior, anterior chamber depth, lens thickness, center corneal thickness, pupil size, and they also measure wide to wide distance. So all the things are being included in one machine itself. That's why the optical biometries are more being used nowadays because they're more accurate for measurement of axial length. Even in the pseudophakic, aphakic eyes, we can measure. Phakic IOLs, they also give good readings. Measurement is less affected by the type of IOL material which we are using. We can measure better optical axial lengths in myopic eyes with staphyloma in children. Silicone oil-filled eyes, no need for velocity conversion is required. It is free from the examiner's bias. Even in post-refractive surgery patient, it gives good results. Combined anterior segment imaging device and ocular biometry, both are given in this. So it has accuracy and reproducibility, faster scan speed, automated positioning system, and dynamic eye tracking. There are various technologies being used in this optical biometers. It can be partial coherence interferometry. It uses infrared light. IOL Master 500 is based on this technique. Another is optical low coherence reflectometry, OLCR. Low coherence infrared light, Lenstar, LS 900, Hawk Street, Aladdin Topcon, Galilei G6 Zymer is being based on this technology. The latest technology is swept source optical coherence tomography, SSOT. In this, on this technology, IOL Master 700, Ergos, and iStars, they are based. So we have various biometers nowadays available with us: IOL Master 500, 700, Lenstar, LS 900, iStar 900, Tommy, Ergos, Aladdin, multiple. A1 Scan, Galilei, G6 Professional. So there are all these various newer biometers are available with us. IOL Master 700 is the latest. IOL Master 500 was the older version, and now they have upgraded the technologies. So maximum have all these features. This is SSOT type of tech machine. It takes full length OCT image of the eye. There are about 2,000 scans performed per second. It identifies ocular geometry. Lens tilt and decentration, even this can be identified with this new machine. There are fewer refractive surprises. As doctors have mentioned, Dr. Gautam and Dr. Meeta has rightly mentioned that you need better IOL power calculation, exact, precise, to give good post-operative results. So there are fewer refractive surprise with this type of biometry. It always check fixation, foveal pit as being seen. Then it can also diagnose the macular pathologies, holes and ARMD. So we are on alert mode. If there is any retinal pathology, we can refer these patients to the retinal surgeons or retinal specialists. It is telecentric, distance dependent, independent. So even if your optometrists are performing, there are no bias in this. Even through the dense lens, because the IOL Master 500 has the limitations. You cannot perform in the dense and wide cataract. So you have to keep another machine with you. That is the older one, ultrasound A scan with you. But now with the IOL Master 700, it can go even through the dense cataract. So single machine is sufficient to do all the calculation. As Dr. Meeta has mentioned, you have to go for online various formulas. Now all these online formulas are also being included in this machine, like Higgins suits for the post-refractive eyes. It has inbuilt toric calculator, Barrett toric calculator. It can also detect so many anterior segment pathologies like this, detecting Descemet's detachment, iris cyst. It can tell you about the patency of York PI, even positioning of the crystalline lens or IOL. If there is any lenticular deformity, it can be detected, like lenticonus, type of cataract, positioning of your ICL. If there is any vitreous changes, scleral lens vaulting, even mebiography can be performed. Meibomian gland dysfunction can be seen with this. When the IOL master is performing first scan in the morning, it do self-calibration. It takes time is very small for doing the calculation. 45 to 1 minute for both the eyes. So in a busy setup, when there are many patients, this is a really boom. It's a non-touch technique, so free from indentation and all those criteria. And there is excellent inter-observer variation. There is no variation. So these are the various technologies and various machines which are having these technologies. More or less all the machines are same. There is very small variation. It depends which institute or which person is having which kind of machine with you. Thus, the goal of cataract surgery or any phakic IOL is sharp, clear vision without glasses. Outcomes are dependent on accurate biometry. Thus, to improve refractive outcomes, surgeons continue to strive. Surgeons are trying their best to improve their surgical skills, and they are doing so many practices. They're doing so many classes to improve wet labs. But industry is also providing a wide range of options. Thank you.
Thank you so much. Thank you so much, ma'am. Nicely covered and finished very well in the time. So thank you all. And you rightly said the new armamentarium having a lot of newer devices, newer optical biometers, which is certainly having advantages, especially in the complex eyes. So we'll discuss later at the end if time permits. Now I would like to invite our next speaker, Dr. Pradnya Sen, ma'am. She will be speaking on the IOL power calculations in the pediatric cataracts. Ma'am, are you there?
Yes, yes, I am here only.
I would like
Good
to
afternoon, everybody.
I would like to introduce Dr. Pradnya Sen, ma'am. She's a consultant and head of the Children Eye Care Center at Sadguru Netra Chikitsalaya, Chitrakoot. She's trained in pediatric ophthalmology at SNC Chitrakoot only, and she had experience of 15 years of experience in management of pediatric eye diseases and strabismus, having extensive experience of more than 5,000 pediatric cataract surgeries. Over to you, ma'am.
At the outset, I would like to thank scientific committee MPSOS for giving me this opportunity. So, emmetropic implant power calculation can be obtained from axial length measurement and tonometry. It is a very straightforward decision in adult eyes, but in children, unpredicted growth of the eye has to be considered. So IOL power calculation in children, especially in younger children, is always challenging. And a present option is selecting fixed IOL power for implantation into the eye that is still growing. So if you go for emmetropic power, there is always a risk of significant myopia at ocular maturity. And if you undercorrect, it can be hurdle in the battle against amblyopia. So we have to find out which is the ideal IOL power. So before this, I would like to tell you something like which formula you should use and which biometry. So the immersion biometry is always better than the contact biometry in children, as if you if in adults, if you get 0.1 mm of error in axial length measurement, it can give you error of 3 to 4 diopters in IOL power calculation. But if in children, if you get 0.1 mm of error in axial length, it can give you error of from 4 to 14 diopters in your IOL power calculation. So immersion biometry is better than contact biometry, and the different formulas, they have been used in children with variable result. And as per our experience, it is the SRKT which is the best, or which gives better results in shorter eyes, and for longer it is the Holado 2. So coming to ideal IOL power, it should be something which will cause least refractive error in adulthood. So that should anticipate the expected myopic shift, and you have to undercorrect. And one another should be the best to fight amblyopia. That is, initial hyperopia should be low enough to be corrected by glasses to facilitate compliance with amblyopia therapy. So when you go for IOL power calculation in pediatric cataract, one thing we start with the step-by-step approach by considering the age at the cataract surgery, and we have to undercorrect to compensate for expected myopic shift. There are two approaches. One is the Hans recommendation, another is the absolute value. According to the Hans recommendation, you have to undercorrect by 20% if child is less than 2 years of age, and if child is from 2 to 8 years, you have to undercorrect by 10%. This is more accurate. Another one is going with the absolute value, in which you consider the residual refraction along with the age, and this is more practical. We use Dahan's approach along with some additional factors such as status of the fellow eye. So always determine the refractive status of the fellow eye to minimize anisoconia. Next is the expected compliance. If you are expecting poor compliance, it is better to leave less refractive error so that you can deal with it with glasses, occlusion therapy, and follow. Next is the parents' refractive error. You have to specially look for high refractive error, especially myopia, because if the parents are myopic, we expect more myopic shift in child, and in such cases, we have to leave the child more hyperopic. Next is the IOL power. If the more the IOL power, more the undercorrection. So if say if it is a 50 diopters at 2 months of age, then we will undercorrect by 10. So we will implant a 40 diopter IOL power. And if the child at the same age 2 months, another child with 40 diopter, you will undercorrect only 8 and you will implant the 32 diopter. So it depends. If it's more the IOL power, more is the undercorrection. Next is the microphthalmia. In such eyes, target refraction may not be reached even with the highest available power. So in such eyes, highest available power should be chosen. These are some special situations like a traumatic cataract. So first we have to see whether we want to implant the IOL primarily or secondarily. In primary IOL power implantation means at the time of corneal tear repair. If you are thinking of, like in this case, if you are thinking of implanting the IOL power at the time of repair only, then it is always better to take the IOL power of the fellow eye and put that IOL in the traumatic eye, cataract eye. So, and if it is in the central corneal, if it is, sorry, if it's a peripheral corneal tear, then you can go for undercorrection. But if it's a central in which you are thinking that post-operative refraction will not be possible, then in such case, don't undercorrect. The same with the secondary IOL power, secondary implantation of the IOL. If you are thinking of the secondary implantation, if there is a corneal scarring and if you expect that there will be no, it is difficult to do refraction, then you will implant the same IOL power. And if you think that refraction is possible, then you will undercorrect. And in secondary IOL power cataract, you will take the same IOL power calculation. There are some cases in which there is a corneal scarring. In such cases, like ophthalmic cases, or in cases with the congenital corneal opacity, or in cases post PK, in which you think that there will be difficulty in post-operative refraction in such eyes, then don't go for undercorrection. So this is a case scenario 1, and in this this is an infant with bilateral cataract, and say it's a IOL power which has been calculated is plus 38 diopter. So in this case, we will go for 20% undercorrection. That means we will undercorrect by 7.6. So we will round it up to 8, and we will reduce 8 the IOL power, and we will implant the 30 diopter in such child. And you consider the same child, and when the parents are myopic, then instead of 8, we will undercorrect by 10. We will go for more undercorrection, and we will implant only 38 diopters in such child. This is another scenario. You can very well see this is a unilateral cataract in infant. So there are 3 possibilities, and you have to always consider the fellow eye refraction. So in this eye, there are 3 possibilities. One, the child may be emmetropic, hypermetropic, or myopic. Say again, if you take the 38 diopter is the IOL power in this eye, which is cataractus. So being infant, we will reduce 20%, and that will be the 8. And we expect somewhat 7 or 6 post-operative hypermetropic correction in this eye. And if you think that the fellow eye is emmetropic, then there will be anisoconia of more than 4 diopter. So in such case, we will, instead of going for 8, we will reduce 6, and we will implant 32 diopter IOL in this eye to reduce anisoconia. If the fellow eye is hypermetropic, then we say +2 or +4, then you can go for 8 diopter undercorrection. And if the fellow eye is myopic, -2, -4 or something, we have to go for less undercorrection, like 4 or 2 only, to reduce anisoconia.
Ma'am, please conclude your time.
Okay. Third one is a bilateral cataract, and in this you will 5-year-old, so 10% reduction, and you will implant the 21.5 diopter case IOL. This is a 7-year-old child, and you can very well see this is a late presentation, so we expect no compliance or less compliance, so there will be no undercorrection in such eyes. So always target post-operative undercorrection till 8 years of age by considering age along with status of the fellow eye, expected compliance, and parents' refractive error. Thank you.
Thank you so much, ma'am. Nicely covered topic. I think these are the special cases which needs special correction also. So now I would like to invite our next speaker, Dr. Ganesh Pillai, sir. He will be speaking on the IOL power calculation in the silicon filled eye. Sir, are you there? Please share your screen. Dr. Ganesh Pillai did his MBBS and post-graduation from the very prestigious AIMS. He did MRCS from the Edinburgh also, ex-senior residence from the AIMS also. He is currently medical director at ASG Hospital, Bhopal. So over to you, sir.
Thank you so much, AI MPSOS, for giving me this opportunity to speak on a very important topic after a pediatric cataract discussion. As pediatric cataract discussed by Dr. Pradya ma'am, it's an enigma in itself, and we have to keep in mind many things before putting an IOL power in. I'm Dr. Ganesh Pillai, and I'll be discussing about IOL power calculation in a silicon oil-filled eye. I have no financial interest. As we all know that in the silicon-filled eye, nuclear sclerosis is the most common thing that we see often. And posterior subcapsular cataract, probably the second most common. Other things that we also see is a posterior capsular plaque, posterior capsular rupture, and emulsification of silicone oil in the anterior chamber. There are various challenges that we face during cataract surgery in a silicon-filled eye. The most common being IOL power calculation, others being silicone oil in anterior chamber, zonular instability, capsulorhexis difficulty due to an upward thrust, pre-existing posterior capsular rupture or a plaque being present, large fluctuations in the anterior chamber depth, poor flow due to an intumescent cataract. So these are the challenges that we face. Now this is an ultrasound of an eye, of an oil-filled eye, and the same eye without the oil fill. You can see the difference in the globe size over here. The first picture, you can see the axial length being measured by ultrasound in the oil-filled eye being 31.50. In the other, the same eye after the oil has been removed, the axial length comes out to be 22.75. Why this difference in axial length? So a study was done to see what is the difference between axial length before the oil removal and after the oil removal, and it was found that the ratio comes out to be 0.7. But why this ratio of 0.7? So need to go to the basic, which has already been discussed. But the important factors over here is the axial length measured is a function of velocity and the time. So what is the velocity in different medias is something that we need to know. So the velocity in aqueous, vitreous, and also an aphakic eye is 1532 meters per second. In a normal lens, it's 1641 meters per second. In an intraocular orbital soft tissue as well as blood, it is 1550 meters per second. Cornea, it is 1604 meters per second. And if we see the average velocity in a phakic eye, it comes out to be 1550 meters per second in a myopic eye, and a little more in a hyperopic eye, that is 1560 meters per second. So what is the difference between the vitreous and the silicone oil? Basically, the vitreous chamber depth is something that we need to accurately measure to get a reliable breach in the posterior capsule. A prior consent for refractive surprises should always be taken, because even after so many things, you may still have a surprise. So good IOL power calculation can give you a result which has a satisfying outcome eventually. I would like to sum up this.
Thank you.
Thank you so much.
Thank you so much, Dr. Ganesh. A nicely covered topic, and you rightly said that there is role of proper counseling and setting the targets, because these silicon oil-filled eyes definitely produce some errors in the IOL power calculation. So considering them is very important here. Our next speakers, Dr. Prem Chandani sir and Dr. Dolly Chandra ma'am, are not available, unfortunately, because of their some personal reasons. So I would like to call upon Dr. Shreya Thatte ma'am for her talk. She will be speaking on the role of anterior segment OCT in IOL power calculations. Dr. Shreya Thatte ma'am is professor and head of the Department of Ophthalmology at Sri Aurobindo Medical College and Postgraduate Institute of Ophthalmology. She's having vast experience of 25 years of experience in the field of ophthalmology and
so this anterior segment OCT can give you qualitative as well as the quantitative assessment. In qualitative assessment, one needs to identify the very important landmark, and that is the scleral spur. And scleral spur is nothing but the inward projection of the sclera at the junction between the inner sclera and corneal curvature. Many people, they use the opposition between the iris and inner corneal scleral wall, but we have to remember this. Sometimes this oppositional closure cannot be so accurate as shown in the gonioscopy. In quantitative assessment, again, the important landmark is the scleral spur, and many machines, they have inbuilt software. So they calculate the distance from this scleral spur, and we can measure the exact accurate parameters. And what parameters we can see? These are the parameters: angle opening distance, angle recess area, trabecular space area. As you are seeing here, this is the angle opening distance, this is the trabecular space area, and this whole area is the angle recess area. What are the structures you can see in anterior segment OCT? From conjunctiva, cornea, anterior chamber, iris, lens, up to the sclera, you can see in anterior segment OCT. So now let us talk about the anterior segment OCT in cataract surgery, how it helps. It helps in calculation of the IOL power. You can evaluate lens, anterior chamber, angle structures, intraoperative use, and even post-operative management of complications. So we will talk about one by one. In IOL power calculation, already said by the main speakers that for the correct IOL power calculation, corneal power is a major role. And this anterior segment OCT has high repeatability and reproducibility and reliability also. Even this is very useful post-refractive surgery cases where there is always challenge of predicting or precising to get the precise IOL power because of the index of refraction, instrument error, or even the IOL formula error. In such situation, we require accurate measurement of corneal power, axial length, corneal keratometry, and effective lens position after surgery, which already explained by the previous speakers. Why we have these issues in post-refractive surgery patients? Because of the patient's expectations, high expectations, and they don't want to depend on the spectacles post-cataract surgery. And there is always reduction in the accuracy of conventional IOL power calculation formulas. How to deal with these issues? There are many innovative IOL power formulas are available, which are already discussed. ASOCT plays here major role that it highly repeatable anterior and posterior corneal curvature measures and then calculates the net corneal power, and which is very important for the correct IOL power calculation. Even in patients where their prior data of the refractive surgery is not available, here also anterior segment OCT is very useful. There are fluctuations with different IOL formulas in IOL power. So one can go for the ACRS online refractive, post-refractive IOL calculator. There are other formulas also. And with this, you can get very minimal deviation from the target refraction, which is not very large. So the patient can accept this type of target refraction post-operatively. Another important thing which we can measure is the anterior chamber depth. And this is again important for the IOL power calculation, which is already mentioned by the previous speakers. And this is also important for the phakic IOL insertion. while measuring the corneal thickness, that is corneal pachymetry, we have to see when we are seeing the cross section of the anterior segment image on the corneal meridian, we can see a white central vertical flare, and this is we have to achieve this to get the correct pachymetry of the cornea. And this corneal reflex artifact is very important. One needs to achieve when you are measuring the corneal thickness. How we can use intraoperatively? This is very helpful in all the critical steps. In assessment of the corneal wound of architecture, position of the IOL, wound gapping, even whether you are doing adequate stromal hydration or not, then you can even do check while doing the trenching, the adequate depth of the trenching is not how much depth you are going, and and for there is always challenge and actually seeing the incision size, not incision angle, incision length. Even posterior wound gap is there or not, so that you can correct if there is descendant membrane detachment while doing the side port entry or main wound entry, or posterior wound retraction is there or not. All these things you can see in clear corneal incision by intraoperative anterior segment OCT. So here you can see there is mild descendant detachment during the intraoperative, here endothelial misalignment, and here there is epithelial misalignment. So you can correct during the surgery itself. Post-operative also you can see the single plane incision, biplanar incision, even triplanar incision. You can see small detachment of the stripping of the descendant membrane. Here there is wound gapping, posterior wound gapping, and here there is wound retraction. This also you can clear while doing surgery. Post-operative also, this is very important in detecting any incision-related, clear corneal incision-related problem, as we have seen during the intraoperative. And apart from this, you can evaluate the location and stability of the IOL, and you can diagnose the capsular block syndrome after cataract surgery. So this is various grades of the descendant membrane detachment post-operatively, and you can see correlated with the clinically. Sometimes clinically it may not be visible because of the edema and small amount of the descendant membrane detachment, but with ASOCT you can localize and detect this small descendant membrane detachment. Capsular block syndrome is another complication, though it is very rare, but you can see clearly on ASOCT, though short scan or in the long scan where you can see entire overview, you can see there is a distance between the posterior capsule and the IOL, and it is filled with the milky white liquid, and sometimes it is the clear fluid. This clinically also we can correlate. So there is increased distance between the IOL and the posterior capsule. Even post-JAG also you can see clearly the gap between the posterior capsule, the distance between the IOL. This is the IOL margin, and the posterior capsule is reduced. There is rolled up capsular lens capsule. So you can clearly visualize that. In position of IOL, as here it is seen, one haptic is broken, which you can see. There is no haptic image is there. Posterior capsule is rolled up. There is a rupture in the posterior capsule, and zonules are also ruptured. So you can very well clearly see on the anterior segment. Yes. So in conclusion, we can say this is the non-invasive high-resolution imaging technique which can provide very clinical findings for the cornea, lens, and anterior chamber. And in cataract-related problems, you can visualize lens capsule evaluation. You can evaluate your clear corneal incision, and it helps in the post-refractive IOL power calculation. If you have time, I can quickly talk about the other uses of the anterior segment OCT. You can measure the corneal thickness post corneal surgeries, or even you can measure the anterior chamber depth, which already mentioned. You can even in cases with the heterochromic iridocyclitis, you can see the iris atrophic patch, which you can correlate and within the slit lamp photograph. There is keratic precipitates are also very well visualized. Even the plaque of the posterior capsular opacity. This was the case of the Fuchs heterochromic iridocyclitis. In glaucoma, it has many uses, and it can be compared with gonioscopy. Here you can see that there is angle closure glaucoma, here patent iridectomy, and in this case, the iridectomy is blocked, failed iridectomy is there. You can visualize the depth of corneal scar. We have already seen in clear corneal incision also. In this set, you can very well establish the slip disc. This is the longer scan, and this is the shorter scan. You can see in details of this. Even in the scleral contact lens fitting also, this is very well useful. In cases with the iris cyst or tumors also, you can visualize their site and extension. And same with ocular surface tumor, you can see the extension of the tumor, whether it is in the cornea, sclera, or deeper structure, angle structures, and accordingly you can plan for the post-operative plan can be done. So that was all about the anterior segment OCT. I think previous speakers have already mentioned many things for the biometry. And thank you, Gautam, for the
Thank you so much, ma'am, for providing such a good insight in the field. And I think anterior segment OCT is an inbuilt part of the the same principle is used for the latest the stage is open for all panelists and esteemed chairpersons to comment and share their experience as well as question answer. So
may I speak, Dr. Gautam?
Yes, sure, ma'am.
Two things I would like to say here. As we have already talked, anatomical axial length and optical axial length. So anatomical axial length we are measuring with our ultrasound biometers, and optical one with optical biometers. And as Abha has nicely said, that there is a difference of 200 microns, which amounts to 0.2 millimeter. So this point has to be taken into the account, because many of the ophthalmologists, they are not having optical biometers, and I think 80 to 90% are still using ultrasound one. So if you are using higher generation formulas with, say, for example, Beres 2, with your readings of immersion scan, then I think this point should be kept into consideration, because every machine has got its own inbuilt formula. Now, we want to use Barrett's formula with immersion scan, so this difference should be kept in mind. And again, there is lots of importance is given to ELM, so this point is important. And secondly, again, third generation and fourth generation formulas, as Mita has already said, again, if you are using immersion scans or ultrasounds, in that case, if we use third generation formulas judiciously, as rightly explained by Mita, that will be better, because most of us are again not having these expensive biometers, and this is how we can utilize our ultrasounds or immersion scans in the best possible manner. Thank you, Gautam.
Thank you.
This
Thank
is my
you.
opinion. Yeah.
Very good comments. I think the newer optical biometers having certain customizations also. So we should keep the key thing is that we should keep our own data, and we can customize our own do customization according to them our own data.
Yeah, because anterior chamber depth and lens thickness we are already getting. So this can always be applied to Beres 2 formula to get better results.
Dr. Gautam, I would like to add something.
Yes, sure, sir.
First of all the speakers, they covered their topics very excellently. Very, very good presentations by all the speakers. Now, as regarding Dr. Vasudha was just mentioning about the third and fourth generation formulas, this Barrett's Universal 2 is quite standard, and it gives good results. Now, we have also this AS CRS calculators, as well as Asia Pacific Association has its own calculator. We can refer to that in cases of challenges. Now, the real challenges comes in cases of corneal ectasias and corneal keratoconus and pediatric eyes. The pediatric eyes, Dr. Abha had covered very nicely, but still is very tricky in such cases. And regarding long eyes, I would like to add that holiday one with a WK adjustment is quite good. It gives good results, but still the process is going on, and we are still to overcome this small errors which comes up in tricky cases. And thirdly, I would like to add the real problem is also in cases of refractive surgeries and patients who have undergone refractive surgeries and now you have to implant a lens. So now most of the authors, they say that you do a central 3 millimeter corneal measurement for such cases, and you can combine this with the third and fourth generation formulas, Leda's formula or SRKT. So this is all what I want to just add to the things. But congratulations to all the speakers, and congratulations to Dr. Gautam for conducting this beautiful session. Thank you.
Thank you so much, sir. Such a beautiful comment, and I think I can comment on the like I have few experience regarding the post RK IOL bar calculation, and I prefer to use online formula, that is ASCRS. We have Pentacam device which gives us PVR SF. That means a selected zone we can get a true corneal power both from the anterior as well as posterior, so it covers nicely, and we put those findings in the online ASCRS formula. And but here I just
You're not audible, sir.
Because
you're not audible.
And I prefer to. Am I audible to all? Okay.
Your voice is breaking, sir.
Okay.
That is somewhere some sort of a audio-visual problem due to.
I prefer to keep them on myopic side, so I always keep target of say -1, and if I get -1 diopter of post of refraction, then it is good accuracy for me. So I keep the bar little higher.
Very good.
Especially such.
Dr. Gautam?
Yes, Dr. Jyoti Saxena, please go ahead.
Good evening, everyone. After rather good afternoon. First of all, congratulations to all the speakers. Have wonderfully told about the biometry. Abha, Meeta, Shreya, Aditi, Pragya from Citragud. Everyone did a good job. Just to share my experiences about the biometry. Of course, we all know the biometry that is optical is much better than the ultrasonic. But being working in a medical college or in a setup like this, we don't have access to the IOL master all the time. Most of us are working in a government college. We don't have access to the IOL master all the time. So that's why what my experience and share is that in rare cases where you get a like for example RK, post RK, silicone-filled, and the high refractive error, in those situations you get into trouble. Otherwise, everyone has his own setup, everyone his own machine, everyone formula SRKT is as a gold standard, as I said, and learned by the over the experience. That, as Dr. Gautam has very correctly said, and I teach my postgraduate as well, whenever there is a doubt, keep the patient myope. That would be much easier, post-op condition as being an e-metro brother or being under correction. So always being keep the patient on the myopic side. If there is a confusion, you are confused, the power is not there, limitations is there. Most of us, like we have limitations, So in that situation, we have to see the expectation of the patient and keep them most of the time, myope. So because with different time we change, keep on changing. We do use, phobic and philic and all the time, not standard one. But of course, so keep on changing the A scale, A constant on regular basis, all the, So that is the point that all at the end of the day, the theory is okay, fine. But at the end of the day, what you learn over the period of time with your experience, and I operated my colleagues also, and because they are being myope, So you don't make them emetrope. Never make them emetrope. Make them, little more, myope, so that they're very happy with not using the glasses for the presbyopia or the near. So that's the, my suggestion and my experience. Thank you, Dr. Gautam. Thank you, Vijay, for keeping me as a panelist. And congratulations to all the, participants, all the speakers, and Gautam did a good job. Thank you.
Thank you, sir. Thank you for your.
Thank you.
Quick
Thank you,
comment
sir.
from
Thank you so
Dr.
much.
Battaglia sir and Dr.
Thank-
Advani sir and Dr. Lalit Srivastava, if you are there. Dr. Battaglia sir, a quick comment from you. Sir, you have to unmute. You are muted. Sir, unmute yourself.
Hello. This is
unable, sir.
सर आप फिर से म्यूट कर लिए अपने आप को। डालिए सर, अनम्यूट कीजिए फिर से एक बार अपने आप को।
Hello.
नहीं पता अभी।
Dr. Nishlani, can I come
Yes, go ahead, please. We'll ask Dr. Battaglia sir to unmute later on, and you go ahead, please, Dr. Ajwani.
Majority of this is actually for our general ophthalmologists.
Yes.
And they don't have the access to the optical biometer. And they are doing the A scan. And before A scan, the keratometry plays an even important role. And majority of them, if they are not doing the keratometry by themselves, they may put themselves into the trouble. So keratometry, one diopter keratometry difference can lead to 0.9 diopter change in the power of IOL. So one has to be very, very careful in doing the keratometry, and they should do by themselves. And secondly, in all RK surgery and refractive surgery, if they don't have the access to the latest one, they should avoid taking the steep K. If they don't have the access to the topography, pentacam, they should avoid taking the steep K. They should take the flat K and then the axial length and then routine software which we are taking, SRK2 for the high myope and Hopperskew for the short eyes. So this is the very important. And in my practice, in 75% of my cases, I keep them 0.75 myope as a routine post-op refraction. Unless there's a very great demand for the emetrope, I always keep it at 0.75 post-operative refraction. Thank you very much.
Thank you. Dr. Parmar, would you like to say something more? Or shall we conclude?
Sir is rightly said, sir. It's I think it is very important to set target myopia and counsel the patient that we are not making you completely free of spectacles. Spectacles are must for you. So this counseling part is very important here. For ectasia, I just would like to say that if it is advanced, it is always better to use a standard keratometry, and again counsel the patients for mild ectasia, we can do just like what we do routinely. So we can do according to the stages of ectasia for keratoconic cases.
Fine. Last comment from Dr. Battaglia sir, if you are unmuted, sir. We couldn't listen to you.
Actually, it's unmute. Can you listen?
Yes. We are listening to you, sir. Go ahead, please.
Actually, first of all, I must congratulate you that you have done a wonderful job. It's really revisiting and all the courses we have already finished, and now again we are visiting the same thing. And the topics were excellent, and speakers are up to the mark. But there are few things. Actually, optical biometer, everybody is something he telling about the optical biometer. But even you can say if cataract is grade 3 or grade 4, Most of the optical biometers are unable to measure anything. They will not measure K1, K2 or axial length. Even I have seen IOL Master 500. That again, it cannot pierce the grade 3, grade 4. So this is difficult. If you want to purchase a instrument for 25 lakhs, what is the use then? I have to go to for getting my K1, K2 from the other instrument, then again come to the biometer. So it takes some time. So this is actually, I say, it's a very good, and it is very important also. So you need not have to wait for something. If you have more cases, you can finish early. This is one thing. But for beginners, it is very difficult to purchase such a costly instrument. That is one thing. What they have been taught in the college, that is really working till now. And I would like to ask Dr. Pillai. Dr. Pillai.
Yes, sir.
Was it necessary to remove the oil? While you said that you will be implanting the lens if you have not removed the oil. So what I have learned, it is better you remove the oil first and put the lens after some days. That will be better. Because if you do the diffraction with the oil is in, you put +1, +2, +4, patient will not be able to read 660. So what I have seen in other places also, they remove the oil first, then you put the lens. So that's why I was.
Absolutely, sir. In cases where we can do that, we would prefer to do it. But sometimes you need to keep the oil for a longer duration and the cataract is totally white. In such cases, you need to implant an IOL with silicone oil in situ sometimes. So there we need to keep this IOL calculation in mind. In addition, where the follow-up may be difficult, in such cases, we may need to do the surgeries together. In only those cases, we would prefer to do both the surgeries together. And the last point I would like to say is basically doing a cataract surgery in a totally removed eye may be without any support, may be a little more difficult than with silicone oil in situ as well. So yes, we can fairly predict the IOL power now with these calculations now, but not accurately as already told before.
But in your cases, or in private practice, the patients will always run after you. Why he has not got the vision? You have done 2 operations. Rather now you will be doing 3. First you have done the retinal detachment, then put the oil, then now you put the oil, then again you remove the oil. So every time he will not be able to pay. You come to Jabalpur, people will run after you.
True.
Who is that doctor who is doing 3? They will not pay. That is one thing. That is a drawback. That you have to, in the practice, you will learn all these things. Can
I comment, Vijay? Can I comment on this?
Yes.
Yes, we agree with Dr. Bhattaria. Performing multiple surgery is always a question mark, and patient will definitely have this thing. But as Dr. Ganesh said, sometimes if suppose we have done a surgery and we put a oil, it is only 4 weeks, 6 weeks, and we are seeing there is a significant cataract. At that junction, removing the oil is not possible. It is not indicated. In that situation, probably we have to remove the cataract first, and then after 2 months, 3 months, 4 months, whenever situation is comfortable, we'll remove the oil. That is the thing. But yes, if there is a 4 months or 6 months from the cross surgery, then removing oil and cataract surgery simultaneously is definitely the choice. Just I want one clarification from Dr. Ganesh Pillai here. Suppose we are not removing oil. So what IOL power you are going to put? You want to make the patient e-metrope, or you want to make how you in your presentation you said there will be +3, +4 number.
Basically, only in cases where the silicone oil needs to be kept for a very long duration, say in a case where there is a patient is already one-eyed and the seeing eye has a detachment, and there is a risk of detachment. Probably you keep it for sometimes 2 years, 3 years, replacing the oil in between. In those cases, you may need to put an additional IOL bar, that is plus 3.5 or 4. That is, it's a specific situation I mentioned, not in the cases normally.
Because once you remove the oil properly, then again you have to
Yeah. Yes, absolutely. This is only one indication where we have to do it. Otherwise, no.
Thank you, Ganesh.
Fine, thank you. So we come to the conclusion of this session. May I call upon our team member, Dr. Rakesh Shakya, to have a pleasure to introduce the session officials for session 4. Over to Dr. Rakesh Shakya.
So this is the fourth session of the Phacoemulsification. So this is the on the behalf of the SNC. So we have this is and this will focus on the provide the basic and advanced information of the Phacoemulsification. So I would like to invite our chairperson, Dr. P.S. Bindra, Dr. Pradeep Vyas sir, and Lalit Srivastava sir, and Kavita Kumar ma'am, and our panelists, Dr. Rajiv Gupta sir, and Ashok Sangai sir, and Avinash Bhatnagar sir, and Praveen Khare sir. And so I would like to actually hand over this session, our dynamic moderator, Dr. R.K. Gupta sir. Please go ahead, sir.
Hello. Hello.
Yes.
Dr. Gupta.
या मैडम
हाँ मेरा थोड़ा सा कनेक्शन गड़बड़ था पिछले वाले सेशन में. I was trying to connect and speak something. Everyone spoke about A scan, biometry, IOL power calculation, keratometry, etc. Two important things which I think is very, very important whenever we are planning the final IOL power of the patient is, number one, the profession of the patient, because you have to keep in mind, everyone was saying that you have to make a patient myopic by 1 diopter, but my say is one has to ask for the need and profession of the patient. That is most important.
What is
Number
the
one.
of the patient?
And number two, one must always keep in mind the refractive status or status of vision of the other eye. See, we have two eyes. We never have to work only on one eye. You never know what is the status of other eye, whether the other eye is myope by 1 diopter, whether other eye is hypermetrope by 1 diopter. So if you are planning to operate the other eye, you have to always look both the eyes and then plan your surgery or the final IOL power of the eye. So this is a very important thing which all the youngsters should take home, that before finalizing the IOL power of the eye, please look into the status of other eye, number one, and the professional status of the patient. Thank you.
Yeah, sure, ma'am. And I think it helps in the deciding your monovision correction also.
Yes. Monovision. Yes.
So
Thank you.
Yes. Thank you so much, ma'am, for your inputs.
Thank you, Kavita madam, for your inputs. Now, good afternoon, everyone. Now it's last session of this midterm conference, and after having all these good talks, in the conference we always keep the phaco in the last, because if we keep the retina last, then you can imagine what happens. So that was the strategy of our scientific committee chairman Nichalani Saab. We are having a galaxy of the speakers with us. They are very much experienced in doing phaco surgery. I think all are senior persons and they are doing surgery since last 20 to 25 years. So we will take their advantage of their talks. Now, without wasting much time, I would like to invite our first speaker, very dynamic and young surgeon, Dr. Rahul Shukla from the Jabalpur. And his talk will be on phaco-dynamics and understanding the machine. Rahul Shukla, please join.
Sure. Okay. Is my screen visible?
Yeah.
And am I audible?
Yeah.
Yes.
So at the outset, good afternoon, everyone. And at the outset, I would like to thank MPSOS and Chairman Scientific Committee, Nishlani sir, for giving me this opportunity. I'll be speaking on phaco-dynamics, understanding the machine. So, okay. All right, fine. So, yeah, how do I go back then? Fine. So we'll talk about the phaco machine. The phaco machine has got a console, which obviously is a computer which controls all the functions of the machine. The power, vacuum, and the flow rate can be set. And it has got a multi-mode panel wherein you can have the settings of different doctors. As you can see here, I've got a few doctors whose names are set. And you can have different grades of cataract, which can be again categorized. So you can have the chop mode, the quadrant removal mode, epinucleus, cortex, polish, autosert, and the visco removal mode. That is for one grade of cataract. You can have it for different grades of cataract also. You can have it for a soft cataract. You can customize it for a hard cataract or a very hard cataract, myopes, different settings. So obviously the touchscreen panel is really very good. Coming to the pumps, we have the Venturi and the peristaltic pumps. The peristaltic pumps works very well in the hands of the phacosurgeons. It's their preferred pump. It's ideal for a nuclear fragmentation and epinuclear cleanup. It's safe and better. Obviously, the Venturi pump is preferred by the retinal surgeons. It's very fast. There are risks. Obviously, people usually graduate to a peristaltic pump and then they go to the Venturi pump. Then we have the fusion pumps, which have better fluidics and they give you better outcomes. They give you less phaco energy is needed to emulsify the nucleus. There is less inflammation. There is less endothelial loss, and obviously there are reduced chances of the PCR and the IOP spike. Coming to the handpiece, there are three types: the phaco handpiece, the irrigation, aspiration, and the bimanual. So a typical handpiece consists of a tip, sleeve, body, and the line. Obviously, the irrigation and aspiration and the electricity line. The phaco tips initially was the concept that a 0-degree tip is very good for holding, whereas the 60-degree tip is very good for cutting. Now we've got the hybrid tips, which take care of most of the things. And the energy delivered can be, it could be a fixed energy, it could be a linear energy, it could be the pulse mode, and finally you have the burst mode also. You have the longitudinal as well as the torsional ultrasound again. So these are the various options which you have. Obviously, you have to titrate it to the individual case. Coming on to the IA handpieces, it can be a single IA handpiece, or you can have bimanual handpieces. And finally, the foot switch. The foot switch, obviously, it has an irrigation mode to it, the irrigation aspiration, and the infusion. 1, 2. So these are the true resistances which we feel whenever we are going. And then finally, we have the side kit functions of the foot pedal. You can have a reflex, continuous infusion, pulse on and off, bottle height adjustment. And irrigation tubing is white, aspiration is blue. I'm just revising the whole thing. Let's come to the main thing, that is the irrigation. It is the infusion pressure in millimeters of mercury, millimeters of water, I'm so sorry. And obviously, we have the IOP now in the new machine. It's usually controlled by the manual or an automated IV pole. And the new machines have the active fluidics, wherein the side drums compress the BSS bag and maintain the target IOP. The goal is to provide an adequate infusion pressure to maintain the equilibrium. And what are the ideal anti-chamber conditions? This is what we have to actually look at. It should be a deep, stable AC, number one. And you need to have constant intraocular pressure. And how do you do that? So what are the essential conditions for that? The constant infusion pressure is obviously one, gravity effect, and you can have active fluidics which maintain the IOP. There should be zero or minimal leak, determined by the wound size, tip and the sleeve size, and leakage from the side port. Obviously, if you're having large leakage, you can all get a new side port made. That will going to help you immensely. And constant aspiration flow rate again is important. So some amount of fluid enters the eye and some amount of fluid goes out of the eye. Make sure it goes through the AFR. Now, when to raise the bottle height or increase the IOP? Obviously, when we want to deepen the anterior chamber, if the incision leakage is excessive, and if the aspiration or the vacuum levels are causing chamber shadowing, you need to raise the bottle height or increase the IOP. When to lower the bottle height? Obviously, whenever you have a PCR during the vitrectomy, or when the AC is too deep, as in cases of high myopes. So the infusion dynamics is basically, if you have too much of infusion, it would lead to an overpressurized eye that would lead to a poor solubility. The pieces wouldn't come to you. And if you have too little infusion pressure, it would lead to a soft eye, leading to chamber instability and ultimately surge. So you have to balance the things. You can't go either way. Second is the aspiration flow rate. Now the aspiration flow rate, it is withdrawal of the fluid from the eye. Rate or speed at which the fluid is removed from the eye, and it determines at what speed you attract the nuclear pieces to the distal end of the handpiece. That is actually the followability. It is the attraction of the nuclear pieces to the phaco-tip. Now the AFR, obviously, if you want to minimize the vacuum rise time, the AFR has to be increased. But you need to decrease the flow rate whenever you have a PCR because, and secondly, high myopes, because that leads to anterior chamber deepening and the pupillary block. And finally, eyes with weak zonules. Coming to the vacuum is actually, once the piece comes to the phaco-tip, it can be emulsified, but you need to hold the piece to the phaco-tip. That is vacuum. So it's basically vacuum has to be, it starts in phacoemulsification. It starts the phacoemulsification, but then the piece would actually shatter away. By doing vacuum, increasing the vacuum, you can actually hold the piece to yourself. And mind you, the vacuum builds only when the tip is occluded. So when to raise the vacuum? When obviously you need to increase the holding power at the tip, that is the hard cataract. And you lower the vacuum in cases of taking out the last nuclear fragment, chamber instability, shallow ACRs in hypermetropia, and also in the cases of PCR. Rise time is the terminology is how fast the vacuum builds up after the phaco-tip is occluded. It is directly related to the aspiration flow rate. And then you have few terminologies. One is the surge and second is the venting. Surge is sudden shallowing of the anterior chamber, and that leads to either a PCR or the shallowing of the AC. You can always reduce it by venting, which is a process wherein the machine senses, and you can have an air fluid going inside. And active sensory handpieces have sensors in the handpiece itself now, in the Centurion, where they sense and extra fluid goes inside the eye so that the surge doesn't take place. Just to summarize, you should know your phaco machine. We need to play with our foot pedal and parameters. We need to titrate our setting with pushers. This might take a while. I don't think we should be afraid of a rent. It actually is an opportunity to get your anterior vitrectomy in use. Read. Watch the phaco videos. Record and analyze your videos also. Thank you so much for your patient hearing.
Very good talk, Dr. Rahul. And you covered all the basic point for the beginners. That is very important. We will discuss in the last, after all the speakers are over. Now I would like to invite Dr. Prerna Upadhyay. She is an in-charge surgeon of the Seva Siddhan Eye Hospital. She is also a prolific surgeon, high volume surgeons. And her topic is the perfect incision, preventing wound-related complication. Dr. Prerna, please share your screen and start.
Good afternoon, everyone. First of all, I would like to thank Dr. Nichlani and scientific committee members for giving me this opportunity. Am I audible, sir?
Yes, go ahead.
My screen is visible, sir?
No, you need to share it. Rahul from Antod, can you help her how to do it if she is finding some trouble?
Okay.
Fine. So can we go to the next talk till she comes back again?
Yes, we can do that. So may I call another speaker? Next speaker, please. The Prerna is having some problem with the network, so that is not possible. Now I am inviting Dr. Purindra Bhasin from Gwalior, and his talk is on the perfect rhexis every time. Dr. Bhasin, please share your screen.
Can you see my screen, please?
Yeah.
Am I audible?
Very well.
Thank you. Thank you, Dr. Gupta. And at the outset, I would like to thank MPSOS and the Scientific Committee Chairman for giving me this opportunity to speak on perfectrhexis every time. I don't have any financial interest. Continuous curvilinear capsulorhexis. This is the topic allocated to me, and this is the must, or we need to have a complete CCC for the safe phaco. And 1985 was the year when Gimbel and Newhan, both from different continent, one from Gimbel from America, Newhan from Germany, they both presented in their annual conferences in ASCRS and German conference that circular capsulorhexis, circular fashion capsulotomy is the way to go ahead. And mind it, during those days, phaco was not an in thing, and removing the cataract was safely through small incision was the basic idea. And then they came out with this term that is continuous curvilinear capsulorhexis, which in itself explains everything, how and what are the way to do it, and how that it should be a circular thing. The aim is to make a complete circle without any radial tear, because we know if there is a radial tear or any angle in the capsule, that can go and extend to the periphery. It should be well in the center, and the size of the capsulorhexis should be 0.5 to 1 millimeter less than the size of the optical part of an IOL. And it should not be neither be too large nor be too small, because all these have their own consequences. There are basically three techniques. One is with the help of cystitome, which we make it with the help of a 26 gauge needle, or we can make it with a forceps, a Utrata forceps, which is most commonly available, or maybe small incision forceps, or the combination of the two. So this is how we can do it. The initial puncture is made right in the center, in the visual axis, or in the center of the lens, and then a capsule is folded on itself with the cystitome. And in a circular way, if the capsule is folded properly, it will always follow that path. So this is how we can make it. It is non-edited, and there is no addition made in this videos, in all these videos. So initial nick, fold the capsule on itself. This is under topical anesthesia. So your excursion or your movement of pull of the on the capsule should be right towards the center of the eye and should be small. And we should not press the eyeball, or rather, neither we should lift the cornea. So this will avoid the egress of the viscoelastic from the eye, and it should well cover the IOL all around, as you can see in this. And then coming to a capsulorhexis in a Morganian or a mature cataract. So after the initial nick, after we are stabilizing the eyeball with our second instrument, I'm using a side port. Because of the small size of the paracentesis incision, the chances of egress of viscoelastic from the anterior chamber is less. And with the help of micro-incision forceps, you can slowly and pulling the capsule towards the center, centripetal force, you can do it in a nice way. And mind it, in all these cases, your chamber of the anterior chamber should be, your anterior chamber should be properly filled up with the viscoelastic. Neither it should be overfilled nor it should be underfilled. It should not be leaking. And in such cases, mature cataract cases, you should have high viscosity OVD in the anterior chamber, because it tends to come out less easily from the anterior chamber. This is a very unguided capsulorhexis. This image comes in one of your eyepiece of the microscope, and by making this guides you how big or how small your capsulorhexis site should be, and it should be well in the center. And this is very, very useful in cases of premium IOLs like toric or multifocal IOL, because we require our IOL to be well covered all around, as in this particular case. And you can make such impression with the markers which are available in the market. I used to do it in way back in 20s when this variant was not available. We used to make an impression on the center of the cornea, and with this, guided by this, till the time you finish the capsulorhexis, this impression lasts on the cornea, and it doesn't damage the epithelium. Coming to an interesting case, when after the routine cases, this is a case of hypermature cataract. And in these cases where the intralenticular pressure is high, and if the positive pressure is there, so you tend to start with a small rhexis, and then you spiral out. Means you enlarge it in the same go, or maybe you can enlarge in a second sitting after the cataract has been, or phacoemulsification has been done and IOL has been implanted. So this way you can spiral out and make the capsulorhexis of the desired size, which is 5 millimeter, which we intend to, because our IOL optic is 6 millimeters, so it will cover the lens all around by 0.5 millimeter. This is a leaking fluid Morgagnian cataract, white milky fluid. The moment you make an initial puncture, it comes out in the anterior chamber with a fine side port with cannula. You remove the milky fluid from the anterior chamber, and you go inside the capsular bag through this opening and remove the milky fluid. And this will decrease the intralenticular pressure, keep the chamber filled with adequately filled with viscoelastic, and use the side port paracentesis incision.
Please sum up.
Yeah, this is make a paracentesis. Through the paracentesis incision, you can complete it after intending in a small rhexis. Then you enlarge it and make it a 5 millimeter size. So this is how you can do it. There are various other cases, and because of the paucity of time, this is one case. If time permits, can I show this case, please, Dr. Gupta, or should I close it? Dr. Gupta?
How much time?
This one last video.
Okay.
This is a case wherein the capsulorhexis has gone extended to the periphery. So this is because of the fibrosis of this capsule. You see that it's not easily folding up because there is a fibrosis at this part. So with the help, we can pull it gently with the help of a utrata forceps, fill the chamber, and then you complete it. Or there are other videos wherein I was showing how to cut it and then enlarge it. These are all small videos. And this is Argentinian flag. You see, it appears in a case when there is a high intralenticular pressure and there is a hypermature cataract. So in this case, you cut the anterior capsule with the help of microforceps or the forceps Vaness scissor, and then you complete it in a circular fashion. Do it on the opposite side, and similarly you can retrieve the extended rhexis by cutting it with Vaness scissor and then completing the cutting the anterior capsule in a circular fashion. You mind it, all these cases are very risky to do phaco because there is chance of posterior dislocation of the lens and nucleus fibrin. To conclude, complete CCC is an essential part for the safe phaco. Focus on advancing edge for any peripheral running of capsulorhexis and retrieve it as soon as possible. Fill the anterior chamber with OVD, and better to use forceps to complete it. Be prepared to convert in hypermature and Morgagnian cataract cases. Thank you.
Very nice talk, Dr. Bhasin, and you completed almost all the problems related with the capsulorhexis, particularly in the hypermature cataract. Now I think Dr. Prerna is ready. So Prerna, please share your screen and Go ahead. Yeah, now it's coming.
Sir, good afternoon, everyone. Hello.
Yes,
Is visible now?
it's not coming. Your text is not coming.
My screen is visible, sir?
No, no, Dr. Prerna, you have to,
Share the screen.
there is a green button at the bottom. You have to press it and then go to the desktop from where you can select. Close it first. Close your presentation first.
Please keep your presentation on desktop.
Rahul is there. If Rahul Jain is there, please help her from IT. Dr. Nicholani? If Prerna can mail her PPT to Rahul directly, then he can share on this.
Yes, please.
He's not able to share the screen.
Dr. Prerna Upadhyay. She is not able to share the screen.
Prerna
Dr. Prerna
Upadhyay.
Upadhyay. Dr. Prerna, please unmute yourself first.
What is the choice of making the capsulorhexis, needle or forceps, Dr. Shakya? You make it with forceps or you prefer it with needle?
We discussed in the last.
Actually, I start from the 60 down.
There is a time because we are just looking at each other. We can discuss scientific contents.
Okay. Then. So initially, when I was in post-graduation, I start with the 60 down. But when I joined the SNC here, I start with the forceps. So, but sometimes when the port is very small, like 2.2, then I always do with the 60 down. And sometimes we use the combined in cases with like hypermajor cataract. Initially, we make a nick and aspirate the actually cortex material, then make a small axis and then cut with the help of Bana scissor and complete another axis. So I always use the here the mostly forceps and sometimes it's 60 down.
So actually forceps you require a slightly wider wound, 2.8 millimeter or so wound because maneuverability is slightly difficult. Your opinion, Dr. Nicholani, Dr. Gupta, what do you say?
Can we go to the next speaker so that we continue this proceeding later?
So then I would like to invite Dr. Shakya. His talk is on irrigation and aspiration methods and precaution. Dr. Shakya, please share your screen and start your talk. कहाँ प्रॉब्लम हो रही है इसको?
So I'm audible.
Yeah.
So everything is covered by the Dr. Rahul sir and Basin sir. So the irrigation aspiration is used for the removing the lens material and removing the viscoelastic. And when are doing the irrigation aspiration, you should be bothered about anti-chamber maintenance, epinucleus management, and meiotic pupil, and some complication. They are the three types of irrigation aspiration done by coaxial handpiece or by manual handpiece. It is depending on the hello.
Rakesh, your voice is.
My voice is not coming.
Yeah.
Go ahead, Doctor.
डॉक्टर राकेश पास में से बोलो, थोड़ा पीछे मत हो.
I mean, my voice is coming not.
Yeah,
Yes,
very
it's coming, coming.
Go ahead.
Okay. So I always use the actually when I was beginners, I actually had very difficulty to insert the irrigation aspiration cannula in the antechamber. So nowadays actually I always use the bimanually. So for the irrigation aspiration, so I want to video. My video is running
The video is not running, Dr. Rakesh.
now.
No.
No.
In fact, your presentation is not moving.
I think I stopped.
Yes.
Now
it's there. Yes, it's ready.
Sorry.
निचलानी सर कल हमने वो ट्राई किया था ऑप्टिमाइजेशन run the video smoothly.
Yes. Dr. Rakesh?
Yeah.
Would you remember that point? Optimize video clip for उस पे जाके आप click करिए, you'll definitely find an improvement.
Yes, sir. I just share the again.
I'll do it for you.
Now my video is running. No? Okay, now? No.
Yeah, now it's running.
Now it's running?
Yes, Rakesh. Now it's
very
running.
slow.
Go ahead.
Okay. So I always use the bimanual. So I just inserted the both irrigation aspiration cannula and just go near to the rhexis margin and then pull it and then to the center and do the like the tangential movement and toward the center and give the full vacuum and then aspirate it. So I always keep this irrigation in behind the aspiration cannula. So this is very protective to advantageously actually catching the posterior capsule. So and then I change the hand and then remove the cortex on the other side very easily with the help of this bimanually and so in this in the bimanually it is the you can this is the bimanual you can remove the very easily. This is not should be done at the direct stitching of the capsule or direct stitching of the cortex because it can cause the inadvertent PCR. So you always sweeping movements by the aspiration and then loosen the cortex and then keep in the center always aspirate it. And for the IOL very easily with the help of IOL. So this is the case of small people. Some of the nucleus material is remaining, so it should not be done like that. So actually aspirate and crescent between two, and then this is the miotic people. So the irrigation cannula is just retract the iris, and then see the capsular margin and hold the cortex and remove in the center, and then aspirate very easily. So this is a very good technique for the undilated or miotic intraoperative meiosis. So just retract the iris with the help of irrigation, and then but sometimes it can engage the iris, and sometimes it can engage. You can engage the rhexis margin. So you should be always careful during the pulling the cortex from the behind the iris. Like that, I actually the 2 times I hold the iris in this case. So after that, after putting the IOL with the irrigation aspiration cannula, you can always rotate the lens so you can remove the remaining cortex, and then you can also retract the iris to see where the IOL is in the bag or not. And then when the sheet is slightly thicker, so you can just remove or just loosen the sheet all around, and then keep it with the changing the hand, the sweeping movement. You can loosen the cortex all quadrant, and then keep in the center and keep the irrigation cannula behind the aspiration, and then give the full vacuum, and then very easily. So this is the subincisional cortex. So in the SICS case, you can scoop out. So this is the scoop out ice cream scoop method. You can just give the simple cannula, just hold it and go toward the center and remove it very easily in the cortex. So for the polishing, you keep the parameter very low, FR or vacuum very low, like the 10 or 6, and then bottle height slightly higher, like 80 or 100, and then do the with the smooth removal of the cortex and also removal of the anterior capsule margin. You can easily remove the cortical fiber from the anterior capsule margin. In this case also. So initially, when you beginners, when you start the polishing, you always start with the smooth cannula, and sometimes there are the many sanded cannula available. But these are the another myotic people. Sometimes you hold the PC during this process, even after retracting the iris with the irrigation cannula. So I noticed the during when I retract the iris, and I noticed there the small PCR is there. So I do the vitrectomy in this case, and then the PCR is slightly small, so I just put the IOL in the bag very carefully because this is a plate haptic IOL, so you can change it. But in this case, I do it very easily. Sometimes you can hold the capsule margin during IA, so this can do the joint analysis. For this is the 2 o'clock hour, so you put the capsular tension ring with the help of the Tuchinski hook, insert the manually, and then manage it properly. So for the actually irrigation aspiration, the circular access is required. That is circular access required, and hydrodissection is must. So actually loosen the cortex from the capsule, and then after do the hydrodissection, proper hydrodissection is very important. So you always see the fluid wave because the thick sheet always remaining in the immature cataract. After that, you can always very easily remove the cortex. So I always use the. Thank you. So for the take-home message, I always use when you are beginners, you always use the bimanually because it is very safe, and hold the cortex and move tangentially with the low vacuum and aspirate the cortex in the center with the full vacuum. And aspiration force always keep up when you're doing the aspiration, and the continuous flow is available but useful to avoiding the inadvertent release of the position 1 and the potential collapse of the antechamber. And most important, the side kick function is also available. So when you catch the capsule or iris, you can do the side kick function and aspirate any air bubble or fluffy material when lying in the antechamber. So the complete cortical cleanup is a very essential step, because sometimes any inattentive inattentive, you can cause some complication. Thank you, sir.
Okay, thank you very much, Dr. Rakesh, for you demonstrated various methods of irrigation and aspiration in different and difficult situations. Now I am inviting another speaker who is very well-known person. I don't want to introduce himself because everybody knows him. His topic is hydroprecision and tackling different nuclei and cataracts. So Dr. Nicholani, all is yours.
Thank you, moderator sir, and session officials for allowing me to present and share my thoughts about hydro procedures and tackling the different nuclei. The prerequisite is proper slit lamp examination, how to find out the grade of cataract. You need to have optimized CCC, a good hydro procedures, a proper setting to avoid surge, and a protection of endothelium is must, and how to minimize the time while you are doing all these surgeries. In a dilated pupil, when you see, you have to grade the nucleus sclerosis or cortical cataract depending upon the thickness of the nucleus grade and the pupillary size occupied by the cortical cataract. You can grade accordingly from grade 1, 2, and 3, and finally to a brown and a black cataract. So a proper slit lamp examination will give you all these ideas about a nuclear, cortical, and the posterior subcapsular cataract, which are the common cataracts. So again, same that way, the pictures in a slit lamp. Here you can see the different grade of the nuclear sclerosis from grade 1, 2, 3, and 4, and finally a black cataract, which is a Niagara cataract. Yes, directly going to the video clip, because this is a video session. I have tried to incorporate the different variety of the nuclei, how to deal with them, particularly when you are dealing with any variety of the nucleus. The essential part is just doing a proper hydrodissection. Must see that the wave is going from one corner to another corner and making the nucleus free, which is very important. And thereafter, a rotation of a nucleus is very important to make it free. So these two steps are very important. A particular tip for the beginners when they are doing for divide and conquer, they must take nucleus of grade 2 or grade 3 and try to hydrodelineate the things, the nucleus particularly, so that they must have an idea that what is the extent they need to move. So this is a tip for the beginners, that you've got a limit of a nucleus, you are making a central trench and going up to the depth of 2/3 of the nucleus itself, rotate it to 90 degree, make a trench from the another side to the 90 degree, and with the help of two instruments, you can definitely divide a nucleus into 4 pieces, which is called divide and conquer. So that was a point which I wanted to stress, that grade 2, grade 3 and hydrodelineate, and try to see that you've gone to that limit, never crossing that limit, to avoid the damage to posterior capsule. Now coming to the horizontal chop, here you should have enough grip of a vacuum, go from 12 o'clock or from temporal side, and then have a proper grip, take a second instrument behind the limit of the nucleus itself, bring it close, both the things, the second instrument and the something goes there, yes. And simultaneously, when you're going to, going to make a chunk, you can rotate it by 90 degree and take it out with the optimized phaco power. Now coming to a vertical chop, again, the precaution which we need to take is just that you must go to the core of the nucleus. The sharp chopper has to be put into the mid-periphery and then approximate both of them and then make a side movement, and this is how you can divide the nucleus into different pie. Either you can make it 6, 8, depending upon the size of nucleus. Once those nucleus has been divided into different pie or different chunks, try to catch the apex of the pie itself. This is very essential. And with the optimized power, you can definitely take out whole of the nucleus one by one, eating the chunks of it. So that was a vertical chop. Now coming to stop and chop, this is particularly a brown-black cataract. Make a trench up till the depth of 2/3 of the nucleus. The essential part is this, that you should cross the depth of the core of the nucleus. Once that is done, deeply buried the nucleus tip, and then with the vertical chop, you can definitely divide it into 2 halves. This is a posterior polar cataract. The important thing is just to take out the epinucleus from the nucleus itself, then hydrodelineate it. You can see that nucleus has been nicely circled up. The limits has been outlined. So that is the place where you have to move and take the nucleus out. Once that part is over, with the separate irrigation aspiration, move irrigation behind the anterior capsule, and this is how the plaque is lifted up, not giving any kind of posterior capsular rand. This is a soft cataract. Essential part here is just to keep on hydrodelineating, make the nucleus into the smallest part. So that is the success of doing a soft cataract. There are other methods as well, but this is one of the simple methods. Once the nucleus has been put into the smallest part, start doing phaco and see how all of the nucleus has come up. This is a Morganian cataract not being caught with the phaco tip beveled up. You need to take it beveled down, and this is how you can, I mean, say, divide the nucleus and take out this nucleus. To conclude, a good hydro procedures, rotation of nucleus is must, optimize powers for different cases, you need to decide with your experience. Thank you.
Thank you, Dr. Nichlani, for a very comprehensive talk. And you almost covered all the techniques of managing nucleus, ranging from soft to very hard cataract, and very unique technique of dealing with the posterior polar cataract. Now, I think I should invite the next speaker. He is Dr. Pawan Isthapak from Jabalpur. He is again a very prolific surgeon and volume surgeon. And his talk is on the safe loading and implanting variety of the IOLs. Dr. Pawan Isthapak. Dr. Isthapak?
Yes. 1 minute. Yes. Yeah. Now my screen is visible?
Yeah, very well.
So, thanks to MP State Ophthalmic Society and Chairman Scientific Committee, Dr. Nichlani, sir, to give me this opportunity. So this is safe loading and implanting the variety of IOL. As we know, loading systems, there are two types of loading. One is preloaded, which is available by the different companies, and another is self-loading. The customized injectors of different makes are available in the market. So there are three types of IOL: single piece IOL, then 3-piece IOL, and plate type IOL. Technique of safe loading: remove the injector and cartridge from a sterile blister. As all we do, apply a small amount of viscoelastic solution on the inner channel of cartridge and tunnel. Remove the intraocular lens from the vial and place it into the central hinge of the open cartridge. Press the lens into both guide rails, and with the help of a rounded forceps, examine the position of the lens. Make sure it is correctly aligned in the closed cartridge. Then retract the silicone-tipped plunger of injector and load the cartridge into the front end of the injector. Push the cartridge into very front position. Push the plunger forward to ensure that the silicone-tipped correctly enter the loading chambers. Then advance the lens to the foremost point of the cartridge outside the eye. Now this IOL delivery system is properly loaded and ready for use. The another thing we must remember that the lens should be injected immediately after being introduced into the cartridge, as viscoelastic solution may lose its lubricating properties when it exposed to air for a longer period of time. Why safe loading important? It is important to avoid the complication like PCR, IOL damage, haptic or optic fracture, malposition of the IOL, and corneal lesions. Now I will show you the video. Yes. As you see, this is the lens which is placed into the cartridge. and make it forward to the tunnel. Then if you do not place it properly in the cartilage, then it opens like this. You can see here it is rotated in the anterior chamber, haptic is over the iris, and this haptic is outside the wound. To avoid this, you have to take proper precaution while you load the intraocular lens in the injector and cartridge. Now this is the time to struggle. Now you just push the haptic inside the IOL. But with the proper placement of the IOL in the cartridge, you just hit this haptic to this cartridge portion of this cartridge to make to fold it slightly backward. Then put this haptic close to the optic. Then mount it, and this lens is ready for use. If you mount it properly, then it opens.
Mohan,
You see, this is very good thing of the IOL. It is opened into the bag, and just wait for some time. It will expand into the. You see, this is the micro incision lens. In this type of lens, implantation is very easy. Just to put the IOL, press by forceps, and it comes into the tunnel, and just inject in the bag. It opens automatically. This injection with preloaded system is very easy. It comes in the almost in the very good this thing in the position. So just inject the viscous into the cartridge, and this preloaded system lens is ready for the use. Just inject it into the bag, and if it is then with the help of the lens hook, just place inside the bag. It is very easy. This is another type of Envesta lens, hydro square edge lens. Just hit the haptic to this cartridge, so make it slightly bending on the backward side, and so that it should not open. You can see this into the anterior chamber, into the bag, and just tuck it. It will go into the bag.
Last minute is remaining, Dr. Stapak. Please try to stop.
See, this is the another type of lens. Sometimes this type of lens engage into the plunger. So take the proper precaution. Just fold the lens from the inferior optic also, haptic also, and take it to the forward in the tunnel and just inject into the bag. You can see this is the rhexis is extended, so you have to rotate this lens on the 180 degree. So that the anterior flap on this side and on the another side, they should be over the haptic and optic. And remove the viscoelastic. So thank you very much. This is the proper placement of the IOL in the cartridge between the rails and proper use of viscoelastic. You can avoid the complication of IOL implantation. Thank you very much.
Thank you, Dr. Stapak, for a very comprehensive talk, and you covered almost all the problems related with the safe loading and implanting of the IOL. Now, I would like to invite next speaker. He is also a very renowned person and always has innovative ideas in his brain. He can manufacture lens in the anterior chamber. I have seen somewhere. So, my dear friend, Dr. Upi Agrawal, this is all yours. Come and show some another magic here. Dr. Upi, please.
Good afternoon, everybody. At the outset, I thank MP State Ophthalmic Society and Dr. Vijay for giving me this opportunity.
I just want to share my screen. इसको पहले ओपन करके रखना होगा शायद, ये ना प्रेजेंटेशन, उसको पहले ओपन करके फिर शेयर करना रहेगा।
बच्चे बहुत काम आते हैं सर,
बिना उनके काम नहीं चलता है सर। Now can you able to, अपन तो सर्जरी करना जानते हैं बस, बाकी ये सब जानते हैं।
बिल्कुल।
Is not coming.
Just a minute.
बच्चे के सामने बोल नहीं रहे हैं ओपी भैया, वरना दिल से तो आप बच्चे ही हो।
Done.
Now it's coming. Yes.
So, recognizing and managing posterior capsule rupture. With posterior capsular rupture,
और आपने देखा नहीं अपना वीडियो में नीचे नाम चल रहा था।
तो राइट कॉर्नर में व्यू आएगा, उसमें से स्पीकर का राइट कॉर्नर में व्यू वाला बॉक्स आएगा, वहाँ पर उस पर क्लिक करोगे तो स्पीकर व्यू आ जाएगा। तो
राइट अपर कॉर्नर पे आएगा ओपी।
The video presenters always do find this kind of problem often. Can we have some next speaker, Dr. Prerna, if she is ready? She has sent me the video. Video is downloaded with me in my desktop.
you can.
If she is ready, we can go ahead with Dr. Prerna.
No.
Is she there? No.
Dr. Prerna.
Yes, sir, please.
Yes.
Good afternoon, everyone. Sorry for the inconvenience I have created. I would like to thank Dr. Nichlani and the team MPSOS for giving me this opportunity.
Okay.
Am I audible, sir?
Yes.
Our screen share नहीं हुआ Vijay.
Sir will do.
Screen is not shared.
Vijay.
You want to?
Yes,
okay.
sir. You play.
Fine. I'll do.
Okay.
Yes.
Yes, now it's coming.
Yes. Good afternoon, everyone. Sorry for the inconvenience I have created, sir.
Yes, Dr. Prerna, please go ahead.
No,
Yes. Voice nahi aa rahi isme. Sound is already recorded, sir, in this video.
Okay.
Surgeons usually gives it. Depth should.
I'll run it again.
Evolution of cataract surgery incision has been towards smaller incisions, moving from 13 millimeter to 2.2 millimeter temporal clear corneal in an attempt to reduce postoperative astigmatism. Wound construction needs more importance than junior surgeons usually gives it. Depth should be 50% and incision should start 2 millimeter behind the limbus and at least 1.5 to 2 millimeter into clear cornea. The smoother and larger is corneal lip, better is the sealing action. Only difference with small incision cataract surgery is that side pockets are not needed here. Corneal incision was introduced by Dr. Howard Fine. It could be given temporally, superiorly, obliquely, or on the axis of the greater corneal curvature. Start clear corneal incision anterior to the limbal vascular arcade. First enter tip of keratoderm at the limbus, pierce the epithelium, and then pass through the stroma, almost equal thickness of roof and stroma up to 2 millimeter, and then after slight dip, pierce the decimates membrane and enter into the anterior chamber parallel to the iris plane. Clear corneal incision is preferred these days because it is more aesthetic and time consuming. Follow the limbal vessel, hit the epithelium, go straight up to 2 millimeter into stroma, divide it into 2 equal halves, and then hit decimates and enter into the anterior chamber parallel to the iris plane. It should be triplanar, secure, 6-dimensional, and not too loose and not too tight. Now see in slow motion, angle between the blade and conjunctiva should be 20 to 25 degrees. Same, hit the epithelium, then stroma up to 2 millimeter, and then enter into the anterior chamber parallel to the iris plane. This is perfect 3-planar incision. Why temporal? Because less obstruction and with age, more chances of against the rule astigmatism. Incision is the mother step of the phaco surgery, so it should be very meticulous. Ideal phaco incision should be 6-dimensional. There is entry wound, exit wound, 2 side walls, roof and floor. Either it is square or rectangular. It makes no difference. It depends upon the size of the blade. Paracentesis should be done with the MVR blade, preferably either with the slit knife. They should be 2-planar, not too long, not too short, and they are not very close to the main wound. It's better they should be more than 45 degrees apart. OCT is a very good tool to monitor wound construction. This is ideal wound. Both external and internal entries well approximated, and cornea is divided into 2 equal halves. Hydration should be done with 2 cc syringe and 27 gauge cannula at the roof of the midstroma and minimum like shown in this video. If tunnel is too short, not gives any stability and needs suturing at the end of the surgery. On the contrary, if tunnel is too long, there will be compromised visualization and difficult instrumentation. Give importance to the inner edge of the wound also. It should be either straight or concave. If you dip the blade too much at the time of the internal entry, like this, it will give you chevron incision. That means triangular inner lip. And once this happens, see the end result. Too much corneal edema and see the inner lip next day at the OCT, not at all approximated. Sometimes everything is fine from your side, proper paracentesis, proper cubical wound, but case is difficult, like this post-RK surgery case. At the end of the surgery, all wounds are leaky. So suture all the tunnels, no ego issue whenever you find this type of a situation. In pediatric cases also sometimes we do suturing. If tunnel is not proper, it gives rise to all types of major complication like here. Here also tunnel is leaky, so it's better to suture and then proceed. Wrong wound is the gateway of all major complications. From endothelial damage to PCR and even endophthalmitis. So first fixate the eye properly, pressurize the eye properly, and then try to make classical triplanar incision. At the end, I should advise, use always sharp blades, match and select blade size according to the tip and sleeve size and IOL to be implanted. Well, begin, half done. Thank you for kind attention.
Thank you very much, Dr. Prerna, for very good presentations. And
Evolution of pediatric surgery incision has been towards smaller incisions.
you have explained everything, the geography of the wound, the way how the, incision is made. So very nice talk. Congratulations to you. Now, Dr. O.P. Agrawal, are you ready?
For bearing with me.
Video unmute.
Hello.
Please go ahead.
Unmute.
Yeah. So this makes PCR an unwanted and unpredictable accident during cataract surgery that takes away the wow factor from the post-operative experience. Even if patients escape cystoid macular edema, astigmatism, and other complications, the quality of vision is often suboptimal after PCR. We should take all whatever all presenters have shown. If we will follow it properly, then the chances of whether it was managed appropriately or not. So if we talk about the management of PCR, anticipation of PCR, like in posterior subcapsular cataract, traumatic cataracts, we should know that PCR can happen. What are the steps to prevent? In steps to prevent, I'll suggest that we should be fully acquainted in managing PCR by the way that we should keep our skills upgraded to manage PCR. All anterior segment surgeons should learn how to do anterior vitrectomy. This is very important. Then to recognize PCR. Very important, if we'll recognize PCR early, we can manage it properly. Then the proper management. Prerequisites are no panic, skill to manage PCR, and we should have VR vectors. So how to recognize the PCR? This is what we can get. At this immediately, we have to recognize, yes. So there are few different videos how we have to recognize early and we have to act fast. So first we have to recognize as early as possible. PCR can be at different stages of cataract surgery. So initially, when we were dealing with nucleus, now at the time of IA, but this is the blunder which I have done in this patient. Even at the time of removing subincisional, here I did try that only with single side port I can remove this small fragment of nucleus. At the time of implanting the IOL, so these are the steps where if we recognize it earlier, these are the obvious PCR, but in few patients, very early recognition where we can not able to see whether behind the nucleus, behind the fragments, there is a capsular rupture. That is very important. So now how to manage? If we are getting the PCR when the nucleus is intact, and we can able to do dry vitrectomy first try to stabilize the vitreous coming in the anterior chamber. Then preferably, if possible, chamber, after doing dry vitrectomy, there should not be any vitreous in the capsular bag in the anterior chamber. Then deliver the nucleus in the anterior chamber. With the help of small incision cataract surgery tunnel, we can remove the nucleus, whether it is soft nucleus, hard nucleus, whatever it may be. Try that most of the nuclear fragments and cortex we can prolapse out of the anterior chamber. Here I used anterior chamber maintainer. There was small cortical fragments in the vitreous cavity that can also be removed at the same time. If we have VR backup, that can be done. And in this case, I'm implanting multi-piece intraocular lens in the sulcus. So this type of patients, we can very well manage our own. If the PCR is happened during cortical aspiration, then first do dry vitrectomy and remove the vitreous from the capsular bag is maximum as possible. Here we can use vitrectomy cutter, we can use bimanual IA. Sometimes we may need to use Simcoe cannula also. Remove the nucleus material from the anterior chamber and from the and then we can implant in the sulcus. Here also the same lens can be implanted. Here first I'll disengage the lens from the capsular bag. We'll bring it out from the capsular bag. We'll implant this lens in the sulcus first. After implantation of the lens over the capsulorhexis in the sulcus, and then in each and every patient, we should do vitrectomy. Vitrectomy is mandatory because otherwise it will give raised intraocular pressure, more inflammation, more post-op complications. So with the same phacoemulsification system, we can do vitrectomy in this type of anti-vitrectomy in this type of complications.
Dr. OP, now try to sum up, please.
So very much.
Video is not running.
Hello.
OP, video is not running.
I think he has completed. I think he has completed.
Yeah. Okay. Thank you very much, Dr. OP Agarwal, for a very nice presentations and good demonstration that how to control the PCR and implant the lens in the sulcus and in the back. Now, I think our last speaker of this session will be Dr. S. Tripathi, and his topic is choosing safe settings for the beginners. Dr. Sunil Tripathi, he is from Jabalpur. Dr. Tripathi, please share your screen and start.
Yes, sir. The screen is visible, sir?
Yeah.
Yes, sir.
I'm audible? Yes. So good afternoon, everybody. So my today's topic is choosing safe setting for beginners. Thanks for the scientific committee MPSOS for giving me this topic.
Please make it full screen, yes.
So we cannot do the phaco in same setting for all the steps and in every eyes. We have to optimize our settings of parameters according to grade of the nucleus and steps of surgery, type of eye, whether it is shallow AC or deep AC or myopic, hypermetropic, weak Gonioscopy, like that. See, what is safe setting? The safe setting is that in which we can efficiently perform the nucleotomy along with lowering the complications like endothelial cell loss, wound burn, and surge-related complications like PC rupture. In simple peristaltic machines, what I use, these three basic parameters we have to keep on changing during our surgery. This is the vacuum and flow rate or aspiration rate or power. In the coming slides, with the help of video, I will explain how these parameters are changed during the surgery.
While sculpting and trenching, you are not going to hold anything, so you don't need vacuum. I have set the vacuum at 50 in this case. Flow rate is also not much required. It is needed only to clear the emulsified lens material. Power should be high enough to easily emulsify the cataract. See what happens while trenching. You are emulsifying the cataract and you are moving forward simultaneously. If power is not sufficient, you will push the nucleus and there will be zonule stretching.
You can see the power is 50 and aspiration is 20 in this case, and vacuum is only 50.
Now, during chopping the nucleus, you need a good grip. So, increase the vacuum, increase up to such a point that surge should not occur. Increase the flow rate so that the pieces will come towards the probe on itself. Set the power according to the grade of the nucleus. In my case, it is grade 3 nucleus and I have set the power at 40. It varies from machine to machine, whether it is longitudinal or torsional phaco. Set the power at such a level that nucleus will be easily emulsified. If you raise it higher than the required value, things will not be under your control and you will land up in endothelial damage and wound burn. You can also use the pulse and burst mode to reduce the heat produced into the eye. Now comes the last piece. There is nothing between the probe and the posterior capsule, but only a thin sheet of epinucleus. Be careful, otherwise you will rupture the PC. Bring down all the three parameters at medium level. Now a sheet of epinucleus is left. It is soft, so you set the power at minimum level. You can raise the flow rate so that you don't have to struggle to bring the sheet towards the probe. Set the vacuum at low level because you are not going to hold and chop the epinucleus.
To conclude, understanding the concepts behind the phacofluidic setting is instrumental in optimizing the parameters for increasing the efficiency and safety of your phaco technique. Thank you.
Thank you, Dr. Tripathi.
Thank you, sir.
Very nice presentation.
Thank you, sir.
Completed in time. Now come to the discussion part. I would like to ask few questions from our senior panelist. My first question goes to Dr. Rajiv Gupta from Gwalior. Which machine do you recommend to the beginners, basic or higher end, and why? Dr. Rajiv, please.
Hope I'm audible to everybody.
Yeah.
My recommendation to all the beginners is that first choose your budget. Because when you begin your practice, a lot of budget has to be spent on many things. And you are not even sure that how much practice you are going to gain in a year's time or two. So the budget constraint is always there. Choose your own budget and depending upon the budget itself. One. Second, if the suppliers can provide you the after sales services so nicely, because many high-end companies are not able to give you the after sales service. Third part is that if not merely the after sales service, but the valuation of the after sales services parts that is required. And fourth and the last, if you can really manage those machines efficiently, don't run after the high-end machines. So the basic level machines which you can buy in your budget, which you can maintain, which gives you the decent results, they are the best thing.
Right. Anyone wants to add something to this question? Dr. O.P. Agarwal?
It depends on the training of the person going for the starting practice. If those students are trained on higher end machines, they should prefer to go for higher end machine. But as Dr. Gupta said, for initial stages, the basic good machines is very, very important. Good machine, basic good machines.
Yes, agree with you.
Yeah.
Now my second question to Rajiv again, that do you plan your incision according to the astigmatism? Phaco incision.
Are you asking me?
Yeah.
Yes.
Oh,
Rajiv.
actually, yes, the right question. Normally plan the incision according to the axis of the steepest axis of the corneal astigmatism. But again, it depends upon the condition. If the patient's eye is sunken, low, which retroorbital fat is not very high, the eyeball size is smaller, then the most convenient side I choose, despite that the patient axis is on the different axis. I mean, the steepest axis on the other side, but I prefer the temporal incision.
Dr. Prerna, what is your opinion regarding the amount of astigmatism corrected by customizing your incision?
So definitely it helps a lot. Most of the surgeons are doing clear corneal temporal because it produces less astigmatism. 3.5 millimeter temporal incision produces around 0.37 diopters astigmatism as compared to superior, which produces about 0.6 diopters. So although I am not clear corneal temporal always, I always choose my incision according to the K reading, and I go on steeper meridian.
That is the right answer. Okay. Now, Dr. Ashok Singh is there from Sagar. No. Now, second question is how to maintain the leaky incisions. Mainly with the beginner, this is the problem, that all the time the incision is leaky. If you proceed with the phaco, there are so many complications. So, Dr. Arvind Bhatnagar, please answer this question.
Yes, sir. Good evening, everyone.
Good evening.
Good evening.
If the incision is leaky, how will you manage it?
If the incision is leaking,
Yeah. During phaco surgery, if
the incision is really leaking, its a leakage is pretty big. Means if you're talking about the main incision, the phaco incision,
main incision,
if it is leaking and there is a lot of surge, then I would preferably go to another site, close this incision, take a suture and do another site. Go to another site and do the operation from the other side.
Right.
In newer machines, there are now the options that we can have leakage, incision leakage factor, and the machine will give more fluid. And for small leakages, we can adjust through software also, like in Centurion.
Yes, sir, it compensates.
Yeah.
No, Dr. O.P. Agarwal, my question is that if the person is the beginner like me in phaco surgery, now if the incision is leaky, what are the primary parameters to prevent the leaky incision? Leaky incision, now he is having the basic machine, then what to do?
Yeah. Primary parameters are if the incision is larger, and we are using 2.2 millimeter incision and it is 2.8 or something, we can change our sleeve. There are different sleeves available. If we are doing with 2.2 and incision is leaking, we can change to 2.8 sleeves if it is available in OT. Usually we should keep it available in our OT. So that will compensate, and we can go ahead with 2.8 sleeves, even with 2.2 millimeter incision also, needle also. Number one, if it is leaking, we have to suture the incision and we can shift our primary incision.
Yes, that is the answer.
I would like to add one thing.
Yeah.
As I mentioned, we can always increase the aspiration flow rate, reduce the flow rate. We can always reduce the vacuum. We can reduce the parameters accordingly. That way, what would happen is the leak would be compensated to an extent. But obviously, if it's a huge leak, shift to a new incision. And that is what I mentioned. It's always more sensible, like what Rajiv, but Nagar said. But shift to a new incision.
Sir, may I ask one question? Actually, I have deliberately included that post-RK surgery case in this. I want to know others' opinion. Most of the surgeons suggest it's better to go scleral in post-RK surgery. So, what is the expert opinion of different surgeons? Whether it is right to go through corneal or scleral will be better.
Dr.
I prefer scleral.
I preferably slightly scleral, but in 30% of patients after RK, we should be prepared that we may need to suture the sections.
Okay, thank you, sir.
I also prefer scleral incision between two corneal incisions.
Yeah, that
is into the antechamber between two corneal incisions.
Okay. Dr. RK,
it all depends
can I
upon
add a
the
point?
number of incisions, particularly. If there are just 4 incisions, you can go safely with the clear corneal incision. There won't be any disruption of the linear cuts of the RK surgery. But anyway, if the size of incision is, I would say, equal to the space between the 2 incisions, it's always advisable to go with the scleral incision. Even I will say you can go 2 millimeter behind the limbus and do the routine phaco that we started in the beginning and how we learned the phaco with the scleral incision.
Yeah.
Yes.
I would like to add a point specifically in that situation where you have suggested that the wound was leaking and the surgeon is a beginner. I'll definitely suggest not to go further doing the same surgery from the same wound, as it may result into the catastrophe results. Better you convert, or better you go for the another incision. I will not suggest to unnecessarily go further.
Yes.
One question to Dr. Rakesh. What is your preference of the IA? Whether you would like to go for all the time coaxial or bimanual? Dr. Rakesh.
Yes, sir.
What is your preference of IA? Coaxial or bimanual?
Yeah, I always actually use the bimanual because it is very safe, actually safe technique. To cut for the beginners, you can use the you can remove the cortex all around. So there is nothing the subincisional cortex, because in the coaxial you can always use the bend tip or some 45 or 90-degree tip to remove the cortex. But for the beginner point of view, sometimes sometimes you hold the capsule or capsule margin in this type of situation.
Dr. Praveen, your opinion?
I always use bimanual. I also use bimanual.
I always use coaxial because it is very fast and there is no need of preparing the side port incision.
For beginners, sir, bimanual is good. For you, at your level, you can do.
I think coaxial is always better than the bimanual.
But what I have seen that for beginner also, if you train them properly, it is better. I have seen that for beginner also, the chances of PCR is more with bimanual rather than coaxial. PCR is more with bimanual. So
I feel bimanual is very safe.
Yes, sir. I also feel the same. I always taught my
Because
juniors.
I'm well versed with both the techniques. I used to operate with coaxial also.
We all learned with the coaxial. At that time, we don't have bimanual. Bimanual comes after 10 years.
Yes, sir.
Later on.
Nijlani, what is your opinion?
See, it is all up to you basically how you start learning. The basic idea is this: the anterior chamber has to remain stable. That is the thing more important rather than I would say. But yes, I would say biomanual gives you a better maneuverability to take out the 12 o'clock cortical material. I use basically both. When I started with coaxial and then in a difficult situation, I use biomanual. Otherwise, in routine, coaxial is all enough. With the curved tip and all those things takes away all the cortical material from all the corners of the bag. Can we have a quick comments from Dr. P.S. Bindra? They are with us. He's with us. Dr.
Yes, sir.
P.S.
But microphaco is, this bimanual is good for the microphaco.
Now I have one question for Dr. Bindra, sir.
Hello. Yes, Rajan.
Good evening.
Good evening.
What precautions will you take while dealing with the last piece of the nucleus, sir, in the phaco?
See, the large piece of the phaco is to be taken with the high vacuum. If the PCR is there, then we should put the visco from the side port, and we should not take out the phaco probe till we put the visco from the side port.
Yes.
And it is better to give visco support, and better to give viscote is the better choice to separate the two, push the posterior capsule back and take out the hard piece of the nucleus safely.
Anybody anything else wants to add in this last piece?
For the last piece of nuclear fragments, we definitely should reduce our settings. If vacuum is 450, 500 or 600, which nowadays for hard cataract, we are using 600 vacuum. We just get slow down. We should not do it very fast. With the newer generation machines, we can definitely do very fast cataract surgeries with even grade 4, grade 5, grade 6 cataracts. But definitely with last piece, we should be very cautious. We should reduce our parameters. We should reduce aspiration flow rate as well as vacuum both.
The more precaution is to be taken those who are using the machine with the venturi pump.
Yeah.
And we should bring the last piece to the pupillary plane. We should not go deep down, bring the piece in the middle and then take it out.
See, all the higher end machines, they are having the better foilability. So the last piece automatically come in the center. And it is the OP, Dr. OP said rightly, that we should slow down our parameters and we have to be very slow. We should not be speedy as we are doing earlier. We have to be very slow and very cautious about it. Because sometimes the edges of the last piece, this can dent and this can chatter and damage the posterior capsule.
My one more question to Dr. Pawan Sthapak. Suppose you are implanting the IOL and suddenly the IOL is stuck into the cartridge. Half of the IOL is in the chamber and half in the cartridge. What will you do in that situation?
I think it depends the IOL. The proportion of the IOL is more into the anterior chamber or it is more into the cartridge. If it is more into the cartridge, just take it out and use another IOL. If it is more into the anterior chamber, then I push the plunger back and try to push it again. If you put 2-3 times, it goes into the anterior chamber. So,
because it is not going then?
If it is not going, then you have to remove it. Yes. Then you have to remove and take another IOL.
If you don't have that IOL power in your OT, suppose you are having only one IOL of that.
Then I take out the cartridge from the injector and open the cartridge again. Try to take out the IOL and put it to the VSS, and then again I have to put it into the
Actually, I had a situation in my OT one time. What I did, one of the leading haptic was in the anterior chamber, half of the optic is in the anterior chamber, and remaining was in the cartridge. So I took the BP knife and I cut the cartridge there only.
Yes, sir. Yes,
Then
sir.
the lens is released, and then I put the same lens into.
Sir, most of the
So
surgeons
if you push the cartridge again and again, then definitely it will come out with the rubber, that silicone.
Don't happen. It don't happen, sir. It don't happen. Sometimes it stucks up at the cartridge itself. That what Dr. R.K. Gupta has told. You incise the cartridge tip with the blade.
With the blade.
I have done few times. Yes.
Or even if it's not possible, pull out the lens from the wound itself, or you can cut the lens itself and take out in pieces.
Fine.
Then implant it again.
If one haptic is broken, the leading one in the anti-chamber, then what you will do?
We can take it out.
Take out the haptic.
We can take out the haptic by.
It also depends. There are two haptics. If I mean to say, one piece of the haptic has gone, the terminal piece, then you can leave the IOL. It doesn't cause any problem. It will be there. And if it is broken completely, then you have to cut it and remove it. That is the option.
If lens is not available in your OT, then?
When you leave that and put the PMMA IOL if that is available.
Yeah.
So put 0.5 diopter higher, make it a little bit
A few times I have done one more thing. I make the notch in the IOL and fix it with the capsulorhexis. If your capsulorhexis is very good, circular, then
Dr. O.P. Agarwal, what to do in such situation?
it may come in.
I have manufactured the IOL inside the anterior chamber. One of the leading haptic was disengaged with multi-piece IOL from Elcon. So what I did, I just inserted that haptic into the optic and implanted the lens.
But if it is single
piece lens,
single piece IOL, then what you will do?
Then we have to cut it in two pieces and remove, and the implant only 0.5 diopter plus minus will be available. There are very rare chance that we will not have the IOL. Only in cases of toric IOLs or multifocal IOLs, there are chances that you are not having the same diopter of lens available. But otherwise, for monofocal IOLs, we are having all diopters available.
And what are the comments of Dr. Bindra, sir?
See, if that, in most of the cases, only the trailing haptic get broken, not the leading one.
Yes.
And if the trailing haptic is broken from the 2/3 of its total size, then and the rhexis is proper and central, we can leave the IOL in the bag. It will be placed nicely, and it won't give any surprises or complication afterwards. But if it is broken from the optic haptic junction, then we have to take it out. Otherwise, it will be decentered.
Okay, sir.
What are the early signs of there is a PCR during hydrodissection? And this question I would like to ask to Dr. Pradeep Vyas sir from Ujjain. Pradeep sir.
Unmute. Unmute करो.
प्रदीप सर अनम्यूट करो.
हमें दर्शक दीर्घामी रहने दो.
हम नहीं बताएंगे. So I would like to ask this question to Dr. Praveen Khare. That what are the early signs of PCR if it happens during hydrodissection, and how will you manage the case?
Sir, if it happens during hydrodissection, it's usually a case, most of the time it's in posterior polar cataract. So in those cases, when we do the hydrodissection, if there is a red glow, we will not see the wave properly going on the other side. And secondly, there will be sudden deepening of anterior chamber followed by shallowing of anterior chamber. And third thing, I think while rotating the nucleus, you will feel some hindrance while rotation. So these are the points which will suggest that probably there is a PCR during hydrodissection. And as it's the earliest procedure, earliest step of phacoemulsification. And for personally, I will say that as we do not know the extent of PCR at this point of time, so I will suggest that we should convert the case into SICS. That will be a safer option if it's at the level of hydrodissection itself.
And suppose during the nucleus management, half of the nucleus is phacoemulsified and half of the remaining, and it is a hard cataract. And suppose you find there is a big rand, then what will be your strategy?
Sir, if there is a big rent and if it's about half of the nucleus is still left, the possibility is either we can slightly enlarge the your corneal wound or limbal wound, whatever you are doing that, and we can remove the nucleus in pieces through the other means like height visco expression, or if you are using fish hook, then we can take out with fish hook itself. Or if it's a small PCR, then we can do the sliding, this protection by putting an IOL after doing all the vitrectomy into the sulcus or in the bag, and after that we can do the phacoemulsification. So whatever you are comfortable with. Or if you are not comfortable with this, then we can always convert it into a size.
What about the IOL scaffold technique in such situation?
Yeah, so this IOL scaffold technique that I was talking about. That if it is so, then after doing vitrectomy, we can place the IOL first into the sulcus or in the bag, whatever is comfortable, and after that we can safely do the phacoemulsification. But again, if it's a larger and harder nucleus and we have to do everything into the anterior chamber, that will be a problem for corneal endothelium. So again, we have to find out that what is the safer method, and if we are not comfortable, we can convert it into a size.
Dr. Lalit sir, what precautions will you take for posterior polar cataracts during phacoemulsification in relation with hydrodelineation?
We have to be very careful when we do the hydrodelineation, and the vacuum and power has to be maintained very nicely. Otherwise, the chances of PCR will be there. So we have to be very careful.
Bindra sir, what is your opinion?
Rajan, posterior polar capsule, first you have to make up your mind before taking the case that you have, every step you have to take precaution. See, starting from the hydrodelineation, we have to see the wave, and we should go for the, we have to observe the wave whether it is separating the posterior polar cataract or not. Number two, if there is a sudden red glow is visible, then you have to be more cautious. Third thing, you have to maintain your anterior chamber very nicely to be filled with the visco all the time. Fourth thing is, for the posterior polar cataract, you have to remove the cortical removal should be done from all over. You have to remove the central part in the last. So if at all there is a chance of posterior capsule rupture is there, we can maintain it, we can do it. And we first try to remove the 6 o'clock, 12 o'clock position, cortical matter, then the 6 o'clock.
Sir, I would like to add one point. Plan CCC also is small, 5 millimeter, because
CCC,
at the end, if you
if at all we have to put in the sulcus, then we can think of it.
Can I add a point?
Yeah.
Can I add a point? In those cases which we are very sure that the patient is having posterior polar cataract, I would suggest don't hydrodissect the case. Don't hydrodissect. Go for smaller hydrodelineation, smaller in all the quadrants first. Or second thing, don't hydrodelinate even. Do the direct phacoemulsification. You take out the center part and then you can aspirate it out. That would be much safer.
And rotation is also not required.
Technique.
One thing more. We should avoid rotating the nucleus as in other cases we are doing.
Yes.
One more technique I have learned from Dr. Vasavda.
Inside out delineation.
Make one trench in the center, and from that trench you do the hydrodelineation. That is very safe. Now the last question, because it is already 4:30, goes to Dr. Sushil Tripathi. That what are the basic tips you want to give for anterior vitrectomy to the beginners?
Yes, sir.
Tips of anterior vitrectomy to the beginners.
Yes, sir. Sir, yes. Whenever there is rent, first of all, don't pull anything inside the eyes. Don't pull the vitreous. Don't aspirate anything. And first of all, the first step should be the put visco and do anterior vitrectomy. Okay.
Right. Dr. Shukla?
Yes, sir.
Rahul Shukla?
So first would be making sure you keep the probe inside. From the side port, you can always inject a heavy OVD. Viscoat is preferred, and gradually pull the probe out. Make sure that if the vitreous tag is attached to the probe, you can cut it with the scissors. Inject Transilone because it is the best way to recognize the amount of vitreous which is there, and then plan your vitrectomy depending on the pieces which you have. If you have more pieces in the anterior chamber and the vitreous has come, then definitely it's better to shift to an SICS, take out all the pieces, do a vitrectomy and put in a 6.5 IL, or if you have the, adequate bag available, you can always do an optic capture. For the vitrectomy, it's better to do a vitrectomy with low vacuum. The cut rate should be high. The vacuum should be low so that you don't need to pull it out. So the vitreous would come out if the vacuum is very high. And finally, when you have done everything and you put in the IOL, do put Transilone again. Make sure that there's no residual vitreous which is left. Why? Because these wicks really lead to glaucoma, secondary glaucoma, and by any chance, if the endothelium is, if it touches the endothelium, it leads to corneal decompensation.
Sir, in higher-end machine, there are two modes. IA cut
and cut IA.
Cut. So
yeah.
It also depends at what stage rent has happened.
Yes, ma'am.
So that is all from my side. Thank you very much, everyone.
Thank you, sir.
Chelani, please.
Thank you, Dr. Rajan Gupta sir and session officials for taking an active participation in this session of cataract.
Okay.
Yes, sir.
मैं तो थोड़ा बोलना चाहूँगा.
Please, sir.
First, congratulations for this nice piece, and special mention of Prerna because I've seen this girl as a house surgeon to now chief of that institution, and moreover, हम तो भाई ICC के जमाने के लोग थे. It was you whom I saw. You were performing IOL, and it was your motivation who made me an IOL surgeon. You and Prerna. So thank you, both of you. And then, of course, at the age of 60, I learned phaco surgery also at Chitrakoot. क्योंकि ऊपर जाके भगवान को जवाब देना था कि फेको आता है कि नहीं आता है. And thank to Rakesh. Rakesh was my teacher that time.
Yes,
and Rakesh, I think you are not disappointed. You were not disappointed with my working. Rakesh, any comment?
No, sir, you are the rock, sir. No problem.
भाई 60 साल की उम्र में फेको सीख के आया भाई मैं तो.
That is very creditable.
सर मेरे साथ पीजी किया था वो भी बता दीजिए सर.
अभी रेटिना और सीख लो.
सर मेरे
पड़ेगा क्यों तू बिगाड़ रहा है ना उनको.
सर व्यास सर तो मेरे साथ पीजी के टाइम पे थे सर. हमने जब पीजी कर रहा था सर.
There is no age of learning. We keep learning, I will say, with the age. So it's always.
But you, I'm really thankful to you.
Now I would just like to add one more thing. If you've given a permission, I would like to add one thing. सारे webinars बहुत अच्छे होते हैं. There are good talks and all. But I think the take-home message, one more message I want to just make sure that the audience takes home. At 60 years, if somebody can learn phaco, new beginners, जो 25 साल के 30 साल के बंदे हैं, वो बहुत अच्छा और सीख सकते हैं. They've got good reflexes. तो डरना जरूरी नहीं है, हिम्मत होनी चाहिए. And kudos to Vyas sir. आपके कारण ना एक inspiration चला जाता है कि when in your age, when you have learned phaco, obviously others can. This is the biggest take-home message, and all the seniors are very important. That is the reason we need feedback from our seniors. Their opinion matters, and how have they modified themselves? The youngsters can always take a leap from that. Thank you so much. It was a pleasure, sir.
Yes,
I also want to add one thing. I also want to add one thing. Can I say? I have also learned the same thing which Dr. Pradeep Vyas is saying, to learn at the age of 60. I have seen my uncle, Dr. Gokul Das ji. He learned IOL at the age of 60 when it was just started. In 1990, he purchased microscope and started doing IOL surgeries at that time at the age of 60 years. So this is very nice to learn at that age, and I got a lot of courage from him that if he can learn IOL Why not me? So
Yes,
this
yes,
is
Dr.
something very
Nichlani,
good.
this is how I say
Dr. Nichlani, Dr.
Yes, sir.
Nichlani, see, it is always said that every doctor is practicing till death. So practicing means
true.
nobody is perfect on this earth,
That's
and
why called
everyone is
practitioner.
student.
Fine.
Yes,
So,
sir.
But I think
learning
webinars
is
like this
going,
are an inspiration
we
to the
must
juniors,
keep
sir.
keep learning, and
Yes.
get an inspiration from the elders and the seniors, how they started learning. So it's a great message for the PGs and the young generation ophthalmologists that learning has no age. Just keep on doing dedicated work, and you will come to a great and good end with a great success. Just one 30 seconds announcement from my side, because being a chairman scientific committee, the abstract and the other video and poster and faculty talks is all open up till 15th of July. Today is 11th, so hardly 4 days are left. I would request all the ophthalmologists of MPSOS do participate actively. It's all on the digital platform. The website already has been being repeated on WhatsApp and email. So kindly just go there. Try to, incorporate more of your scientific work the way you want, whether it is a paper, poster, or scientific talk. It is all open. Even the scientific talk, this time we have opened it up so that all the ophthalmologists who are doing any specific work of their choice, they can participate in a scientific talk as well. So that was a message from my side. Before I hand over mic to Manav Setia, I just would like to say one thing more, that certificates of everyone we have participated, whether it was a faculty talk, chairperson, or moderator, is all ready with Dr. Manav Setia. He has taken a great care of preparing the certificates. Those will be handed over either at the time of annual conference, or maybe mailed up, or can be downloaded from the site itself. So before Dr. Manav Setia say a word of thanks, may I invite the Vice Chairman of Antod Group, Mr. Raman. He has to say something.
Yeah, thank you so much, Doctor. And good evening to all, Doctor, and MPSOS Executive Member, Doctor. This midterm MPSOS Conference 2021 is supported by Antod Pharmaceuticals. As I would like to share my screen. Hope it is clearly visible to all of you. As you may be aware about, today Antod is India's fastest growing super specialty pharma company as per the recent data of IQVIA 2021 April. Also today, Antod has over the 170 ophthalmic and ENT products portfolio. We do have it. And today is a great day for Antod Pharmaceutical. Today, entire Antod family and medical fraternity is celebrating the 44th Foundation Day. That is the 11th July 2021 of the Antod Pharmaceutical. Antod founder, the late G.V. Masurkar sir, that is the 98th birthday celebrations as Antod Foundation Day. So to the helpesh, the people that we are doing a lot of things on the occasion of this. So man, those who brings the word to India in ophthalmology, ENT, and nowadays dermatology, and puts it onto a global map. Here, I would like to take an opportunity to show a Antod corporate video. So this is very nice line he has mentioned. I opened the two gifts this morning. They were my eyes, and he was nothing other than the Mr. G.V. Masurkar, the foundation and the mentor of Antod Pharmaceuticals. Just a glimpse about the today's all sessions major product which has been correlated with all the sessions. we have Moradexa, dexamethasone sodium phosphate, pre-operative and LASIK surgery. It's a clear solution. The second session that we had on the glaucoma, we have the preservative-free range of the product. AB press that assured us sterility for the 60 days after the opening. And the last sessions on the Lockyer fusions, that is also our tear substitute. And recently we got the DCJ approval for Rocket Plus. And this is one 30-second video. So this is the recently that we have introduced the high-tech division with all the ophthalmic surgical needs products, which has the complete basket. And these are the supportive services that we have. Currently, we are here for the Entomate, that is the webinar series, as well as the OT staff training, and I said for the field reminder. There are many more the educational support system that currently Entod having. Thank you so much, Doctor, for making the Entod as the fastest growing ophthalmic and ENT company. Over to I think Manu sir for word of thanks. Thank you so much, especially for Vijay Cheslan sir and entire the MPSOS executive member. Thank you.
Yeah. Congratulations, Minister sir, and member of the scientific team, and the speaker, Dr. Rahul, Dr. Punendu, and all, Dr. Prerna, sir. Very nice. Heartiest congratulations, sir.
Thank you, sir. Thank you, sir. So, to formally thank everyone, may I invite Dr. Manav Sethia to continue the session with vote of thanks.
Yeah. Thank you, sir. With this, I would like to convey my sincere thanks to Chairman Scientific Committee, Dr. V.K. Nishnali, sir, Honorary Secretary of Madhya Pradesh Ophthalmic Society, Dr. Gajen Chawla, sir, President MPSOS, Dr. Hitesh Agarwal, sir, President Gwalior Divisional Ophthalmic Society, Dr. Rajiv Gupta, sir, for their kind and timely support. My thanks to all speakers, chairpersons, and panelists and moderators of Retina session, Glaucoma session, Biometry and IOL power calculation, and cataract sessions. My sincere thanks to all attendees for their active participation in making this scientific session a success. And lastly, Team Entod for their support in flawless conduct of this scientific session. Also looking forward to a shift soon from the virtual to a more physical meet in the distant future. Thank you once again. Thank you.
Thanks everyone from Scientific Committee and MPSOS Executive Committee, to all the delegates, to all the speakers, to all the session officials. And we promise from MPSOS that we'll keep conducting these variety of scientific fees to all of the members. And get ready for the annual conference, 44th annual conference at Viva. Very soon, Dr. Gajen Chawla is going to have a discussion about it, and the things will be finalized within this week of time. Thank you. Thank you, everyone.
Thank you. Thank you. Thank you, Vijay. Thank you, Rajan bhai. Thank you, Chawla. Gajen. Thank you.
Gajen, are you? एक प्रश्न है कि क्या is it possible that we'll have a physical conference at Riva?
Thank you, Yogi bhai.
अगर मेरे से आप पूछोगे तो मैं तो मूड में हूँ सर, पर्सनली तो मेरी इच्छा है, अगर गवर्नमेंट ने परमिशन दे दी तो बिल्कुल करेंगे सर।
नहीं, because river people I talked with Shashi, they were probably they are not interested.
नहीं सर, करेंगे सर, करेंगे, बात करेंगे उनसे सर, बात करेंगे।
राजीव, you put on weight.
Yes, 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 हम तो अभी सर मूड में हूँ।
मोटा हो गया राजीव।
राजीव तो सर always smiling।
Directly proportional to his practice.
चलिए सर,
चलिए साहब, बहुत मजा आया।
चलो बहुत बहुत विजय, थैंक यू।
Thank you
राहुल,
Thank you,
विजू,
sir.
बहुत
Thank
बहुत
you,
बधाई।
Chawla sir. Thank you, Vyas sir and Rahul sir. Rahul sir.
Thank you Rakesh, thank you Niklani sir, thank you Rajiv sir, thank you
Thank you Rajan bhai, thank you Gajen, thank you Vijay bhai,
sir, bye bye bye
bye sir,
bye Rahul, bye Bhatnagar sir,
thank you Vyas sir, thank you
Parvez sir bye,
Thank you.
thank you।